Dr. Dinesh? कौन सा वाला है आपको? अच्छा तो इसको रिड्यूस करके ऐसे करते हैं ना? नाम कर देना है क्या? नहीं नहीं अच्छा ठीक थैंक यू सर यस थैंक यू वॉशरूम दो मिनट आशी स्टार्ट हो रहा है नहीं कवर हो रहा है ना उसमें हाँ हो रहा है तुम जितना हाँ तुम बोल एक साथ
Yes, sir.
A very good morning. A very good morning to all the seniors, delegates, faculties, and my dear students. It's a pleasure to welcome you all to Lucknow for Coagulation Update CME, followed by today's workshop. So, in this session, we have tried to accommodate all the good topics of coagulation from the eminent faculties, and I look forward for a fruitful day and an interactive session. So, without further much ado, I would like to hand over the mic to my junior resident, Dr. Soumya Agarwal, for further proceedings.
Thank, thank you, ma'am. Good morning, everyone. I would like to invite the chairpersons for the session 1 to on the dais, Dr. Savitri Singh, ma'am, Professor, Department of Pathology, PGICH, Noida. The second chairperson, Dr. Survi Gupta, ma'am, Senior Consultant and in charge, Hematopathology, Department of Lab Medicine, Max Super Speciality Hospital, Lucknow. On the dais, please, ma'am.
Good morning, everybody. So today's first talk is Dr. Dinesh Chandra. Doctor is additional professor, Department of Hematology, SGPGI, Lucknow. He has expertise in bleeding and thrombotic disorders, anemia, hemoglobinopathy, transplant biology. He has got awards and honors, International Society of Thrombosis and Hemostasis, ISHB, the award, fellowship, 2020 year, publications 35. So over to you, Dr. Dinesh, for your talk, please.
Thank you, Chairperson, and good morning to everyone. So I would like to thank first of all Rashmi ma'am and the organizing team to invite me here and to give my some viewpoint on this very important topic, how to set up a coagulation lab. So this is the one topic which nobody teaches, and when we are junior resident or senior resident, and even the junior faculty, then still we have no idea about it. So because we like as we as a faculty, we never involved our resident to get in all these process to procurement and how what is the minor things which we have to play. So I think it is like the picture on the top, something like this. Somebody is making a house. So I think the best example is a housewife in the home who is know everything when she set up a kitchen. So she know where I have to put cutlery, where I have to things, it, how much I have to buy in future, where I have to kept. So same thing we have to apply when we planning to set up a coagulation lab. So before starting my talk, I'm having privilege and honor to be work with all these people who are the legend in the field of coagulation, and I learn a lot. And the lower one is more important to me. Mr. Surinder Singh from CMC Vellore, then Mr. Suresh from PJ Chandigarh, Sri Boss from PJ Chandigarh, and Mr. Suresh from IMS New Delhi. And I have privilege to work with these people. These are the really legend. I can say they have more than 40 and 50 years experience in working in coagulation lab as a technical staff, and they are too good. So I have learned from all these people, and with their permission, so these whatever I'm going to present over here and which I have learned from these people, these idea are from them. So I take their permission to share these ideas with all of you. So before set up a lab, we have to think about something like the lab which we are going to establish, is it in government institute, and what type institute it is a medical college, it is some district hospital, or it is a referral institute, or we are going to set up a corporate lab, or it is a stand-alone lab. So in a stand-alone lab, whether we are going to only coagulation lab or along with hematology and biochemistry lab. So these all things we have to keep in mind. Then the most important thing, which tests I should start first. So what my clinician wants, those tests, most important, those should be my priority. And another, the major thing is budget. How much money I have in my pocket. Then from where I am going to get the samples is from the my hospital only, or it is a referral center. So we are getting the sample from other hospitals and centers also, or these how many samples we are going to get in a week or every day, and what type of samples we are going, and do I know what are the permissions and paperwork I need to complete before I start the lab, and later on the registration and accreditation. So if I'm in going to get a my standalone lab or a corporate lab, then I have to have major budget to be spent first year in the either in the procurement or rental of that lab area. Then next thing is the equipment, then reagent and salary of the persons. But the same thing will change next year because we have already buy the equipment and area all the things in the first year. So second year it is going to be the major expenses on the reagent and the salary of the staff and the maintenance of the equipment. And if you are in a private sectors or you are in a standalone lab, then you have to spend a lot of money on your marketing and advertisement also. So that are the small things, but we have to keep in our mind. So if I have a space, so how I should utilize that space the best? So as I told, are we going to only establish the coagulation lab, or along with coagulation we are going to start with hematology and biochemistry lab also? So according to that, and what how many samples I am going to get per day and per week. So according to that, I have to place my instrument number of instrument on that. And when we deciding about the area to divide, so we divide upon the floor area and bench area. Bench area where we put the instrument and when we perform the assays and all those things. So always bench area, it is preferable that we separate the analyzers from the other like centrifuge and separating all those things because they should not disturb the laboratory areas. And the important thing, all the analyzers, majority of them have optical system for detection. So they should be in dust-free area. So if I had to design my dream lab, because most of the government sector, we are not the choosers, we are the one who has get something, and now we have to become that place as our dream lab. So suppose if I am too much fortunate and I got my opportunity to plan my own lab, so how I should go for it. So I will plan like this. If this is the area I'm going to, so I will divide like this is if this is my interest. So the patient will come, they have to place somewhere and sitting. So that is the waiting area for the patient. And if we are going to establish the other things like, so they need some type urine sample, some they are waiting for, so they need go to toilet and other things. So it should be attached to that place only. Then next to that is better you have a collection area. And in collection area, you should always keep a recliner chair, which you have seen majority in time of blood bank and all this. So some patients, they are very sensitive, they get fainted and all those, so you can manage all those things. And next to your collection area, there should be area where you can separate the samples. And after this, I will plan my area where I can put all my instrument. So I divide it. If I have two or three type of the things like biochemistry, hematology analyzer, and coagulation, so I will divide my areas according to that. And in this area, I can make some area where I can put the centrifuge separately because they produce lot of vibration, so they should be kept away from that. And the area should be demarcated for particular test. So, and there should be enough moving area for the person who are working. So accordingly, we have to divide how much, what instrument we are going to buy, and according to that, we can what is should be the weight, and along with this instrument, there should be a computer and monitor. So along that should be decide and design that area. Then only we should buy and keep all those things. So before planning this, we have to already have an idea what we are going to purchase and how many things we are going to purchase. And next to that, we should have a storage room where we can keep our deep freezer reagents and all those lab refrigerants and sterilization area if we need. But I think this is the most important area which nobody or very less labs keep it is the pantry for staff. Because I can tell you this cost you a lot. If they don't have area to eat, they will eat in the lab. We have an incidence when we have buy fully that high-end hematology analyzers, and due to the some delay, it has kept in the corridor for next 3 4 months, and after 4 months we have opened, then the lot of the wire and something motherboard board they have cut, the reds have cut something. When we call the company person, they say it need 20 lakhs rupees to replace all these things. Similarly, happened to our fax area. Now it is 2 crores machine which has been kept. The Reds has kept one of the nozzle and one. Now it is 15-year-old, so we are not getting all those things. So that is what you are going to cost if you don't put all those things, and there should be a fire exit and all those things. So if I have made to my room, because somebody who is had to look after the manager or the faculty, they should make some room somewhere between the lab and this area where you can sit calmly, nobody will come directly and contact them, so they can do their work properly. So next part is what test I should start first. So as I say, you should have to very good communication with your physicians, with your hospital persons, what they want the first priority in there. So we cannot start all the 100 tests at a one time. So we will go for 10, 20, and then next move on as per the requirement and the budget will allow. So if I have to set up, then I will prefer to start with my screening test, PT, AP3, fibrogen, D dimers, and mixing studies. Later on, I can start with factor assay, born disease, and platelet function test. Once I have them, then we have other departments, so we can cater with them. Now, because you also need a confidence, yes, I can manage this, so I should move further. So not directly I am jumping on a Vichista assay without establishing that I am good enough doing factor assay. So next we can do for the thrombotic workup. And if now I am a referral lab and we have samples from other the hospitals and not the patient are referred to us, then we cannot say, oh no, this is test is costly, so we cannot do it. So we have to kept that thing. I know it is in loss, but we have to do that thing also. So now we have planning. Yes, we have to start a lab. We know how much money we have. So which instrument I have to buy? So it is just like I have to go 20 kilometers. So I have the bike, this car, or this luxury car. So I know everybody wants the third one. But the things over here is if you have a budget, you should not spend all your budget. It is not one time. Okay, this budget is for one whole year or 2 years. So if you have suppose 50 lakhs rupees, so you cannot spend all 45 lakh rupees to buy an instrument. You have to maintain in all those 50 lakh rupees your reagent, your salary, everything. So if I don't have that much of load, I can start with semi-automated, or later on when I have sufficient amount of samples and I know I am going to get profit and no loss, then I can go for fully automated and so if I have to buy an instrument, which instrument I should choose? So as I told, it is very important what samples, what number of tests you are going to do, and which test you are going to do. So there is mainly all the instrument in coagulation lab is working either on electromechanical or photo optical methods. So they have both their advantage and disadvantage. So today's topic is not what is advantage and disadvantage, but we know our instrument very well because doesn't matter how rich my department is, it is not going to give me every 2 years to buy a new equipment. So I have an idea in next 5 or 10 years what are the tests I have to do. So is I am going to need only clot-based assay or I am going to need the chromogenic assays also or I need turbidimetric assay also. So I should choose according to my test whether this facility, this technology is available in my instrument or not. So accordingly I will choose. But choosing an instrument is depend one of the major thing who is the provider in that area because maybe one company is very good in south but he is not very good providing all the things in north and vice versa. So you have a good idea with your colleagues and the peer workers. What are the companies which are going to provide you a better service? Then is are going to give me a continuous support in case of breakdown and everything. So that is also very important which we don't think. The only thing about the instrument but not about the service also. So it is not only that you have buy a very good equipment, which equipment you have buy, you have to validate it. So performance assessment we have to, the company will come and do and show you, okay, this is the things, all the controls is passed, it is not enough. So you have to give them samples, so you have to check their accuracy and precision, and you have to run their own old samples or the controls and see whether they are working fine or not, and you have to find out what are your limit of detection and what is limit of quantification. So you can make that statement in your reports. Along with this, you have to buy other equipment like centrifuge. So for coagulation, it is best to use the swing out type of centrifuge and refrigerated. But whenever the comes word refrigeration, everybody thinks it is 4 degrees centigrade. It's not 4 degrees centigrade. It is ambient temperature between 22 to 24 degrees centigrade where we have to process all our coagulation samples. Then we need very important is pipettes. So sometimes some pipettes are very cheap, so we are not going to buy that. We have to see our budget and the pipettes which because they are one time and you are not going to replace them. So the calibration and quality should be good of these things, and definitely we need a very important equipment that is water worth. So we have to keep the sample, we have to store the samples, reagents. So we need a lab refrigerator where we can store around 4 to 8 degrees centigrade majority of the reagents. But some of the reagents and samples especially have to freeze at minus 20 or minus 40 or minus 80. If I have budget, then I will go for deep freezer. But if I don't have, then I have the options, the upper part of the freezer in that normal refrigerator. But I will never prefer to buy this frost-free refrigerator because they also defrost. But when they defrost, you never come to know. But I know this old one is like Baba Adam, there is lot of ice in that. Even the 24-hour electricity is not there, it will not going to melt. If it is melt, then you come to know whatever I have kept over here is gone. So that is the best one if you don't have budget for the deep freezer. Then very important, there is so many companies, so many reagents present in the market. So which reagent I should buy? So first thing, as I told, which has the uninterrupted surface, where you can see the consistency and the stability of these reagents. And most important thing, they should be compatible to your uh, analyzers. And especially in the fully automated analyzers, you can use other company, but it is better to use the same company reagent because otherwise we have to do lot of validation and other things which cost you a lot. And whenever you ask for the reason, you ask your vendor, whatever reason you are providing, you provide me for the one lot for at least 6 months because in population, everything depends upon our reference range. So reference range will take out whenever the lot change or any breakdown happens. So if your lot is changing every 2 months, you cannot ask 30, 40 people to give samples and do all the things. So lot of wastage of reagent as well as people will see and they run up. Okay, he's come to take my blood again. So it is okay for once in 6 months, but not every 2 months. So just an example, like PT, if we are choosing, we should have the ISI value near to 1. And if we are choosing the APTT reagent, then for routine workup, we should not choose the LA sensitive APTT reagent. We should LA insensitive APTT reagent. And there is lot of things when we start with the labs. These are maybe not matter to the labs which have lot of workload and lot of things, but where you have limited resources and you want to do lot of things, then you can prepare instead of buying commercial plasma, which costs 1 ml almost 1400 rupees, you can prepare in house. Okay, the same thing, exoplasma is serum and this with the variant sulfates and urea cross probability test. So these are simple reagent. If you buy once, you will get retired with this salt will not finish, and they give the wonderful results in your interpretation. So once you have the reagents and equipment, then you have, before starting and giving reports to the patient, you have to establish your reference range and cut off for majority of the test, especially for PT, APT, lupus. This is the common one where you have to. So you have to take at least 30 to 40 healthy person to take out the reference range, and then it should be done as I told with the new lot and the any major breakdown. So we are whatever we are doing, are we are doing good or not, is our instrument is working good or not, our reagent is fine or not, so that somewhere we should check, so that we can check with the internal quality control and we use the control. So it is recommended at least two level of control you should use, one is low or one is normal. And in some specific tests when you have high workload and your range is too much, so you can use third level of control also. And definitely we have to participate in external quality control. So because we know our control is good, we are doing good, but where we stand among all the labs, that we should also know. So that is more of checking of your accuracy, because what we are doing in internal quality control by running this control is we are checking the precisions. This thing we are very poor. So we don't document the things which happens good, we document, but what happens bad, we don't document and we put it under the carpet. So if some mistake we have made in the lab, then the test goes wrong. So what it seems is all the evidence from the lab has been eliminated. So nobody will tell this test has been done, and so we should not. We should always mention those things more importantly. So we should learn from that mistake and don't repeat again in the future, because it costs you a lot of wastage of reagent and lot of confusion. So once we know, okay, because of this we have this wrong test and wrong result. So the documentation is very important. And until unless you are not documented, you are not going to learn from it. And definitely we have to do the accreditation from this. Okay, so this is the one part, but I think the most important person in your lab is the technical staff. As always, Dr. Sukesh Nair says that the technical staff is the one who take care of your labs as your wife take care of your home. So he's second wife in your life. So you have very good harmony, and whom you are choosing should always be very important. So life can be heaven or hell, depend upon the person with whom you are working. So majority of the time, the lab director or manager is usually faculty. The supervisor is the senior technical person, and the other lab staff. We need a favorite sense stationary person. But the very important thing from the first day of the lab you are starting, you should designate, decide what is the duty of each person. And if that person is on leave, then who is going to take the responsibility of that person? Because especially in government sector, this has happened, this is not my work, I'm not going to do it. So if you have a written document that yes, it is your responsibility and you have to do it, then that person will do it. So this is a small thing but very important to work with. So what we should choose, so that person should at least have graduation in medical technology or diploma, and they should be trained in the lab which they should are going to, which they have basic knowledge and equipment and the reagents and how to store keep. And we should always involve these person to make, when we are making SOPs, logbook, stock register entries and everything, because you are not going to do every day, because you have other responsibility to do, other works to do. So these are the persons, so it is better to train them and you just help out them whenever they are. So that is very important, and it is always needed because we have to update ourselves. So our technical staff, our lab should also be upgraded with the continuous CMEs, trainings, programs. If you need, okay, this person we are going to start this thing, so we have to send those person for the following things. Yes, this person is not on board officially, but this is the one of the most important person who is going to run your lab actually, because suddenly nobody can exactly expect how much reagent I am going to need. Suddenly one day, because in government sector we see, if we send a purchase order today, it will come after 1.5 months or sometimes 2 months, because it has gone through so many processes. So for 2 months you cannot shut down that particular test. So they can provide you on the long basis, and if there is some breakdown or some shortage, or if something wrong goes on, they can come and support you immediately. So that's why you have to do a survey, which company, which provider is the better to give all those things in your areas. Just 5 minutes more. So other thing is the safety equipment. We have to think if something happen wrong, spill over, needle stick injury, so what I have to do. And when I listen to Jasmina Man talk, then I come to know, and I go through some document, I come to know so many permission I needed to start my lab before giving the reports. I think majority of us does not know ki so many permission, even it is applies to government sector also. So this is the some basic brainstorming which we have done for the World Federation of Hemophilia and its other organization, because they are the way to establish lot of other labs. So if the sample load is low, what is the test should be done, and if it is intermediate lab, what is the equipment should buy and what test they can perform, and if it is referral lab, what test should they do. So, to summarize, it is very important to assess yourself, your vendor, your physicians, your patients, what tests you are going to do, how much money I have, how I should best use it, and how I train my person, how I choose my staff, what permission I need, and never ever think that this is today I have to think. So you have to always think 10 years back. Today I have one equipment, but I have made the space like that. I don't have a space to put another equipment, so I have to think about next 10 years what I'm going to do. So accordingly, we have to plan. So this is my beautiful team from SCPJ, Dr. Ruchi, Dr. Kashyap, Dr. Rahman, and Manish. And these are the best person in my lab, Mr. Viswas, Mr. Meena, who are doing hard work. And I always acknowledge these people, the best one, who are taking care of my lab. Thank you very much.
Thank you, Dr. Dinesh, for your excellent talk. Explaining everything in detail, and especially you emphasize this thing. There should be some separate eating area, and why it should be, and then what all laws. Other than that, I would like to add, if there is no eating area in the lab itself, then one by one they will say, सर कुछ खाने को जाना है, अब टेस्ट लगा है तो हम क्या करें? Incubation का time over हो गया and he hasn't turned up, then it will reflect poorly on us.
Yes.
Very nicely you have elaborated all the points. Thank you.
So this is not all of mine. I guess I have listened to and discussed with the people which I told. So these are their ideas also, and I have put it in my presentations. Whatever we have discussed, and I have learned from these people. Thank you.
To listen to you.
Thank you, sir. Now I would like to request Dr. Savitri Singh ma'am to present a memento as a token of her appreciation to Dr. Dinesh Chandra sir.
Our next speaker is Dr. Namrata P. Awasthi. She is Professor, Department of Pathology, Dr. Ramanuja Institute of Medical Science, Lucknow. Her expertise is in hematology, non-hematological applications of flow cytometry. She is a recipient of 7 awards, both national and international, for her academic excellence. She has also won a Brian Howard Award for International Symposium on Technological Innovations in Lab Hematology, ISLH 2021. She has also won the TCS Award for Best Published Paper in Clinical Sciences in 2018, an award for Best Published Paper in Basic Science category at Research Showcase Foundation Day 2022 IMS Lucknow. She has 49 publications in international, that's 22 in international and 27 in national peer-reviewed PubMed and Scopus index studies. Over to you.
Thank you, ma'am. A very good morning to everyone, and a warm welcome to Pathology sir, ma'am, everybody here, my teachers, Jatir sir. And it is indeed a matter of great honor and pride to be standing here in front of the stalwarts of hemostasis. And I extend my gratitude to Dr. Rashmi Kushwaha and her team for having me here. So the topic given to me is from symptoms to solutions, evaluating bleeding disorders. And I've been given 20 minutes. And you understand that this topic can go on and on and on for the full day. So I'll just try to touch upon and emphasize on the main things. So let's start from this case history. So there's this 19-year-old female with a history of frequent nosebleeds requiring pressure and heavy menstrual bleeding lasting for 8 to 9 days with an additional history of easy fatigability. There is no significant bleeding history in the family. However, the mother also complains of heavy bleeding. The family physician suspects that there is a bleeding disorder and he orders the following. He orders certain tests, CBC and peripheral blood film, PTINR, APTT, fibrinogen. Fair enough, they have to be done. But this family physician happens to be sitting in Delhi, surrounded by very good labs, performing a lot of advanced coagulation testing. The funds are not an issue, so he thinks now let us do all the factors which I know of. So he also orders factors 12, 11, 9, 8, 5, 7, 5, 2, and so on, every factor. So the CBC results are out. Hemoglobin is 9, a microscopic hypochromic red cell indices, normal platelet, normal PT, normal fibrinogen, but an elevated PT, APTT. And the patient had developed microscopic hypochromic, that is iron deficiency anemia because of the menorrhagia. So now we have to think at this point of time that are all these tests which have been ordered necessary? And then, if not, how do we decide how to go about it? So let's see. So when we are talking of a case of a bleeding disorder, the symptoms are extremely important, and these symptoms will guide you to the solution. How? So these symptoms will give you a history, and history taking is an extremely important part in any workup for a bleeding disorder. Here, I wish to emphasize that as laboratory personnel, also as uh, hematopathologist or somebody doing coagulation testing, we should emphasize that the patient should be sent to the laboratory and we should assess on our own what is the history, what all tests are done, rather than simply depending on the clinical orders. Like do these tests. No, you should ask the patient to come. That obviously you'll have to collaborate that with your clinical counterparts and then assess the patient, decide on the screening tests and so on. So for a detailed history taking is extremely important, followed by the laboratory workup, which comes in two phases, the screening test and confirmatory test. So based on the screening test, you will then do the confirmatory test. So what all things are important in history? These 5 questions are extremely important. Whether the patient is a bleeder or not. Because many times, no, the severe bleeders, not a problem. They will bleed so much, you know that they are bleeders. But the patient with mild or moderate bleeding disorders like von Willebrand disease type 1 or mild or moderate hemophilia, you can have a problem in assessing whether the patient is actually a bleeder or there is just trivial bleeding. Then, whether the patient is a bleeder. Second question, whether the patient has a mild or a severe bleeding phenotype. Then, is the defect in primary or secondary hemostasis? Fourth question is whether the disorder is an inherited or an acquired disorder. And if it is an inherited disorder, what is the type of inheritance? So these are the 5 most important questions. So now how do we decide whether the patient is a bleeder or not? Earlier, these used to be very subjective. My experience, I might think that this is a mild bleeder, somebody might say, no, this is not a bleeder. So in 2010, IST SSC bleeding assessment tool was published in the Journal of Thrombosis and Hemostasis. And this gave us a lot of objectivation of how do we assess these patients. So what this BAT score or the bleeding assessment tool does, it takes into consideration 14 types of bleedings and then scores them from 0, 1, 2, 3 and 4. So these bleeding sites are epistaxis, cutaneous bleeds, bleeding from minor wounds, oral cavity, GI bleeding, tooth extraction, surgery, menorrhagia, postpartum hemorrhage, muscle hematomas, hemarthrosis, CNS bleeding and other bleedings. For example, how do we score them? If we consider a patient with epistaxis, so if that patient has more than 5 episodes of epistaxis in a year, or the epistaxis episode lasts for more than 10 minutes, it is given a score of 1. If the patient needed consultation and some investigations were ordered, this is score 2. However, if an active intervention was required in the form of cauterization or packing or antifibrinolytic therapy, it becomes a score 3. And if blood transfusion or replacement therapy was required, it becomes a score 4. Okay. Similarly, there are scoring for every kind of bleeding. Let's take menorrhagia as well because our patient had menorrhagia. So if the patient had to do only consultation or there was history of changing pads more frequently than every 2 hours or there was clot and flooding or a pictorial bleeding assessment score was more than 100, this is a score of 1. If the patient had to take time off from work or school for more than 2 times in a year, or the patient required antifibrinolytics or hormonal therapy or iron therapy, it becomes a score 2. However, if the patient required a combination of treatment or the bleeding history was present since menarche and for more than 12 months, it becomes a score 3. So probably our patient had a score 3 here. And similarly for the epistaxis also, when the patient was asked again and again, that patient complained of one episode where she needed packing. So that also becomes a score 3. So a bleeding score of 6. So this BAT score is good for inherited bleeding disorders. It is not aimed at working on the acquired bleeding disorders. So now we have assessed whether the patient is a bleeder or not. Now and these are the normal reference ranges for the BAT score. For adult males it is 0 to 3. For adult females it is 0 to 5. And for children aged less than 8 years it is 0 to 2. High bleeding score is associated with the presence of an inherited bleeding disorder. However, any patient is a severe bleeder if there are spontaneous bleeding episodes, there are history of hospital visits, if transfusions were required, and the extent and quantity of bleeding was highly significant. Now, for mild and moderate bleeding disorders, as I said, they pose a challenge. So this document guideline consensus-based document was published in 2019 by the European Hematology Association, and it gives a guidance as to what a mild bleeding disorder looks like and what a moderate bleeding disorder looks like. So in a mild bleeding phenotype, the patient may have more or less frequent mild bleeding symptoms that may be perceived as alarming by the patient, but they are not life-threatening or organ-threatening, and they may appear later in life. The bleeding may be spontaneous, but usually it is provoked by hemostatic challenges like menstruation or dental extraction or a surgery or trauma. And the individual bleeding episode do not exceed a score of 2. Mostly it was for consultation only. Now, for a moderate bleeding phenotype, this individual scoring does not exceed more than 3 BAT score. So this is how you can objectively assess whether this patient is a mild moderate bleeder or a severe bleeder. So now 2 questions sorted. Coming to the third and fourth questions, whether the defect is primary or a secondary hemostatic defect, and whether the disorder is inherited or acquired. So we all know whenever there is a vascular injury, first there is vessel wall constriction, then platelets are activated, platelet plug is formed after platelet aggregation, and this is the primary hemostasis. Now, simultaneously tissue factor is released, coagulation cascade is activated, a fibrin clot is formed, and a stable hemostatic plug is formed. This is the secondary hemostasis. So the disorders of bleeding can be related to primary hemostasis or secondary hemostasis. So the primary hemostatic defects are platelet function defects, von Willebrand disease, and congenital thrombocytopenia. For secondary defects are well-known hemophilias A and B and other factor deficiencies. Then there are a battery of acquired bleeding disorders, liver disease, vitamin K deficiency, oral anticoagulant therapy, heparin overdose, DIC, bone marrow disorders, and immune thrombocytopenias. So what are the differences in the presentation in an inherited or an acquired bleeding disorder? So onset in inherited disorders is infancy and childhood, whereas acquired may appear in later ages. There may be a positive family history in inherited, it will not always be present, but the family history of bleeding is definitely absent in acquired bleeding disorders. Bleeding manifestations usually are more severe in inherited and less severe in acquired. And there is lab evidence of a single or an isolated abnormality in inherited, whereas in acquired, you will see there are multiple hemostatic defects coming up. So this helps us in deciding whether it is an inherited or an acquired disorder. On the fourth question, how do we assess the inheritance pattern? So in reference to the coagulation or bleeding disorders, we have to think about 3 kinds of inheritance patterns: X-linked recessive, autosomal dominant, and autosomal recessive. So in autosomal dominant disorder like type 1 von Willebrand disease or a 2A or a 2B type, each affected person usually has an affected parent, and the disorder occurs in every generation. So there will be a history in the parents. Then comes the autosomal recessive type, in which Both parents of an affected person are carriers, and the disease is not typically seen in every generation, although siblings may have the disease. So most of the clotting factor deficiencies like factor 1, 2, 5, 7, 10, 11, factor 13 deficiencies, Bernard-Soulier, Glanzmann, and type 3 von Willebrand disease are autosomal recessive. Now coming to X-linked recessive, which are well known for hemophilia A and B, the males are frequently affected, and affected males often present in each generation. There is a history on the maternal side of males. So this is still the inheritance. Now, when we usually talk of site of bleeding in bleeding disorders. So site of bleed can be either surface or deep bleeds. Deep bleed means bleeding into muscle and joints, and surface bleeds are mucosal or superficial cutaneous. So epistaxis, gum bleeding, urinary tract bleeding, GI bleeding, menorrhagia, these all are mucosal bleeds, and they are not like menorrhagia and all, they are not deep bleeds. And then superficial cutaneous bleeds in the form of petechia, purpura, small superficial hematomas, and easy bruising. They are all considered surface bleeds. So when we contrast the primary hemostatic disorders or secondary hemostatic disorders, the site of bleeding in primary ones are skin and mucous membrane or surface bleeds, whereas in secondary hemostatic disorders, it is deep bleed. Petechias are a feature of primary disorders. Ecchymosis, if present, are small and superficial in primary, whereas they are large and deep in secondary. Bleeding after cuts and scratches is a feature of primary disorder. Bleeding after trauma is usually mild and immediate if the disorder is of primary origin, whereas it is delayed and often severe in a secondary defect. And joint bleeds are a feature of secondary hemostatic disorder. So primary disorders are primarily platelet defects, and secondary are the coagulation disorders. Umbilical stump bleeding, large hematomas, and delayed wound healing, they are features of fibrinogen deficiency and factor 13 deficiency. So if this kind of disorder is present, you should specifically think of these two things. Late bleeding episodes are features are associated with fibrin formation defects or defects of the fibrinolysis pathway. Then one should be aware of the rare bleeding disorders as well. They are actually rare, but one should be aware of these because sometimes in certain disorders, the clinical phenotype and the severity of defect do not correlate well. That means the deficiency might be severe, but the patient might be presenting as a mild or a moderate bleeder. So it is good to know this. And these disorders, they pose a specific challenges in pregnancy and childbirth. Now coming to the investigations as such, the investigations of primary hemostasis are bleeding time, platelet count, platelet function analyzer or a PFA 100, platelet aggregometry, and tests for von Willebrand disease. For want of time, we will not be discussing these at all. Then the secondary hemostatic defects have to be assessed through prothrombin time, activated partial thromboplastin time, thrombin time, and factor assays. So the prothrombin time, it assesses the extrinsic pathway and the common pathway. The APDT assesses the intrinsic pathway and the common pathway. Thrombin time will assess the fibrinogen levels, and you can directly measure the fibrinogen as well through a fibrinogen assay. So these are the major things, and we are not discussing the coagulation cascade and so on. It is expected that the students, learn like this, and the practical things I'm just highlighting here. So what are the screening tests? Screening tests are platelet count, prothrombin time with INR, APTT, and fibrinogen concentration. Some labs do a thrombin time also as a screening test. The second line investigations, they depend on the result of the primary test, the screening test, and they comprise of specific factor assays, tests for von Willebrand disease, and platelet aggregation studies. So this table, this looks a very busy table and a busy slide. This has actually been taken from DESI, and I request all the people in training, residents, to please do not leave out DESI. I understand that students these days are not reading DESI at all, but please go ahead. Without reading DESI, you cannot train yourself. So this table is from DESI, and look at this is a very beautiful table, comprehensive table, and this tells you that after the screening test, what are the conditions which are associated with those screening tests, and how do you proceed with the second line investigation. So I'll just take this example maybe, like PT normal, APTT prolonged, fibrinogen normal, and platelets normal. So what are the scenarios associated with this? So there could be defect in factor 8, factor 9, factor 11, factor 12, or precalculin or contact factors. Or there could be factor VIII deficiency secondary to von Willebrand disease, or there could be circulating anticoagulant like lupus. So now these are the conditions, and what are the second line investigations? So you'll go ahead with the mixing test for correction. Then you'll do specific factor assays, von Willebrand factor assay, anti-10A assay, and so on. So please go through this, table and chapter. Now, what about mixing tests, because they are at most important? Any abnormal PT or an APTT can be because of either a factor deficiency or because of presence of an inhibitor. And therefore, it is very important to understand what is the cause of that prolonged APTT. So mixing tests are essentially done on a mixture of 1:1 plasma, a patient plasma, one part, and the PNP, one part. Mix them and perform an APTT or a PT, whatever was your concern. So if it corrects, the prolongation corrects, it was because of a deficiency of a factor. If it fails to correct, it was because of an inhibitor. So what are inhibitors? Inhibitors are basically antibodies. They bind to coagulation proteins. They can be specific or non-specific inhibitors, and therefore there will be no correction in the APTT whenever an inhibitor is present. The mixing test can be done with various types of plasma. The PNP, which contains all the factors, then aged plasma, which is deficient in factor 5, 8, 1, and 2, or adsorbed plasma, which is deficient in the vitamin K dependent factors. And Dr. Dinesh was just telling you that you have to keep barium sulfate in your lab. That was for preparation of the adsorbed plasma. Then factor 8 deficient plasmas and factor 9 deficient plasma. Not many labs are doing these aged and adsorbed plasma these days, but if you can manage it, it will give you a fair idea of how to proceed. But at least a mixing with PNP and if possible a factor 8 and factor 8 and a 9 deficient plasma would really help. So this table shows you how does a mixing test result assist you. For example, if there is a defect in factor 8 in the test plasma, that is, we are talking of a patient suspected of hemophilia A. The APTT will be abnormal, but it will be corrected by adsorbed plasma and factor 9 deficient plasma, but not by the aged or a factor 8 deficient plasma. And there will be correction with normal plasma. So that suggests that there is a factor 8 deficiency. So you can go directly with the factor 8 assay rather than doing factor 8, factor 9, 11, 12, and so on. Is it 20 minutes already? Okay. Okay. Then there are specific assays like factor 2, 5, 7, 8, and so on. Tests of von Willebrand disease and platelet aggregation studies. So this is a simplified flowchart for United Bleeding Disorders. If the screening tests PT and APTT are prolonged, then do a mixing study. If there is a correction, that means there is a deficiency. So how do you proceed? If only PT is prolonged, that means there is a factor 7 deficiency, do a factor 7 assay straight away. If only APT is prolonged, do mixing test and then do specific factor assay. If both PT and APT are prolonged, that means there is a defect in the common pathways. Do a thrombin time. If it is prolonged, it suggests a fibrinogen defect, then just do fibrinogen assay. If not, then do the other factors. And if both PT and APT are normal, but the patient is still a bleeder, then it means there is a factor 13 deficiency, do that. Platelet function defect, do a platelet function analysis, and a mild Willebrand disease, so you will do a VWF assay. So just 2 minutes more, time to go back to the case we had discussed. Now, how should you have proceeded in this case? So this was the history. Frequent nosebleeds requiring pressure, heavy menstrual bleeding with easy fatigability. Mother has similar complaints, and there was prolongation of APTT only. So isolated APTT prolongation and this kind of a history. Is the patient bleeder? Yes. The bad score was 6. And this appears to be a primary defect because these are all superficial bleeds. This looks like an hereditary disorder because there is a history in the mother, and therefore it looks like an autosomal dominant disorder. Isolated PTT prolongation, that means there is deficiency in the intrinsic pathway, and therefore you can do away with the common pathway and the extrinsic pathway factors. So just cross them out. Now, what were the additional test orders? Factor 12, 11, 8, and so on. Now coming to factor 12, these patients do not bleed. Factor 12 patients deficiency, they do not bleed. They just give an abnormal APTT. So cross it out. Now you're left with 9, 11 and 8 of intrinsic pathway. Deficiency factor 11 is rare and the bleeding pattern is autosomal recessive. So just cross it out. Factor 8 and 9 deficiencies are X-linked disorder. So even they are crossed out. So now why is the patient bleeding? Now you are left with a positive family history in the mother with an autosomal dominant inheritance. There is a mucocutaneous bleeding, so two things are left of primary hemostasis, abnormal platelet defect, and von Willebrand factor deficiency. The lab results show a normal platelet count in morphology. So is it a von Willebrand disease? Most likely. So now you will have to go ahead with the battery of tests for von Willebrand disease, and Jasmina madam will be taking this in detail. So the take-home message here is that lab diagnosis of a coagulation disorder starts from the clinical history, that is the symptoms. The clinical information related to type of bleeding, duration of symptoms, family history provide valuable information. However, you must understand that pre-analytical variables are the most important cause of false laboratory results. So take care of that. Screening tests help in placing the patient in one of the broad categories, and then you have to go for specific factor assays. And thank you so much.
Thank you, Dr. Nandita, for such an elaborate presentation on the importance of history in the lab diagnosis of bleeding disorders. I cannot emphasize enough on the history taken, and especially by a nephrologist, Yusufa herself, in the cases of a bleeding disorder. And it's always this, because the shortage of time will
Thank you, ma'am. Next, I request Survi Gupta ma'am to give a memento as a token of appreciation to Dr. Namrata Avasthi ma'am.
So now I call next speaker, Dr. Sujata Chaudhary. She is Associate Professor, Department of Pathology, ASIC, New Delhi. Madam would be delivering her talk on acquired coagulopathy. Over to you.
Ma'am, give a Sorry, ma'am. Let's take it. वो एजेंट उसके पास मैम को मैंने कहा था सी वही वाली अटकती है कौन सी वाली अटकती है
Sorry for the technical glitch. If there are any questions, they can be discussed with our speakers. So you can utilize the time for the discussion. Sure, sir.
Dibarati, Mike.
5 MCQs. ठीक है? Rashmi is getting nervous. She has promised surprises. She doesn't do this. So till the time Sujata gets ready, take out the paper. Take out the paper and not looking. Write your name. You select the paper at the end of the day. ठीक है? देखो, first question. First question. Are you all ready? Pen, सब कुछ है folder के अंदर. You don't have to search for it. What is intrinsic kinase complex? First question. Be serious. What is intrinsic kinase complex? देखो, write your name also so that you know the answer. What is extrinsic kinase complex? Second question. पहला क्वेश्चन क्या था? What is intrinsic kinase complex? Second question. What is extrinsic kinase complex? Third question. What is partial thromboplastin? What is partial thromboplastin? Google मत करो, मोबाइल बंद करो. Be honest. अब फौजी आदमी है यार, सब कुछ पकड़ लेते हैं. मोबाइल बंद करो. Be honest. First question, what is intrinsic kinase complex? Second question, what is extrinsic kinase complex? Third question, what is partial thromboplastin? ये सब चीज नहीं जानोगे तो कोएगुलेशन अपडेट आप लोग सुन रहे हो. बेसिक कॉन्सेप्ट होना चाहिए. Fourth question, what is thromboplastin? Fourth question, what is thromboplastin? Fifth and final question, what is prothrombin complex?
इसको स्विच ऑफ करके स्विच ऑन करें.
Rashmi, who is going to correct the answer paper?
Sir, I will correct.
आप करेक्शन होगी. टाइम इज ओवर. ठीक है नाम. So what is partial thromboplastin? Anyone? Does it have any coagulation role in vivo? देखा सब silent. Partial thromboplastin is just phospholipids. Unlike complete thromboplastin. What is thromboplastin? Tissue factor, factor 7A, phospholipid, calcium है ना thromboplastin. वो vivo में coagulation करता है. Partial thromboplastin तो phospholipid. तो ये कॉन्सेप्ट बड़ा हम लोग बोलते हैं एक्टिवेटेड पार्शियल थ्रोम्बोप्लास्टिन है. ये सब चीज अभी से कॉन्सेप्ट बना. सीरियस कॉम्प्लेक्स दोनों इंट्रिंसिक पाथवे में है, एक्सट्रिंसिक पाथवे में है। फैक्टर 10 को 10 बना सकते हैं।
पीपीटी में मैं कर रही है।
तो 98 is equals to we can say metal activity extrinsic is 7. ठीक है? So like that,
प्रॉब्लम है इसके साथ उसका वो कनेक्शन
like Dr. Nagar said, everything is in DC. अब लोग DC नहीं करोगे तो फिर कैसे?
पीपीटी हैंडल
पीपीटी
तो
हैंड कर
कौन सा
रही है।
तो
सो विल स्टार्ट विद द नेक्स्ट टॉप देन मैडम को पीपीटी का कुछ करते हैं
ठीक है, तो
मॉडिफिकेशन
को जो एक्टिवेट करना है
मैं आपको मेल पे कर दी
नेक्स्ट किसका है नेक्स्ट किसका है नेक्स्ट अपना का सब शुरू कर देते हैं
मैक्सिमम आपका ये
हाँ मैम आपको नेक्स्ट टॉप कर देते हैं there is some issue with the PPT. It is hanging, so probably we'll move on to the next talk. As Dr. Sukesh is on the way, so sir, can we have your talk now? अपना तो बाकी speakers को
नहीं डुप्लीकेट नहीं है इसको डुप्लीकेट कर दो
क्या
डुप्लीकेट नहीं है करता नहीं है
I would like to request Dr. Nooreen Zati ma'am, dear Professor, Department of Pathology, Era Medical College and Hospital, Lucknow, to come on the dais.
मेरा काम कुछ नहीं ये
चल
आ गया
चल गया
चल गया चल जा
just check it once. चल रहा है ना
चल
अरे ये क्या आ गया दिस इज नॉट ये आपका नहीं है मैम ये है
Sir, you start the talk. Sir, some
ठीक है
सर की कौन सी है
पथारा सर का ही है।
हाँ सर
लूपस अरे और ऐसा करना ना Good morning, ladies and gentlemen. Dr. Tripathi sir, a very good morning to you, my colleagues, Dr. Rashmi, Dr. Namrata, and Jasmina, of course, FMC days. Hi to everyone. So, Thorasa, my topic is a slightly different topic from the previous two topics. This case, you will have a lot of cases, and we'll discuss the cases. So, there are a lot of issues regarding diagnosis and management of the antiphospholipid antibody syndrome. कोई भी clinician से पूछोगे, it's a nightmare, ठीक है ना? So we are all clinicians first, and then we are lab people, ठीक है? So from the bench to the bed, and from the bed to the bench, whatever we want to discuss, they are complementary to each other. And lupus is one subject which tells us how important the clinical features and thereafter the lab management is, right? So I bring you greetings from this beautiful hospital. Dr. Tripathi was asking, "Ye kaun sa hospital hai?" So this is after my superannuation to Army Hospital RR. This was an MBBS college, which is now a DM MCH college. Sir, with your blessings, 53 bone marrow transplants under me in the last 3.5 years, and we have started our MD program in 21 subjects. 4 years. This college is now at the national level. I am proud to be associated with it. This is where my life began in Army Hospital RR, and this is where I was born. Technically, actually, I was born in those days in Kawan Hospital, Pune, and then I did all my studies here. So, what is already known? A quick revision. See, Conley et al. Actually identified in a group of patients lupus, but it was discovered in 2 patients surprisingly with a hemorrhagic disorder. SLE comes with thrombosis. Actually, it was discovered in a hemorrhagic disorder in 1952. And the paradoxical relationship of these patients with LA with thrombosis, despite the so-called circulating anticoagulant. आप समझ गए बात? Circulating anticoagulant है, but thrombosis है. This paradoxical relationship was pointed out in 1963. But it was Feinstein and Rapoport actually who coined the term lupus anticoagulant to describe this coagulation inhibitor in 1972. And much of the credit goes to them. And finally, the lupus as a group of antibodies or autoantibodies that target those negatively charged phospholipids was observed in 1980. Now, each and every word is important. When you approach a subject, read the history of the subject. You know how it all started. ठीक है? उससे थोड़ा interest generate होता है. These are the facts and figures. Now, these are also important. 5 line है, ध्यान से सुनो. Prevalence is 2 to 4%, right? 15 to 20% of DVT with or without pulmonary embolism. Of and 1/3 of new cerebrovascular accidents less than 50 years. Antiphospholipid syndrome. So you must know this subject thoroughly. Cerebrovascular accidents में antiphospholipid syndrome का बहुत बहुत importance है. In 10 to 40% of SLE, you get positive antiphospholipids, and 20% of rheumatoid arthritis patients also you get this positive. Okay. Those asymptomatic patients who are harboring this antiphospholipid, almost 4% has an annual risk of thrombosis. That doesn't mean we'll just start screening everyone, but you should be aware that antiphospholipid antibodies is one of the factors in stroke in young. And this prevalence of APLA or antiphospholipid antibodies increases with age. Are you clear? ये थोड़ा सा PSM टाइप है ये, but ये important है तुम लोग के लिए, ठीक है? It's a shrewd killer, as Dr. Tripathi will agree, a physician's dilemma, a diagnostic nightmare, and a lifetime of anticoagulation. You see those pregnant females with recurrent, trimester, abortions and all, they come. Day 1 से उनको low molecular weight heparin देना है, right up to that. It is a nightmare. And then we produce, and she produces a child, she's so thankful. So the clinical hematologists दिन रात काम कर रहे हैं. So big hand for all of you, sir. And of course, I am part of your team. Okay. So it's an acquired autoimmune thrombophilia actually. If you want to define it, it is an acquired autoimmune thrombophilia. It is characterized by vascular thrombosis, could be arterial venous, recurrent pregnancy losses, non-thrombotic manifestations also, and lab evidence of these autoantibodies. Let's not forget this great gentleman, Graham Hughes syndrome, a very famous rheumatologist. He actually took out all those symptoms of the antiphospholipid antibodies. Okay? He worked at St. Thomas's Hospital, just across the Thames. I just went recently there, and I was happy to give a lecture there. So St. Thomas's Hospital, okay? Just across the Thames. वहाँ पर ग्रैहम ह्यूग्स ने लूपस क्लिनिक खोला था, और उसने ऐसे बेहतरीन डायग्नोसिस दिया था because of clinical observation. So the antiphospholipid antibodies is called Hughes syndrome. Let's not forget it. Now Sapporo कहाँ पर है? I forgot to ask the Dix. That was part of the MCQ. Sapporo कहाँ पर है? Anyone? Postgraduates, you have to read and come for coagulation update. You should not come for just lunch. ठीक है? ठीक है? What is Sapporo? North जापान में एक बहुत सुंदर सिटी है. 1999 में सबसे पहला लूपस का क्राइटेरिया वहां पर डिस्कस हुआ था. Obviously there were limitations. So 2006 में सिडनी में the Sapporo was redefined with various classifications. ठीक है? So this is Sapporo. So at least one clinical and one lab criteria. तो ये है vascular thrombosis, आप लोग को पता है. Pregnancy morbidity आप लोग को पता है. I'm not enumerating all these things, it is known to you. और lab criteria जिसमें lupus coagulant होना चाहिए at least on 2 occasions to be discussed 12 weeks apart. 2 बार आपको टेस्ट करना है, and detected according to, दिनेश साहब बोलेंगे, according to ISTH guidelines. ये बहुत ही नपीचुली गाइडलाइंस है ISTH की. उसके बाद आपको एंटी कार्डियोलिपिन एंटीबॉडीज है, वो IgG भी हो सकते हैं, IgM भी हो सकता है, उसका भी टाइटर होता है. So these are all been quantified in the Sydney criteria. And one very exciting thing in Sydney criteria, which was not there in the Sapporo 1999, कि beta 2 CB1 antibody का पहली बार जिक्र हुआ. First time ever people discuss the beta 2 CB1 antibody, and we know that is the basics of all the lupus anticoagulant tests. ठीक है? So ये सब classification, Sydney classification, ये सब देख लीजिए, clinical lab है ना? Suddenly the chairperson will tell me आपका time हो गया, so I'm not going through all this. ठीक है? So lab and this, but what you must know this, Sydney 12 हफ्ते के अंदर आपको diagnose करना है. The criteria has been quantified. Greater than 40 units of IgG or IgM phospholipid antibody titer or greater than 95% percentile. और ये है some of the clinical criteria which the clinicians will be excited to know that in addition to what Sapro said, cerebral ischemia and stroke was reintroduced in the Sydney criteria, and this is very important because आपने देखा prevalence कितना है. Additional inherited or acquired risk factors of thrombosis was stressed on. बट अनफॉर्चुनेटली ये प्राइमरी एपीएस और सेकेंडरी एपीएस जो हम लोग आमतौर पर बोलते हैं, that was not discussed in the Sydney criteria, and we know this is important. We have something called primary and we got something else. 12 weeks has to be there. Addition of beta to GP1 and cutoff values 40 and more in MPL or GPL, वो cutoff value. But it omitted a lot of non-classical manifestation, particularly hematological. Thrombocytopenia हो रहा है. We now know that antiphospholipid syndrome is one of the reasons of thrombocytopenia. That you will see in the new criteria. Neurological diseases में भी बहुत सारे limitation का Sydney criteria. Now it includes anti-cardiolipin and beta to GP1 IgM isotypes, and you know these IgM isotypes are actually associated with various types of infection. So it is limited as far as its diagnosis and thrombosis is concerned. Does not, as I said, consider primary or secondary APS. So these are the limitations of Sydney. And most important, complement C3 C4 का जो importance है, complementopathies जो नया classification हम आपको बताएंगे अभी, that was not discussed. Netosis, general pathology है ना, netosis, inflammation, obstetrics में APLA क्यों होता है? It is because of netosis, है ना? So all those things have now been incorporated in the new classification, which I am now going to discuss with you. So what is new? अभी तक जो बोला ना आप लोग को पता होना चाहिए. I presume you all knew it. But I know you didn't know it. Now what is new? The ACR-ULR antiphospholipid syndrome classification criteria. ये 2023 का है, latest, ठीक है? So this is very appropriate with this coagulation update. हम आपको कुछ latest बता रहे हैं. It is risk stratified, it is validated, ठीक है? And this criteria is by an Indian author, Medha Barbhaiya, ठीक है? Though she doesn't come to India, she is somewhere else. So ये आर्थराइटिस और रूमेटोलॉजी के एक बहुत उम्दा जर्नल में ये पब्लिश हुआ है, ठीक है? This sets out criteria. These criteria have been validated. और ये इतना बेहतरीन क्लासिफिकेशन है कि ये ओपन एंडेड है. इन्होंने कहा कि हर 3 महीने में हम लोग डेटा देखेंगे और दोबारा इसको वैलिडेट करेंगे. So beautiful. So that if they have told something wrong, that will be recorrected. So that's the beauty of this classification that they have kept it कि 3-3 महीने में हम लोग इस क्लासिफिकेशन को और बढ़ाएंगे. अगर हमने कुछ गलती बोला तो उसको हम कैंसिल कर देंगे. So this is beautiful. Unlike our leukemia classifications and AML, I'm speaking on that in 4 days tomorrow. इसमें इतना problem ICC और WHO. Thank God in coagulation, you know, these controversies are much less, and I, you know, appreciate all the lawyers sitting there in coagulation that they have prevented confusion, which is there in my subject of leukemia. So this is ACLR-ULR classification, ठीक है? American College of Rheumatology, ACR, European Association of Rheumatology, ULR, ठीक है? So इसमें एक एंट्री होता है. आप इस क्राइटेरिया में एंट्री कैसे कर सकते हैं? At least one positive APLA test within 3 years of onset of the clinical symptoms. पहला था 5 साल के ऊपर, वो सब उठ गया. 3 साल के अंदर आपका क्लिनिकल सिम्टम्स और एक APLA टेस्ट अगर आपका पॉजिटिव है, तो you will be considered as a patient of APLA. So you will be followed up. And point system है. ये clinical criteria आपको दिखाएंगे. इसमें point system है with 99% specificity. ये देखिए डोमेन दिखाई दे रहे हैं. There are 8 domains. D1 से D8. लैब का डोमेन है as usual लास्ट में D7 और D8. और D1 से D6 है क्लिनिकल. दोनों को मिलाकर हम लूपस की बात करते हैं. D1 is macrovascular. ठीक है, उसमें पॉइंट्स है 1 and 3. ध्यान से देखिए, VTE without a high risk profile is 3 point, whereas VTE with a high risk profile is 1 point. जिसको spontaneous हो गया, weightage is more than जिसका risk factors पहले से, because the diagnosis will be something else, the etiology will be something else. Have you understood? उसी तरह आप देखिए D2 macrovascular arterial, again without a high risk factors given, more weightage. माइक्रोवास्कुलर D3, इसमें हम लोग बोलते हैं लिविडा रेटिकुलरिस और लिविडा रेसिमोसा। क्या होता है ये, किसको पता है? मार्बलिंग ऑफ द स्किन। डॉक्टर त्रिपाठी देखते हैं, लाइट से देखते हैं, लेंस से देखते हैं। मार्बलिंग ऑफ द स्किन यूनिलैटरल और बाइलैटरल, लिविडा रेसिमोसा, मल्टीपल मार्बलिंग लाइक स्किन, वैस्कुलर थ्रोम्बोसिस हो रहा है। वही चीज अगर एक्सटेंसिव हो गया और बायलैटरल हो गया, अपर एक्सट्रीमिटी लोअर, उसको कहते हैं लिविडा रेसिमोसा। और आप बाद में देखोगे दिस इज एसोसिएटेड विद स्ट्रोक एंड एंटीफॉस्फोलाइटिक एंटीबॉडीज। सो दिस इज लिविडा रेटिकुलरिस और बाद में लिविडा रेसिमोसा। कोएगुलेशन जैसे नम्रता मैडम ने बताया ना, हर चीज में क्लिनिकल चीज है। You have to understand the clinical fact. Otherwise, working in isolation in the lab, जितना भी आप quality control बोलो, is not going to achieve anything. And don't wait for the clinician to give you history. Go and take the history yourself. ठीक है? You are MBBS, so you know you are a physician first. ठीक है? So that comes to Sneddon syndrome. A very famous neurologist, Bruce Sneddon, उसने clinical trial बताया था. Stroke, livido-reticularis, hypotension. अब समझ में आया livido-reticularis का importance क्या है? He suggested it may represent undiagnosed antiphospholipids syndrome, and now we know Sneddon syndrome और एप्ला में बहुत उम्दा एक रिश्ता है। So now we come to lupus content. आपको पता है it's a misnomer, but is retained as a historical term. In vitro anticoagulant, in vivo procoagulant, but still we continue with this lupus anticoagulant term. ठीक है? It is due to immunoglobulin containing fractions of plasma specifically against anti-beta 2 GP1 and anti-prothrombin. So this is one of the 3 lab criteria for the classification of APS. It is a functional assay, as most of our coagulation pundits will tell you. And बाकी जो 2 ऐसे एंटी कार्डियोलिपिन और बीटा 2 वो सॉलिड फेज एलाइसा से होता है। ठीक है? These are various types of tests we have. अभी ISTH ने बड़ा क्लियर कट 2 टेस्ट का नाम जिक्र किया है, हम आपको अभी बताएंगे। ठीक है? लूपस एंटीबायोटिक पियोलिन से कर सकते हो, सिलिका से कर सकते हो, बहुत। लूपस सेंसिटिव का मतलब क्या है? आपने फॉस्फोलाइपिड को इतना कम कर दिया है टाइटर से कि उस लूपस एंटीकोगुलेंट टेस्ट आप सेंसिटिव होते हैं। यू हैव रिड्यूस्ड, अनलाइक व्हाट डॉक्टर नम्रता सेड कि इन कन्वेंशनल एपीटीटी टेस्ट यू हैव एक्सेस ऑफ फॉस्फोलाइपिड, है ना? ओके, डोमेन 7 इज आवर लैब क्राइटेरिया। इट इज अ 3-step प्रोसीजर, रिमेंबर दैट। कोई भी लैब काम कर रहा है आपको बोलना चाहिए हैव यू डन द 3-step प्रोसीजर? यस। 2 screening tests to be used. One is DRVVT test and a sensitive APTT test like a silica test, which has got low phospholipid, silica being the activator of factor 12. At least one of the 2 systems should yield positive results. ये बड़ा clear criteria है. And the result should be interpreted with caution, particularly on patients who are on anticoagulants. आमतौर पे patients anticoagulants में होते हैं, DOAC में होता है, डायरेक्ट ओरल एंटीकोगुलेंट्स होता है, फैक्टर 10 इनहिबिटर्स में होते हैं, बहुत कुछ। तो उसमें अगर आप लूपस टेस्ट करते हैं, उसका भी क्राइटेरिया इस नया क्लासिफिकेशन में दे दिया है, जो कि पहले क्लासिफिकेशन में नहीं था। दिस इज डोमेन 8, एंटीकार्डियोलिपिन एंड बीटा 2 GPI. इट इज ओनली टू बी डन बाय एलाइजा। आपके बड़े लैब बोलेंगे हमारे पास क्लिया है, हमारे पास MFC है, बोले नहीं भाई, these are not recommended. The only recommended test is ELISA. Am I clear so far? Are you all understanding? Okay. So we have got various JTH articles which focuses on the scientific and standardization committee for lupus anticoagulant. Kindly read it. Now, is it also smooth and so simple as I am trying to project to all of you? The answer is no. Timing of the test, can I store the sample, pre-analytical issues, confusion, guidelines, कौन सा reagent choose करना है, डॉक्टर दिनेश साहब बता रहे थे आपको। 3-step procedure, is it mandatory? Screen, next confirm. Yes, it is. Confusion regarding cutoff values, Dr. Dinesh in his inaugural address said, you must have your standards, you must have your cutoff values, without which you cannot run any test, whether it is a simple prothrombin time or anything. So the lab has to decide on these cutoff values. Now this is the cartoon which shows Russell-Viper venom test. You know Russell-Viper venom? Russell-Viper is a very fascinating snake. अभी डॉक्टर सुकेश से मैं होटल में बात कर रहा था. I was commanding Jammu. It's full of Russell-Viper. Russell-Viper is nephrotoxic. The patient presents as a DIC with acute renal failure. ये Russell-Viper करता क्या है? डायरेक्ट फैक्टर 10 को 10A बना देता है, ठीक है? बाकी कोई पाथवे से मतलब नहीं है, सीधा 10 to 10A, ठीक है? तो आपने नॉर्मल सेलम और Russell-Viper venom दे दिया. Venom activates factor 10 and the presence of phospholipid calcium प्रोथ्रोम्बिन थ्रोम्बिन, मैसिव डीआईसी, पेशेंट गया, ठीक है। इस रसल वाइपर को हम लोग डाइल्यूट रसल वाइपर करके रसल वाइपर वेनम टेस्ट करते हैं, डीआरबीबीटी टेस्ट, जिसमें डिलेड कोएगुलेशन होता है। उसके बाद आपने हेक्सागोनल फॉस्फोलाइपेट दिया, प्लेटलेट दिया, कंफर्मेशन टेस्ट, और आपका कोएगुलेशन ठीक हो गया। सो इट्स अ 3 टेस्ट मिक्स। स्क्रीनिंग किया आपने, डीआरबीबीटी थे, मिक्सिंग स्टडी किया, उसके बाद आपने प्लेटलेट देकर इसको कंफर्म किया कि वाकई ये फॉस्फोलाइपेट डिपेंडेंट, ठीक है। एंड दिस इज द फ्लो चार्ट टू अप्रोच द डायग्नोसिस। हर लैब में ये होना चाहिए। पहला टेस्ट पीटीटीएलए, दूसरा टेस्ट स्टैक्लॉट डीआरबीबी स्क्रीन। दोनों टेस्ट नॉर्मल है, लूपस नहीं है। अभी दोनों टेस्ट एबनॉर्मल है, आपने मिक्सिंग स्टडी किया, मिक्सिंग स्टडी आफ्टर इनिक्यूएशन किया, फैक्टर ए से किया, आपको पता चल गया ये फैक्टर डेफिशिएंसी है। अगर नो करेक्शन है विद नॉर्मल प्लाज्मा, पेशेंट प्लाज्मा और मिक्सिंग स्टडी, कोई करेक्शन नहीं है, आप फिर कंफर्मेटरी टेस्ट कीजिए, स्टैक्लॉट एलए कंफर्मेटरी, स्टैक्लॉट डीआरबीबी कंफर्मेटरी। दोनों अगर पॉजिटिव है तो आपका लूपस एंटीकोएगुलेंट है, अगर नेगेटिव है तो फैक्टर इनहिबिटर। समझ गए बात? तो ये बड़ा सिंपल एक अप्रोच है। Whom to test? Do you test everyone? No. Those people for moderate probability and high probability, like unprovoked VTE, ऐसा पेशेंट में हम लोग लूपस टेस्ट करेंगे। हर चीज में लूपस नहीं सोचना चाहिए, डोंट ओवर डायग्नोज लूपस। सो एक्सटर्नली प्रोलॉन्ग्ड एपीटीटी इन एसिम्प्टोमेटिक सब्जेक्ट, अनप्रोवोक्ड VTE, बहुत सारे कारण हैं, सबका गाइडलाइन से, मेरा गाइडलाइन नहीं है, बना हुआ गाइडलाइन है किताब से, आप लोग ये गाइडलाइंस चेकलिस्ट बनाना चाहिए। ओनली सच पेशेंट्स विल अंडरगो टेस्टिंग, ठीक है। So ये सब चीज छोड़ो। Can I store the sample? Yes, you can. You can freeze within 4 hours. You have to do double centrifugation, otherwise platelet activation हो जाएगा और आपका टेस्ट खराब हो जाएगा। And before testing, you should also throw it at 37 for 5 minutes. So these are all guidelines by the ISTHA, which are very much there in the new classification, which all of you should read. Prenatal sample issues बहुत है। अगर पेशेंट एंटीकोगुलेंट है, लाइक VKA, डॉक्टर त्रिपाठी साहब मेरे पास बोलेंगे, साहब ये तो VKA में है, विटामिन के एंटागोनिस्ट, हम क्या टेस्ट करेंगे? नहीं, स्टॉप फॉर अ वीक, टेस्ट INR, अगर INR 1.5 से लेस है टेस्ट कीजिए लूपस का, क्लियर कट गाइडलाइंस। अगर लो मॉलिक्यूलर वेट हेपेरिन में है या अनफ्रैक्शन हेपेरिन में क्या करेंगे, आपको डॉक्टर वर्मा पूछेंगे तो हम बताएंगे सुप्रा थेरेप्यूटिक लेवल्स में इफेक्ट होते हैं। इसका मतलब जस्ट बिफोर द लास्ट डोज और जस्ट बिफोर द सेकंड डोज ऑफ लो मॉलिक्यूलर हेपेरिन आप जल्दी से टेस्ट कर लीजिए। So when your low molecular weight heparin is at its nadir, at its lowest, that means just before the next dose, उस टाइम आप करेंगे लूपस, ठीक है। ये बड़ा बड़ा इंपॉर्टेंट कैविएट्स है आप लोग को, पर्टिकुलरली क्लिनिशियंस एंड लैब पीपल शुड बी इन सिंक। नहीं तो वीके चल रहा है आप लूपस करिए, सब फॉल्स टेस्ट है, यू आर वेस्टिंग योर रीजन, ठीक है, लाइक दैट। व्हिच रिएजेंट्स टू चूज, ये डॉक्टर दिनेश इज द एक्सपर्ट, आई एम नॉट एन एक्सपर्ट इन दिस, तो यू कैन चूज। बट टाइपान, वेनम टेस्ट, एकरेंट टेस्ट, ये सब नए नए टेस्ट जो पुराना जमाने के, सब कुछ आउट है। Silica clotting time and DRBBT, these are the 2 tests you have to do, ठीक है। Now algorithm, आपने ये कर दिया, एक चीज आपको बताना है जिसे रोसनस इंडेक्स कहते हैं। रोसनस इंडेक्स is a very important methodology of diagnosing whether the patient has got factor deficiency or lupus। क्या है रोसनस? ये देखिए, अब मिक्सिंग स्टडी कर लिया है, ये सब छोड़ दे, अभी टाइम नहीं है, बट आई टेल यू what is Rossner's index, ठीक है। I'm skipping, yeah, Rossner's index is, आपने मिक्सिंग टेस्ट किया, माइनस कंट्रोल अपॉन द पेशेंट्स एबीटीटी इनटू 100, ठीक है। और दूसरा हम क्या करते हैं, नॉर्मलाइज रेशियो। लूपस हम लोग या रोसनस इंडेक्स से बोल सकते हैं या नॉर्मलाइज रेशियो से बोल सकते हैं। जब लैब रिपोर्ट देता है ना, नॉर्मलाइज रेशियो से देते हैं, स्क्रीन अपॉन कंट्रोल ऑफ स्क्रीन अपॉन कंफर्म अपॉन कंट्रोल ऑफ कंफर्म। ये देखिए, ये इंटरप्रेट कीजिए। स्क्रीन डीआरबीबी टेस्ट 54 सेकंड पेशेंट का है और पूल नॉर्मल प्लाज्मा कंट्रोल 38 सेकंड। सिमिलरली मिक्स में 45 और कंफर्म 40। अभी आपने रोसनस इंडेक्स बनाना है, देखिए रोसनस मिक्स कितना था 45, कंट्रोल कितना है उसका 38 और पेशेंट का कितना है 54 इंटू 100, 12.9%। ये हो गया रोसनस इंडेक्स। इसी को अगर नॉर्मलाइज रेशियो करोगे, स्क्रीन अपन कंट्रोल का रेशियो अपन कंफर्म अपन कंट्रोल का रेशियो करके आपका ये 1.27 आ गया। रोसनस इंडेक्स क्या है? इट्स अ टूल टू इंटरप्रेट मिक्सिंग स्टडीज फॉर एलए एंड फैक्टर डेफिशिएंसी। एनीथिंग लेस देन 12 indicates a correction or a factor deficiency. So insist on a Rossner's index. 12 to 15 suspicious. Anything more than 15 lupus inhibitor. ठीक है? A high index value suggests the presence of an inhibitor. easy to be done in the lab, Rossner's index, standardize it, ठीक है। दूसरा है हमारे Chang's correction, don't bother about that, and केस। अभी मैं डॉक्टर जसमीना से हम लोग केस डिस्कस कर रहे थे 2 मिनट पहले। देखिए ये केस, ये सोचे लोग मंचोसन सिंड्रोम है। 60-year-old lady, known hypertensive, presented to hematology with 3 weeks duration of bluish patches all over the body, history of gum bleeding and swelling left knee। लोग सोचे कि इस उम्र में कुछ मारपीट चल रहा है, सेल्फ इन्फ्लिक्टेड ब्रूजेस या साइकोलॉजिकल एस्पेक्ट। इसी तरह क्लिनिकल हेमेटोलॉजी मेरे पास आए। नो फैमिली हिस्ट्री ऑफ ब्लीडिंग डायथिसिस, नो नॉन ट्रॉमेटिक और अनएक्सप्लेन्ड ब्लीडिंग, नो नो नो, सब कुछ नो है, ठीक है। हेमाटोमा था टंग में, नी स्वेलिंग नॉन टेंडर विद अ पॉजिटिव पैटेलर टैप। हमने क्लिनिकल कर लिया। ये देखिए ईएसआर सब कुछ नॉर्मल है। एपीटीटी 110, फेलियर टू करेक्ट in 1:1 mixing study. What do you think? Repeat APTT performed 2 additional times. Again, same thing. Fibrinogen level was normal, D-dimer normal was almost normal. BWF, cardiolipin antibody, factor 9, 11, 12, सब कुछ normal. Serum protein electro, हम लोग सोचे कि कोई CLPD तो नहीं है। Serum protein electrophoresis, SFLC, bone marrow studies, सब कुछ कर लिया। DRBVT screen and confirmed test was positive. Quantitative of the coagulation factor 4% factor 8 activity, ठीक है। Bethesda ऐसे 8। What is your diagnosis? Acquired hemophilia with lupus anticoagulation, बड़ा रेयर केस है। हमने सोचा कि रेयर है, हमने फिर वैलिडेट किया और ये केस रिपोर्ट बन गया हमारा, ठीक है, ठीक है, बहुत पहले की बात है। पैथोफिजियोलॉजी आप लोगों को सब पता है, फ्लूइड फेज कोएगुलेशन डिस्टर्ब होता है। मेरा टाइम कितना है मैडम? 5-6 मिनट तो हो गई हो, ठीक है। आई एम ट्राइंग माय बेस्ट टू गो, है ना। Complement activation, this is from New England Journal of Medicine, diagnosis and management of antiphospholipid management। इसमें निटोसिस की बारे में है। A 14-year-old female child has seizures on MRI, lesions in the white matter of the brain। ध्यान से सुनिए, everything is clinical। Thrombophilia work सबसे पहले किया। A young enthusiastic lab researcher who was doing research did anti-beta 2 GP1 IgG and anti-cardiovascular antibodies, ठीक है। He further measured the anti-neutrophil extracellular trap antibodies, सब कुछ उसको ज्यादा मिला और उसको कॉम्प्लीमेंट फैक्टर्स भी रिड्यूस्ड मिला। So netosis, the pathology of anti-beta 2 GP1 antibody is basically enhances glycolytic metabolism, induces tissue factor expression in neutrophils and monocytes, and induces the release of nets। और nets क्या है? Nets have a role in the activation of complement pathway। तो C3 और C4 आपका रिड्यूस हो जाता है, प्लेटलेट्स, एंडोथेलियल सेल्स, सब कुछ प्रॉब्लम हो जाता है और इसी तरह थ्रोम्बोसिस होता है। मोर एंड मोर ऑब्स्टेटिक APS is now inflammatory in origin। Have you understood? Netosis has come in a big way in obstetric APS। तो बहुत सारे केसेस है। ये केस देखिए, G1P0A0 26 week gestation, APS was diagnosed 5 years back due to spontaneous DVT and repeated tests are positive। लॉन्ग टर्म एंटीकोगुलेंट चल रहा है एंड नाउ फुल डोज लो मॉलिक्यूलर वेट है। लेबर चला, लेबर में हाई बीपी, इंक्रीज लेबर एंजाइम, रिस्क स्ट्रैटिफिकेशन किया, ट्रिपल पॉजिटिविटी है। ये प्रॉमिस स्टडी है। तो ऐसा पेशेंट को हम थ्रू आउट द प्रेगनेंसी लो मॉलिक्यूलर वेट हेपेरिन देते हैं। दिस इज एप्ला। और ये मेरा फाइनल केस है, देखिए बहुत साल पहले 1986, जस्मीना FMC 1986। देखो दिस वाज अ पेशेंट विद प्री-एक्लैम्पसिया। ये क्या है भाई, किसी को पता है? सर तो बहुत खुश होंगे इसको देखकर। एली सेल फिनोमेना, ठीक है। इनके पेरिफेरल स्फीयर में हमें एली सेल, इट इज अ मैक्रोफेज, ठीक है। तो एली सेल, उस जमाने में ANA टेस्ट भी नहीं थे हमारे पास, हम एली सेल करते थे डिफिब्रिलेटेड ब्लड में, ठीक है, हिलाते थे फ्लास्क में, याद है? उसका किडनी बायोप्सी में देखिए, मेम्ब्रेनो-प्रोलिफेरेटिव ग्लोमेरुलोनेफ्राइटिस, फुल हाउस इफेक्ट, हिस्टोपैथोलॉजी। व्हाट इज फुल हाउस इफेक्ट इन इम्यूनोफ्लोरेसेंस? लूपस, ऑल द एंटीबॉडीज आर पॉजिटिव, ठीक है, फुल हाउस इफेक्ट। तो इसका लूपस था। शी प्रेजेंटेड एज एक्लैम्पसिया इन फर्स्ट प्रेगनेंसी, बच्चा बॉर्न हो गया। सेकंड प्रेगनेंसी में किसी को पता नहीं था, बच्चा मर गया। उसका फिर किडनी फेल हो गया, उसका एली सेल फिनोमेना पेरिफेरल ब्लड में आया, लिवर बायोप्सी में लूपस। शी वाज अ केस ऑफ एप्ला इन 86। वी डिड नॉट नो ऑल दिस थिंग, ठीक है। तो ये सब चीज क्वेश्चन रेज वगैरह। बीटा 2 GP1 का जो डाइमराइजेशन होता है उसका पैथोग्नोमिक एंटीबॉडी इज डोमेन 1 में। देयर आर 5 डोमेन्स इन बीटा 2 GP1। तो फर्स्ट डोमेन का जो डाइमराइजेशन, उसका तो पैथोजेनिक एंटीबॉडीज होता है, दोज एंटीबॉडीज bind to the phospholipid, and that was the apla। So we'll not go into all this। ट्रिपल पॉजिटिव सबको पता है, ये हमारे बहुत सारे पेपर्स है। लास्ट केस देखिए, बहुत ही बेहतरीन केस, ध्यान से सुनिए। इसमें लास्ट केस है, 2 मिनट। 26-year-old young lady medical officer हमारे यहाँ कमीशन हुआ, बिहार से आर्मी में आई। नो प्रीवियस कोमोबिडिटी, 2 महीना नौकरी थी। उसके बाद ऑफिसर्स बेस में उसका रूम बंद पड़ा हुआ है, शी इज लाइंग अनकॉन्शियस। तो हम लोग उसका दरवाजा तोड़ के उसको लाए। देखिए क्या हुआ। शी वाज अ ड्रग एडिक्ट, बेंजोडाइजेपिन ओपिएट ओवरडोज, राइट अपर लिम्ब मोनोपेरेसिस, एमआरआई शोज लेफ्ट एमसीए इन्फार्क्ट, सेरोसाइटिस एक साथ 2 दिन के अंदर, एसाइटिस, प्लूरल एफ्यूजन, पेरिकार्डियल एफ्यूजन, ट्रांसएमेनाइटिस, रेट्रोस्टेरल चेस्ट पेन, ठीक है, एक्यूट स्टेनिंग, क्या क्या नहीं हो रहा है। विद इन 2 days सर, स्ट्रोक, इन्फार्क्ट, एक्यूट स्टेनिंग, पता चला गुड़गांव में शी वाज पार्ट ऑफ अ कल्चर ऑफ ड्रग एडिक्शन। आजकल बहुत कुछ है वहां पर, ठीक है। लुक एट दीस फाइंडिंग्स, व्हाट आर वी डिस्कसिंग? कैटास्ट्रोफिक एंटीफॉस्फोलाइपिड सिंड्रोम, कैप्स, ठीक है। इसके प्रोबेबल कैप्स, डेफिनेटिव कैप्स के सब कुछ गाइडलाइंस है, ध्यान से पढ़िए। समटाइम्स व्हेन सर्टेन 3 to 5 ऑर्गन्स आर फेलिंग, अचानक एंटीफॉस्फोलाइपिड एंटीबॉडी सिंड्रोम। हमने इसको ट्रीटमेंट किया, हेपारिन दिया, मिथाइल प्रेडिसोल दिया, और उसका स्पॉन्टेनियस रिकवरी। वी सेव द लाइफ ऑफ दिस लेडी। ऑफ कोर्स शी इज नाउ माय फेसबुक फ्रेंड। बट फौज को छोड़ना पड़ा, ठीक है। So these are all the triggers for CAPS: obstetrics, drugs, withdrawal, malignancies, SLE flare, infection, trauma. Differential diagnosis is always there: CAPS, TTP, DIC. Lot of things are there for you all to read. So to conclude, ladies and gentlemen, APLA is a potentially treatable condition. It requires a high degree of clinical suspicion due to its wide spectrum of manifestation. Lack of gold standard laboratory tests, and Dr. Dinesh will disagree with this in confirmation of diagnosis. Now we've got a lot of standardization, and I agree with what Dinesh and Dr. Jasmine are doing. They're doing great work. तो हमारे बहुत सारे लैब टेस्ट अभी स्टैंडर्डाइज हो गए हैं। The best treatment at present is to prevent recurrent thrombosis is anticoagulation duration, of which Dr. Tripathi will still say it is debatable and of course controversial. ये पता है? लास्ट एमसीक्यू क्वेश्चन, मैं कौन हूँ, मैं कहाँ हूँ? देखो, यंग डेज, मैं भी उस तस्वीर में हूँ, ठीक है। या ह्यूज वॉलरस मुस्टैच, ठीक है। गुड ओल्ड डेज। दैट्स ऑल folks, थैंक यू सो मच।
आपका भी क्या हो जाएगा?
Thank you, sir. Though sir needs no introduction, I would request ma'am to formally introduce the sir.
Good morning, everyone. So, as you all have heard him, he is Brigadier Dr. Chatterjee, and he's a senior professor of pathology and neurology, ESIC, MCH, and he has many awards, many honors in many publications. And to his name, and so you can see how good he is. And we are all very much enlightened by his talk. Thank you, sir.
Thanks, sir.
I would request Dr. Survi Gupta ma'am to kindly raise the dais. I would request Dr. Survi Gupta ma'am to kindly raise the dais. Ma'am, please introduce our next speaker.
The next speaker is Dr. Sujata Chaudhary ma'am, and she's Associate Professor, Department of Pathology, ESIC, New
हम आपने स्पीकर मैम मेरे पे किया है नहीं नहीं तो मैंने क्यों ये रहा अभी तो आपको डॉक्टर ने भेजा है मैम मेरे पे पीपीटी आप लोगों के सामने ही खड़ा है। मैम
अच्छा, चलो लास्ट क्वेश्चन. Presentation. What is fibrinogen degradation product?
इसको रिफ्रेश कर दीजिए मैम प्लीज।
हमने सुबह शुरू बता रहे थे.
आया मैम मेरे पास।
What is fibrinogen degradation product? और किताब में देखोगे लिखा है fibrin bracket ogin bracket close degradation product. ऐसे लिखा है. Even they are becoming skeptical. What is fibrinogen degradation product and how does it differ from fibrin degradation product? Anyone? Yes. Dr. Jasmina, I think you can explain this. Fibrinogen degradation product for the benefit of the PDs. Now the fibrin stabilizing straight product and all that thing. Fibrin hormones.
Very tough attending a conference with Dr. Jaffar. He doesn't let me sit in peace for a minute. So fibrinogen can itself be split into smaller products, not which are not cross-linked. When we talk of FTPs, we are talking about cross-linked fibrinogen products where plasmid has acted on the fibrinogen that is formed and the products that are released there are cross-linked. So if that is not there, and suppose the snake venom is acting directly on fibrinogen, it can go into fibrinogen degradation.
फायरफॉक्स खोल दीजिए।
So there is a difference there, and
जो आपने यहाँ से हटाया था
want to see when you are deciding what is the etiology of the fall in fibrinogen concentration.
मैम आ
Am I
जाइए।
right?
फायरफॉक्स का ये खोलिए। मैं अपने पेन ड्राइव में डाउनलोड करूँ क्या? नहीं नहीं मैम बस एक सेकंड कर दीजिए।
नीचे होते हैं ऐसे नीचे ऊपर प्राइमरी और नीचे वाले नीचे जाता है नया वाले में से.
हाँ हाँ बस मैम आ गया ये है ना ये है। हाँ 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 बस मैम एक सेकंड। सॉरी मैम फॉर द डिले। हाँ मैम स्लाइड शो हो गया है। चलेगा ना नॉर्मली।
Very good morning, everyone. Thank you for your patient waiting. I would like to first extend my gratitude to the Thagat sir and heartfelt thanks to Dr. Rashmi for introducing me to this forum and be a part of today's talk. So after a nice introduction to how to set up the lab by Dr. Dinesh and a great insight into how we proceed for the bleeding disorders, followed by Sir's detailed lecture on APLA, antiphospholipid syndrome, I would like to continue where Dr. Namrata left us with the bleeding disorder. So we will be continuing with the acquired disorders now after learning about the bleeding one. So as you know that we quickly recapitulate the components of the coagulation pathway. So these includes the platelets, the blood vessels, the blood clotting factor pathway, and the fibrinolytic pathway. So a quick look, Dr. Namrata already introduced us to this concept and we all know this already. So we have three phases of hemostasis, the primary hemostasis, which is the platelet plug formation, followed by the secondary hemostasis, which is the coagulation pathway, and the main protein which is generated here, you must remember, is thrombin by activation of the extrinsic and the intrinsic pathway. This thrombin, you must remember, is the most important protein generated in the coagulation pathway and it has several properties. It is a procoagulant, it is an anticoagulant, it has a fibrinolytic and an antifibrinolytic property. So once the process of coagulation is initiated, obviously it has to be stopped. Otherwise, there will be a massive clotting in the body. So this is managed by the activation of the fibrinolytic system. So the plasminogen is converted to plasmin, and finally, as the discussion was now going on, that the CROX-linked fibrin clot will be forming the fibrin degradation products, and finally, the clot will dissolve. So now we just had an overview of the normal hemostasis. Now we proceed towards today's topic, that is the acquired disorders of coagulation. So having learned about the inherited ones and the bleeding by Dr. Namrata, now one must remember these acquired disorders are much more common in our clinical setup than the inherited ones. And remember that there is always an underlying condition, there is always an underlying predisposing disease which is causing this acquired coagulopathy. So as you know that these are the four components which are involved, the vasculature and the platelets, the coagulation factors and the inhibitors. So the different disease process, as you can see here, the platelet dysfunction, the vasculitis, amyloidosis, etc., they affect mainly the vasculature and the platelets, and the outcome is hemorrhage. While on the other hand, prolonged bed rest, surgery, warfarin therapy, direct anticoagulants, malignancies, etc., predisposes to thrombosis. But there are certain conditions like the DIC, sepsis, APLA, autoimmune disorders, and pregnancy, which will give manifestation of both hemorrhage and thrombosis. So one must be careful in assessing these. Now coming to how do we suspect clinically any case of coagulopathy? As Dr. Namrata was telling you the history. So you all know the history is a very, very important aspect of to suspect a case of coagulopathy, whether it is inherited or acquired. So the family history, of course, a family history will be there for inherited, and the patient will give you history of spontaneous bleeding and which is recurrent, and usually the onset will be in the childhood. While in case of acquired, we will not be eliciting any such history. On the other hand, you may see certain histories which are related to these like drugs, sepsis, some surgical intervention, autoimmunity, anticoagulation therapy the patient is on, or maybe pregnancy and APLA. The physical examination, as we know that the platelets and the vasculature mainly affects the superficial type of bleeding, the superficial and the mucocutaneous bleeding. Petechia, purpura, these small bleeds, hematuria, epistaxis, etc. While the coagulation factors are mainly responsible for the deeper bleeds, that is the hematoma, hematorosis, and large ecchymosis, etc. So the type of bleeding also gives us a clue as to which aspect of the coagulation disorder is involved. Now, coming to the type of healing. So, as Dr. Namrata was saying, that we have to be very careful and see how the healing is taking place. Is it a protracted or a delayed kind of healing, or there is some abnormal scarring? So, this points towards the defect which is in the fibrinolytic or the fibrinogen deficiency. Now, as we move on, so let us start clinically. What are the important causes of coagulopathy? As my today's audience are mainly the postgraduate students, so I would like you to be attentive and remember what are the more important causes of the coagulopathies. So first is DIC. Now, DIC can be the complication of spectrum of all these disorders. You can see immunology, malignancies, pregnancy, sepsis, trauma, etc. And there are expensive, abnormal, massive clotting as it starts the process. So either there may be vascular occlusion because of the clotting, so it may culminate in tissue hypoxia, which may lead to the organ failure. And finally, this is the pathogenesis of sepsis-induced coagulopathy or DIC. Sequential organ failure assessment we do in sepsis-induced coagulopathy. We will see it later. And once there is consumption of the clotting factor, usually manifests with bleeding, and this is the pathogenesis of non-sepsis DIC. So basically, we have two kinds of DIC. One is sepsis-based, and the one which is independent of sepsis. Now, as you see the figure on your left, you can see the hemorrhagic manifestations in DIC where there is bleeding. The figure on your left shows a gangrene in the foot, which is a result of the occlusive complications. Now coming to sepsis. Sepsis is the widespread inflammatory response to any kind of infection. And this slide is very important, so I would like to draw your attention. So all the inflammatory cells which are involved, like the monocytes, platelets, neutrophils, etc., they all release tissue factor, which is the initiator of our extrinsic pathway. Also, the the endothelial cells liberate the tissue factor whenever there is some injury. So what is the result? A hypercoagulation stage is set in, which moves into the sepsis-induced coagulopathy. That is the initial phase of DIC. This is also known as the non-over DIC, or we call it compensated DIC. We will see and come back why like that. And once there is no treatment, this quickly progresses to over DIC, or we call it as supportive decompensated DIC. So studies are going on to see if at this phase where there is hypercoagulation, these anticoagulant therapy, natural anticoagulants are of like the heparin, antithrombin, thrombomodulin. This the reason being, if we are able to give the treatment at this stage, the hypercoagulation phase, we can reverse the sepsis-induced coagulopathy and it will not progress to over DIC. So once the over DIC sets in, then nothing can be done. Only supportive therapy is the mainstay. So moving on, I would like to pay attention, bring your attention that COVID, which we faced last few years, is also an important cause of acquired coagulopathy, and it also leads to sepsis and finally DIC. So I have a original article which we did in our hospital on 391 patients, and it was a very good study from the Indian setup. Now coming to the score, now why SIC is important. Previously, the International Society of Thrombosis and Hemostasis had given criteria to diagnose DIC, but of late in 2019, the society has introduced the criteria and the scoring for the sepsis-induced coagulopathy. The reason being, as I told you, if we can stop it at that level, it will not progress to over DIC. So let us see what are the scoring systems. It is based upon certain parameters, and according to the values of these parameters, the scoring is given. So for sepsis-induced coagulopathy, it is the platelet count, the PT-INR ratio, and the SOFA score. What is SOFA score? It is sequential organ failure assessment, and it is a cumulative score of SOFA of four organs, the major organs, the cardiovascular, the respiratory, the hepatic, and the renal. So total score the clinician gives, it is a clinical score. If the total SIC score is more than 4, the lab personnel will inform the ward doctors and the ICU doctors that the sepsis-induced coagulopathy is on. While in case of DIC, the parameters we choose is platelet count, same like that, fibrinogen degradation products or D-dimers, fibrinogen, and the prothrombin time. And for DIC, the score is more than 5. So once DIC sets in, it is all over. So let us have a quick look at this case. A 10-year-old female child, she presents with spontaneous gum bleeding and fever for 5 days. Breathlessness, body aches are present, moderate pallor is there, sternal tenderness and hepatosplenomegaly is present, but there is no lymphadenopathy. So what is the CBC looks like? CBC shows pancytopenia. However, the promyelocyte count, as you can see, is 60%. The APTT is prolonged, thrombin time is also prolonged, and the D-dimer results are more than 0.5 nanogram per ml. So any clue? Anybody? Very good. So this is a typical case of APML. So once we do the flow, we can see the blast window here with the APML blast, the hypergranular promyelocytes, and the peripheral picture shows the hypergranular promyelocytes. So now, what is the therapeutic approach in DIC? So DIC has to be treated based on the underlying cause. As I told you, it affects many things. So we will give platelet transfusion if the platelet count is low, or cryoprecipitate can be given if there is evidence of hypofibrinogenemia. Prophylactic low molecular weight heparin can be started if there is evidence of venous thromboembolism. Fresh frozen plasma can be given if clotting time is prolonged and there is overbleeding. However, if there is chances of fluid overload, we should switch over to prothrombin complex concentrate, which is a concentrate of factor 2, 7, 9, and 10. However, the role of natural anticoagulants, as I told you, it is still under debate. Now, having learnt about DIC, the next important cause for our coagulopathy is the liver disease. So we all know the liver is the site of synthesis of the pro-hemostatic and the anti-hemostatic factor, and it plays role in all the three phases of hemostasis, the primary, the secondary, and the tertiary. So whenever there is liver disease, what will happen? All the factors which are released by the liver will come down. But there are certain factors which are produced by the endothelial cell. So we say that there is a rebalanced hemostasis whenever there is liver disease. It has been seen that in ICU patients with liver disease, one-third of the patients die because of acute liver failure. And of note, the cirrhosis patients, it has been seen that they start with new bleeding. Prolonged PT time is a new identity. It indicates isolated prolonged PT may point towards a poor prognosis in these cirrhosis patient. So as depending upon the balance, so it may be either the clotting or the bleeding manifestations. So the vitamin K, the next important cause of acquired coagulopathy. So whenever we see a neonate with any kind of bleeding disorder or coagulopathy, it is vitamin K deficiency. The reason is obvious why the neonates it is more common because it doesn't cross the placenta, neither it is secreted in the breast milk, and the values, adult values are not reached before 6 months of age. So what happens? The treatment is either we give oral dose or vitamin K injections. So here I would like to tell you one thing. In adults, although the vitamin K deficiency is uncommon, it is usually seen in cases of malabsorption and in case of oral antibiotics. We have a new marker for hepatocellular carcinoma, which is protein in, uh, protein induced vitamin K. What is that? I'm sorry for. I'll just get back. Now the case, we see this case, a 1-year-old male child presents with the spontaneous ecchymosis following the intramuscular injection for past 10 days, and he has a premature birth history. Otherwise, there is no any history of joint swelling or fever, etc. Examination reveals only the ecchymotic patches. The investigation normal CBC, but the APTT and the PT is prolonged. So a vitamin K injection is given and the child comes back with the normal PT and the APTT values within 72 hours. So this is the case of the vitamin K deficiency. Massive transfusion also commonly seen in our regular clinical practice. So usually it is dilution of the plasma and the platelets. It is dilutional coagulopathy. So increased concentration of the anticoagulants and depletion of the plasma and calcium. So how do we treat a case of massive transfusion? We give cross-matched ABO-RH compatible blood. Also, we give fresh frozen plasma to maintain the PT and the APTT values within 1.5 times normal. Platelet transfusion is also given to maintain the platelet count above 50,000, and it is started when the count starts coming to 75,000. Fibrinogen count is maintained, level is maintained by giving the cryoprecipitator. The fibrinogen level has to be more than 1.5 gram per liter. So having learnt about all this, pregnancy is also a very important cause. Sir has taken in detail about the APLA. So it is a physiological change in the normal hemostatic process, and pregnancy is a procoagulant scenario. So the procoagulants are increased. This hypercoagulation, there is venous thromboembolism. But always remember in pregnancy, the mortality and the morbidity is because of the obstetric hemorrhage and not for the venous thromboembolism. So how do we manage the case? We have to reduce the bleeding in the labor room by oxytocin, B-link sutures or intrauterine balloon tamponade. We assess the hemostatic failure by the routine primary first line test, CBC, etc. Thromboelastometry is now the point of care in our labor room and ICU patients and even in the wards, which can help us immediately diagnose the cause of the bleeding or the coagulopathy. Fresh fibrinogen level, if it goes down below 2 gram, it indicates postpartum hemorrhage and fresh frozen plasma have to be administered immediately. And of course, the platelet count and the fibrinogen level has to be maintained. Moving on to the acquired inhibitors of coagulation factor. So factor 8 is a known factor for hemophilia, deficiency of factor 8. But however, when these patients are treated with factor 8, they may develop autoantibodies and factor 8 inhibitors might come into play. So there is increased frequency of these patients, and when lab test is done, APTT is prolonged. So, but when mixing studies are done, we see that the immediate correction is obtained, but after 2 hours of incubation at 37 degrees, there is no correction. The reason being the factor 8 inhibitors are time and temperature dependent. So quick look at a clinical scenario. A 35-year-old male presents with spontaneous swelling of the right sacroiliac joint. Family history of prolonged bleed is also present. Earlier, the patient was responding to factor 8, but now he is not responding. So CBC and the coagulation tests were done. So the findings reveal that the mixing study is showing less than 50% correction and the factor assay shows less than 1% of the factor 8. Also, the PT and the APTD is prolonged. So what is the diagnosis? Anybody? Mixing studies shows less than 50% correction. Factor 8 levels are also very low. So it is hemophilia A with inhibitors. So what is the main line of treatment? FIBA, as we call the factor 8 bypassing agents, is the main line of treatment for factor 8 inhibitors. We use recombinant factor 7 and activated prothrombin complex concentrate, which will directly activate the factor 10A bypassing the level where factor 8 activation is required. But the main side effect of this is thrombosis. So to combat this thrombosis, because so fast the factor 10A will be activated, quickly thrombosis will be formed. So it is immune tolerance induction. In this, what we do, we give high doses of factor 8 either regularly or on alternate days of a week, low dose, for about 12 months. The level of the factor 8 are raised to that extent that it cannot now it can easily dilute the level of the factor 8 inhibitors. And if the level of the factor 8 inhibitors are less, we can also treat the patient with desmopressin. So this was important, the treatment of factor 8 inhibitors by FIBA. The next important factor deficiency is factor 13. So it is also autoantibodies which are developed against the factor 13 and underlying causes are there. The first line screening test will be normal. Only the clot solubility test will be abnormal. Once the factor assays are done, we see that factor 13 is positive. So this was a discussion going on when my slides was getting ready, that what is the difference between this primary fibrinolysis, as ma'am said, and the difference, how do we differentiate it from DIC when a stable fibrin clot is formed after the factor 13 has acted on it. So here the euglobin clot lysis time will be markedly shortened, while in DIC it is normal or shortened. And of course, in DIC, it will be accompanied by low platelet count, antithrombin levels low, and the D-dimers levels will also be positive in case of DIC. So this will help us differentiate whether the cause of these fibrin degradation product is because of the DIC or a step earlier before the factor 13 has acted upon it. So moving on to the acquired von Willebrand disease. Yeah, just 2 minutes. So this is also a very common mimicker of hemophilia A and factor 8 inhibitors. Dr. Namrata has already discussed in detail about it. So International Society of Thrombosis and Hemostasis has also given guidelines to manage the case of von Willebrand disease. So moving on to one very important aspect in our clinical scenario is the directly acting oral anticoagulants or vitamin K independent vitamin oral anticoagulants. These drugs act at the level of factor 10A and the factor 2A. So the famous drugs here are the dabigatran, which acts at level 2A, rivaroxaban, apixaban, and edoxaban at the level 10A. Remember, this XA is 10A here. Also, the heparin, after binding with antithrombin, acts at these two levels. So the vitamin K dependent drugs are the warfarin and aciclovir. These are also very powerful anticoagulants, and once the overt bleeding sets in, the treatment is by vitamin K and the prothrombin complex concentrates. Antiphospholipid syndrome I will not touch because sir has already told you in lot of detail. You must remember that acquired deficiencies may also arise because of the protein S, prothrombin, and factor 5 deficiency, which are also very important part of the coagulation cascade. Of course, amyloidosis and heparin-induced thrombocytopenia should also be there at the back of the mind because these may also cause acquired coagulopathy. So finally, now we move, how do we approach a case of the coagulation disorder? So we know, as Dr. Namrata elaborated, the picture of DAISY, the first line test, if all these are normal, then no issues, but anything abnormal, you go for first thrombin test with replicase to rule out heparin infusion, and correction and mixing studies are done to look for the factor deficiencies and the inhibitors, and then the factor assays can be done. Platelet functional analyzer is not yet validated, so in that case we use the thromboelastometry, which is a point of care. Just a quick look how the graph in thromboelastometry comes, and this gives you a clue whether what exactly the bleeding disorder or the coagulation disorder is. Because the first line test takes time and that time may be long before the results are sent to the ward. So the type of test we already know, I will not speak about it. See, these are the screening tests, and the definitive test will be followed by the correction studies, the factor assays, the inhibitor screen, platelet function, abnormalities, von Willebrand assay, family studies, and genetic studies. Also, the thrombophilia profile may be looked at for these parameters: protein C, protein S, factor 5 mutation, and prothrombin gene mutation, as well as the lupus anticoagulant. So finally, the takeaway message, as Dr. Namrata also said, and I would also reiterate it, that this is the detailed physical examination and a clinical history will give us a clue about the type of the coagulopathy, whether it is inherited, whether it is acquired, which component of the coagulation cascade is involved. And based on that, we can proceed for the lab test, starting with the screening test, and any abnormality we detect, it goes for the specific diagnostic test. Thank you for your patient hearing. I'm sorry for the technical glitches.
Thank you, ma'am. I would request Dr. Noorin ma'am to please present a memento as a token of appreciation to Dr. Sujata ma'am. I would also request Dr. Brigadier Bhushan Asthana sir, consultant hematopathologist, administrative appointed to AMC Center and College, to please join Dr. Noorin ma'am on the dais as chairperson.
So very good morning to all. Thank you to Dr. Lakshmi for inviting me to share this session, and I really feel honored to be inviting the next guest speaker, whom we've all been eagerly waiting to listen to, and who's been a teacher to all of us for so many decades. Without wasting even a single minute, I want to request Dr. Sukesh to please come. Thank you for listening.
Here, obstructive. This is the USB drive, no? Huh? This one, sorry.
So you will copy all the presentations?
Yeah, all. Please copy.
सारे presentations just copy कर दो सर के नाम से
Yeah, thank you. Thank you, Dr. Bhushan. Nice to see you in uniform. I've never seen you in uniform before. You look very smart. I think smarter by your shoes also. You're wearing a very smart dance shoes. It's called the, the mochassino type shoes, I don't know whether RB allows you to wear that. Dr. Tathagat can verify that.
This is Brook.
Yes, that's right. Okay. Yeah. So that adds to your smartness, but anyway, you're otherwise smart too. So, obstetric hemostasis is not hemostasis. It is far beyond our understanding, and therefore, management of obstructive hemostasis is absolutely a different understanding than what you understand about hemostasis, because our intrinsic, extrinsic pathway, McFarlane, Oscar Ratnoff doesn't play any role there. So I have got a 22-year-old diagnosed to have acute fatty liver pregnancy. After so many of transfusion, she is finally considered to be no longer coagulopathic. Her PT is 12.1, her APT is 28. her fibrinogen is 145, her hemoglobin is 9.1, and platelet count is 65,000. Good for any type of hemostasis, but she was continuing to still use from the uterus. So issue is, after so much of clinical management, did we create another coagulopathy, or why are these tests not reflecting clinical bleeding? So you must realize one thing: pregnancy is a totally different physiology. The hemostatic factors that exist in pregnancy at a level which are not even covered by reference ranges of normal human beings. There is increase in certain factors, there is decrease in certain factors, but you must realize one thing: all these are being created to protect the mother, maybe at the cost of the fetus, but to make sure, because in this whole process, the only person who is put at risk of close to death is the mother. So all this physiology is created to protect the mother. All the coagulation factors changes just to protect the mother. So we know that we know that maternal mortality rate in most of the countries, which is considered to be a government marker of performance, is mostly caused by postpartum hemorrhage. And most common cause of postpartum hemorrhage is usually uterine atony or trauma, not DIC. Generally the obstetricians love, moment they see extra bleeding, they say DIC ho gaya, DIC ho gaya. No, certain conditions like abruptio placenta can consume factors, and maybe coagulation factors can be abnormal. But DIC is usually seen in pregnancy when there is something like amniotic fluid embolism. Otherwise, very rare. We know that whenever a patient bleeds, we send hemoglobin, platelet count, PT, APTT, and fibrinogen in well-established places for monitoring patients when they bleed. But we must realize that hemostatic impairment, though may develop in PPH, in majority of the cases, these conventional tests are bang normal. They have limited sensitivity to bleeding in postpartum hemorrhage. And studies have shown that PT, APTT, fibrinogen remain normal. I'm talking about adults reference ranges, till the patient has more than the whole body volume of blood loss. That's 5 liters. That is when all the interventional factors come in and start making the test abnormal. We all know that though we talk about primary hemostasis, platelet, von Willebrand's factor, we talk about intrinsic pathway, extrinsic pathway. The most important, the first hemostatic step that happens when there is injury is vasoconstriction. That actually helps the rest of the steps. First of all, it slows down the blood rate, and it also helps the coagulation factors, gives time for the coagulation factors to function appropriately. Now, following the expulsion of placenta along with the residua, we are exposing the myometrium and the blood supply in the myometrium under the placental blood. Here we are talking about different physiology. Vasoconstriction is created by smooth muscles. Now, in this scenario, once the placenta comes out, we don't have any equal of hemostasis in the world as we know vasoconstriction in blood vessels. We know that uterine myometrium has a spiral arteries. Once the fertilized egg is embedded, the spiral arteries undergo change, hormonal changes. Slowly they lose their smooth muscles. They do not remain arteries anymore. Arteries are luminal vessels with smooth muscle. They don't have any walls. The spiral arteries do not have any walls. So there is lots of smooth muscle, there is lots of elastic lamina. So vasoconstriction, forget it. And there is lengthening and straightening of the spiral arteries. And these spiral arteries undergo 5 to 10 times dilatation when the process of uterine development for pregnancy, for the placental insertion happens. Now you must realize once the placenta comes out, the area and the number of such mouths, which is dilated spiral, X spiral arteries without any walls, is going to be exposed for blood flow, is absolutely like putting on a shower. Shower is a small example. Maybe hundreds of showers, putting it on, until you want to put it off, it is not going to stop. The only way still, it is the smooth muscles, but not blood vessel smooth muscles. It is the uterine smooth muscles which come into the play here. The tone comes back, the uterus contracts, and during the first contraction, it helps vasoconstrict or whatever it is, whatever is dilated, it gets constricted. Now here the intrinsic and extrinsic pathway don't come in. It is straightforward tissue factor, fibrinogen, and it's like, almost like giving a whopping dose of recombinant factor 7A at the site of uterine blood vessels. Because there's so much of tissue factor in all those, the syncytial trophoblast, all those, they're rich in this thing. So they straight away generate thrombin, and there is a lot of fibrinogen, there is a lot of von Willebrand's factor, and there is a lot of factor 30. Only these help stop something, but one contraction is not enough. It needs one more contraction, and probably after the third contraction, the bleeding actually will stop. So there is no factor 8 here, there is no factor 9 here, nothing else. There is no factor 5 here. It is just tissue factor, fibrinogen, factor 13, and all that. So I have personally experienced a condition where the fibrinogen can drop from 600 milligrams per deciliter to 300 milligrams per deciliter in matter of 5 minutes. 5 minutes when the uterus contracts. So what is postpartum hemorrhage? We all know the definition. I don't want to go through that. So we must realize that fibrinogen levels can fall rapidly when the bleeding stops. Like I've talking about 600 to 300, definitely 30 minutes is what is published, but I have seen it personally in 5 minutes. And there is strong evidence that low fibrinogen measured by von Closs method, very clearly the publication mentions, measured by von Closs method, is an accurate marker of progression from moderate to severe postpartum hemorrhage. Not even thromboelastomer. Because at 200 milligrams per deciliter, any test is normal. PT is normal, APDT is normal, thromboelastogram is normal. So it is only measurement of fibrinogen levels by the right method will tell you that more than 200 is safe for the child, for the lady. And we know that if it's, the publications have shown that if it's less than 200, it's a positive predictive value of 100% to progression to severe PPH. And a level of more than 400 is a negative predictive value of 79%. A similar result was reported in another study where fibrinogen of 200, less than 200 milligrams, at an average of 4 hours after start of PPH was an independent predictor of 4 hours. Progression to the need of an invasive procedure like iliac artery ligation, hysterectomy, and admission to level 3 nursing. So therefore, the focus on management of postpartum hemorrhage is fibrinogen, fibrinogen, and fibrinogen. Never let it less than 200. Now, interestingly, when this data came out, the developed world saw fibrinogen concentrate. So people straight away started developing data on fibrinogen concentrate. Our world, if we are lucky, is cryoprecipitate. So by the time fibrinogen became important, studies on cryoprecipitate never happened. So I think it is for us to develop that data. So we have also noticed that fibrinogen concentrates are available in our country through Make in India as well as not Make in India. And we find that the cost which is recommended by the government for cryoprecipitate, a dose of cryoprecipitate for fibrinogen and fibrinogen concentrate is definitely more expensive, but the cost is only about, I calculated, 1.5 times more. Dr. Verma, you can verify that. So it's 1.5 times more. A full dose of fibrinogen to achieve a level of hemostasis. So management of PPH is basically monitoring administration of fibrinogen, timely red cell transfusion. So they all, there's a group that comes from, mainly from UK, Wales, which says that there should be a talent in how to estimate blood loss. So a lot of studies have come, and this one particular study is the evaluation of blood transfusion rates by estimation of blood loss. So quantified estimation of blood loss versus estimated blood loss, looking at what is happening. And many studies have shown that it doesn't make a difference. So this study had a lot of variables, but at the end of it, I'm not going into the statistics of this, but the end of it, though the quantified blood loss transfusion was lesser than the estimated blood loss, it was not statistically significant. And they found that when somebody gets involved in quantitative blood loss, the patient going in for postpartum hemorrhage or progression to postpartum hemorrhage is slightly higher. So sometimes it is good to listen to the bedside person rather than looking at the values that come on your test tubes. So clinicians should be aware that blood loss calculated by quantitative measurement can be higher compared to that of visual estimation. Though the amount of blood loss during cesarean delivery is a strong predictor of receiving blood cell transfusion, it should not be used exclusively without consideration of the entire clinical picture, including presence of risk factors, symptomatology, vital signs, and preoperative and postoperative laboratory tests. So yes, we only look at laboratory tests, but good to take the phone call, talk to the anesthetist who is probably available to talk, and understand the rest of the picture so that you can help manage the patient. Because you must realize the clinical scenario is going to be different when you have the results in your hand. 1 hour, maybe, if you're the most efficient lab, 30 minutes. 30 minutes is still too long for clinical picture to change. So when they send the blood samples, the clinical picture when you get back is not going to be the same. So it's good to take a phone call and understand the clinical picture. Okay, is there something else that we can look at? D-dimer is something we talk about in pregnancy because pregnancy has got high rates, and we say that pregnancy is a hypercoagulable state. The cutoff for D-dimer is going to be higher in pregnancy, and therefore can D-dimer be able to identify postpartum hemorrhage? Because postpartum hemorrhage is involved in managing thrombin, though the thrombin is not helping, but it's still producing thrombin. So this study looked at D-dimer. We know that incidence of DVT is estimated to be higher in pregnancy, which is 4 to 5 times higher than non-pregnant population. So what is the role of a laboratory hematology in venous thromboembolism? Not only to identify risk factors, like we do the thrombophilia workup, identifying individuals who are at a higher risk of recurrent thrombosis or rethrombosis. That is something which can make a huge difference in the life of a physician who manages patients' anticoagulation. Monitoring antithrombotic therapy, and of course providing useful ancillary data like D-dimer at initial diagnosis. We know that thrombophilia workup is very fascinating for all of us, but to the patient and patient management, it's very of small benefit. If somebody calls me and asks me that, can I send the patient to thrombophilia? I discuss and somehow counsel them out of thrombophilia. But if somebody wants it, I will never deny it. Because it gives some, it's the most expensive of the coagulation tests we have, but I don't deny it. We know that if a clot is formed, thrombin is generated, and the best product of thrombin is nothing but D-dimer. Though we know that D-dimer is also a product of plasmin, unfortunately, in our studies, we always consider D-dimer as a product of thrombin, a plasmin, not of thrombin. Yes, D-dimer will never be produced if thrombin was not never produced. A lot of FDPs will be produced if plasmin is produced, but D-dimer will never produce if thrombin is not produced. So D-dimer is a unique marker of thrombin generation, and it's a very good thing because it can be done a short time, little effort. It can be cheap if you can make it cheap. It's very sensitive and allows for specific identification of patients. This is a paper which changed the future of D-dimer completely, which was published in 1991 by Henry Bonomu from Switzerland, where he said that this test is the best negative predictive value for venous. And this is a study done on patients with pulmonary embolism. Cutoff of 500, you can rule out. Less than 500, you can rule out venous thromboembolism. Of course, there are many methods to identify. It's sometimes good to discuss with your bedside physicians about your test, because tests are not going to be same in one place to the other place, because D-dimer uses different epitopes, different types of performance specification. So sometimes it's better to talk to them to make D-dimer a more effective tool. And also the type of values that COVID of course revealed or educated a lot of physicians on what is the value of D-dimer, whether it's 500 or 0.5. That was a big confusion. I'm sure all of you must have had calls from your physician and pediatrician colleague, and one question would have been asked: what is the reference range for D-dimer? And I'm sure you would have answered, there is no reference range for D-dimer. D-dimer has only been used for cutoff value. There is no publications on reference for D-dimer, and the one or two publications, they just abruptly stop the reference range and give it as 250. Bus. Me and Joy we thought that we are a good lab, we should have our own reference range, and we did a reference range for D-dimer. It was so pitiable that we ignored the whole data. It was not even going beyond 50. And our cutoff is 500. So we said 500 is cutoff is good enough. Let's forget the reference range. So reference cutoff is much better in D-dimer than reference range. And in pregnancy, a compromised cutoff from 500 can go to 600, but that's a huge compromise. There are many studies which take the cutoff to 1,500, even up to 3,000 for venous thromboembolism. Now, how many of you do D-dimer? How many of your clinical colleagues, not clinical colleagues, physicians or pediatricians call you and say, I have got a patient with thrombosis. You ask them, D-dimer कितना है? D-dimer तो वैसे भी ऊंचा होगा, नहीं लेकिन कितना है? They will never do a D-dimer. So why is not D-dimer done very commonly in our country? We are not talking about pulmonary embolism, even physicians miss, so that's all right. But deep vein thrombosis, the obvious signs of deep vein thrombosis, nobody does D-dimer because ultrasonography is easily available. One guy will come in a motorcycle with a portable ultrasound and do a Doppler for you and go. Whether you will be able to give a good D-dimer solution for them? No. A good D-dimer requires a good analytical system. CAR test will never work. So reliability of D-dimer has come down because of compromised test, and availability of radiological investigations widely in our country has been the main cause of D-dimer not being available. So I thought that let me use COVID to maximize the availability of good D-dimer. The amount of D-dimer, good quality D-dimer that was sold in our country went to more than 1,000 tons. Only good quality D-dimer. Whether it was Abbott's Alpha, whether it was Siemens, Sysmex, whether it was Burfen, whether it was Tego, whether it was BioMerio, all good quality D-dimer was being sold. 1 year after COVID, all the labs returned back their devices. So it's a bad story. D-dimer, we must have always told about the D-dimer after stopping anticoagulation. 1 month after that, you do D-dimer. If it's more than cut off, it's better to put the patient back on anticoagulation. But there was a study which was done over 10 years in Denmark, not Denmark, it was Denmark, yeah, Norway, which showed that, leave alone, in Europe, patients are not very happy about going to hospital. So 1 month after stopping anticoagulation, going to hospital, it's a pain for them. Okay, let's look at when they present with thrombosis, what's the significance? So they looked at the study that if a patient presents with venous thromboembolism to a hospital, what is the D-dimer and significance of the D-dimer? And they found that those people who have got less than 1,500 compared to those who have more than 1,500 have a lesser chance of recurrence. This was a fantastic data. At presentation, if the D-dimer is less than 1,500 or 1.5, we use a different this thing, the chance of recurrent thrombosis or rethrombosis is very low. And those who get more than 1,500 may benefit from prolonged anticoagulation. Prolonged means slightly prolonged. I'm sure Dr. Verma must be facing a lot of patients who may have requirement only for 6 months to 1 year anticoagulation, but they have been left by their physicians on lifelong anticoagulation because nobody had the guts to stop it. So you cannot do with D-dimer, without D-dimer. D-dimer is a very important test. So this study was looking at utilization of D-dimer in predicting postpartum hemorrhage. So there they looked at this particular data and they had about 7 patients out of 278 pregnancies who had venous thromboembolism, of which 2 were twin pregnancies. And we know that twin pregnancies have got a higher chance of venous thromboembolism. So since twin pregnancy is generally reported as one of the risks for DVT, comparisons with singleton and twin pregnancies were analyzed. Age, hemoglobin, hematocrit were significantly higher in singleton pregnancies. Incidence of recurrent history of ART, hospitalization due to threatened premature labor, D-dimer levels, and PPH were significantly higher in twin pregnancy. And blood loss by PPH in pregnancies was twice that in single pregnancy because of possibility of uterine smooth muscle laxity. And they found that a cutoff of 2.6, which is 2,600, may be a better marker for ruling out venous thromboembolism when they looked at other levels of 1.9 and 2.9. And D-dimer levels at 34 to 37 weeks of gestation was positively correlated with postpartum hemorrhage during cesarean section. However, this relationship disappeared after excluding twin pregnancy. So previous reports demonstrate by univariate analysis that severe PPH is associated with higher D-dimer levels during pregnancy, but this relationship disappeared in singleton pregnancy in this study. Although no significant relationship between D-dimer levels and PPH was confirmed, D-dimer levels tended to increase along with increased blood loss. Further examination will be needed to clarify the relationship between D-dimer levels and PPH levels. This is very, very significant because, if fibrinogen is the culprit, D-dimer is a product of not only thrombin, it's also a product of fibrinogen, factor 13 also, and plasma. So D-dimer may have, we could probably use this as a marker for getting D-dimer back into a good go. D-dimer elevation is thought to reflect enhanced fibrinolysis, consumption of fibrinogen, and this is the main mechanism to explain the correlation between D-dimer and postpartum hemorrhage. So in conclusion, D-dimer and long hospitalization are independent risk factors for DVT. However, in the study, the later lost statistical significance in the case of singleton pregnancy, but we also know that it increases with advanced gestational age, and this increase is more than evident in twin pregnancy, but if you use a higher cutoff, you are there. Although the increase in D-dimer level by DVT may be masked by physiological increases, but using a cutoff of 2.6, you are going to overcome that. As for PPH, D-dimer level in twin pregnancy seem to be a risk factor. Yes. That's one of the conclusions of the study, D-dimer and twin pregnancy. So we should pay attention not only to DVT, but also to severe PPS, especially in twin pregnancy with elevated D-dimer. Thank you very much. I can take questions.
Thank you, sir.
Yeah, he's senior to you. He can overtake.
Just
He's in uniform, sir. So.
May I quickly? So there's always so much of learning, and the way you highlighted these important points over the time was really is to know. Yes, we can start off with the question.
Thanks, Mudal. As usual, it's lovely meeting you after so many years. As usual, thought-provoking talks.
Thank you, sir.
For example, the young faculty should now sincerely and seriously look at it and get it back to its lost students. So, we have been doing a lot of massive transfusion protocol without scientific basis.
Yes, sir.
And we are creating TAPO, transfusion associated circulatory overload,
yes,
for no rhyme reasons.
Yes.
Now that we all know that the basis and the fundamental of MTP would be fibrinogen, what is your design as of date of the bricks we involved between the operation theatre and the blood bank, and the smooth transition of these bricks to enable the massive transfusion protocol as per checklist which I think we want your recommendation on this.
Okay, sir. That's a very important point that you brought up, and we have been promoting this concept of fibrinogen, and therefore also the fact that not mostly promoting fibrinogen, but the concept of shock packs. In shock pack science comes from predominantly trauma-driven science, not by PPH. And in shock packs, FFP play a major role. And you must realize that FFP's average fibrinogen is 150. The ladies 600. You're going to dilute out her 600 to 150. So thing is, we have very clearly, whenever we get a chance, we say that FFP is a killer in pregnancy. Okay. So now the data is predominantly on fibrinogen, no data much on cryoprecipitate, because by the time fibrinogen became important, fibrinogen concentrate came. Okay, so now we need to promote cryoprecipitate. Maybe whatever study exists, or do fresh studies. That's another issue. But the issue is that having fibrinogen is, thing is, in my center, no issues. Because, we talk about transfusion, massive transfusion protocol is basically shock packs, which is unmonitored transfusion of blood and blood products, unmonitored. But in our institution, I think after the first set, we have monitored transfusion. It's very rare that we have unmonitored transfusion, but that's not the case in most of the places. Now, most of the places don't do fibrinogen. Okay, so now after our intervention, Tamil Nadu government introduced coagulation analyzer which can do fibrinogen. They're not interested in the fibrinogen. The coagulation analyzer do PT and epilepsy, but they make sure that all coagulation analyzers should do fibrinogen. Good, it was a big victory. But there were only 2 blood banks in whole of Tamil Nadu which could make cryoprecipitate. We have a long way to go. But thing is, the encouraging fact is that the cost of fibrinogen concentrate over cryoprecipitate is not too much. So I think we have to depend on abilities of Dr. Verma like people to promote the use of fibrinogen concentrate. I am promoting. And therefore, in PPH, as part of the massive transfusion protocol, fibrinogen concentrate has to be a part of it.
So you give it upfront?
Upfront.
1:1:1, and then upfront fibrinogen.
Absolutely. Okay. Without FF. Yeah. Because sir, in PPH, as you know, the coagulopathy doesn't anyway exist. It's just the atony and supporting it as long moment the contraction comes back.
Chairperson's intervention, I mean, this is one of the very, very important feedback which this coagulation update should take. So, stressing on the tetanus aspect and the fibrinogen aspect, because we are wasting so much of lives with this circuit overload doing nothing. Thanks. Dr. Savitri, please.
As you said, because of COVID, we had started fibrinogen as part of that COVID. Some people were doing some studies, and at the end, this D-dimer also. After COVID got over, people published their work, whatever, and we were left with only FBG in our lab. And so far we have been doing, and suspected HLH also they may ask. So now my question is, at times we get cryo and as well as FFP for QC as a part of blood bank. So we would get 670, 850, and suddenly one of the cryo would be having 325 or something. So is there any cutoff that what we must expect if that cryo tube is well, put into fluid and 37 and sent to lab within time frame, or if there is 3-4 hours left and then we are doing tests, so we may be reporting less.
So, Dr. Savitri, that is a very important point because you are doing quality control for the blood products. Though compared to factor VIII, there is not much of correlation between blood groups and fibrinogen levels. But just making a simile with factor VIII, whenever we have this problem of postpartum hemorrhage, we don't give them O cryoprecipitate. That's all.
So we don't have that.
No. So the thing is, as I said, this data on cryoprecipitate is not as mature as the data on fibrinogen, because of the fact that by the time this information came, fibrinogen concentrate was available.
So if given chance in a case of AFib
But it's a small volume, doesn't matter. If it's 325, doesn't matter.
Cryo can be utilized.
Yeah.
If it has got FBG, good enough.
Yeah.
So I have a question, sir.
Yes, Dr. Nanda.
So in the ICH DIC scoring, there is this D-dimer FTP level showing moderate increase and severe increase. So what is moderate and what is severe?
They don't give the levels, no?
Exactly.
Yeah. From the time of Jack Hirsch, who was the first chair of the DIC subcommittee, which was probably 40 years back, they have still not given the levels. So I somehow forced Jeko Tachil's boss, that is Seat Talk, who is from Manchester or Liverpool, whichever. So he used 250 as a level. 250 and more is moderate increase, 500 and more is severe increase. So 250 is a cutoff for DIC, 500 is a cutoff for VT. I mean, that is not published.
Okay, sir. So we are not talking about in respect to cutoff of 500. We are not saying that after 500.
No. It's 250. It's not 500. 500 is, 500, nobody, the moment you say 500, we are talking about VT. We are not talking about DIC.
I think there are no more questions. So thank you so much, sir, for your patience. Thank you, sir.
Thank you, sir. I would request Dr. Sukesh Nair, sir, guest of honors of today's event, to please present the memento as a token of our appreciation to the chairpersons of session 1 and session 2. Dr. Surbi Gupta, ma'am. Dr. Noorin Zedi, ma'am. And Brigadier Dr. Bhushan Asthana, sir.
Thank you, sir. What an honor. Thank you. You're not enough now. Oh, great.
After so many informative and educational lectures, I request everyone to proceed for a short 10 minutes tea break. Thank you.
अच्छा उनकी टीवी कॉपी कर लीजिए पहले तो वो पीडीएफ देख इसमें मिलेंगे ना पेन ड्राइव यही है सबका यही है खोलिए खोलिए कर लिया कहाँ किया नहीं सिर्फ ये वाला सारे पीपीटी में कह रहे हैं पूरा फोल्डर का कॉपी कर लीजिए वो है एक पीपीटी का बीच वाला पार्ट जिसमें बोलना बोलना है ना, जिसमें बोल रहे थे ना वो सब सारे 6% से
Welcome all. I welcome all of you back from the tea break. Now I would like to invite chairpersons for the session 3 on the dais, Dr. Vijay Tilak sir, Professor, Department of Pathology, BHU, Dr. Milijan ma'am, Additional Professor, Department of Pathology, KGMU, and Dr. Namrata Vasti ma'am, Professor, Department of Pathology, RML Lucknow.
So a very good morning to all of you. It's my proud privilege to introduce to you Professor Yasmina Aluwalia. She is professor in the Department of Hematology, and her area of interest is in coagulation disorder. In fact, if we talk in India, there are two persons who are considered to be authority in coagulation. One is Professor Suresh Nayak, and another is Professor Yasmina Aluwalia. I request her to give us a talk on bond.
Good afternoon, everyone, and a big thank you to Dr. Rashmi and her team for this honor of standing here in front of you and talking about something which I really like, which is von Willebrand disease, the lab diagnosis. So we're going to talk about bleeding clues which lead to the laboratory diagnosis. There are many here in this audience who are very familiar faces and who have heard this before, so my apologies to them. But it's such a disease of which we know very little about while we are in our student days, so it's no harm hearing things again. So von Willebrand disease is a bleeding disorder, as you all know, which is characterized by a qualitative or a quantitative defect of von Willebrand factor, and this may be congenital or acquired. When it's acquired, we call it acquired von Willebrand syndrome. The prevalence is very high in the population, but we don't get to see so many patients in the hospital. Possibly because of a referral bias, we see only the very severe cases in hospital, whereas the mild ones are there in the population who do not report with gain. It's a big protein which is synthesized by the endothelial cells as a monomer. They form dimers and then finally multimers and are stored in the Bibelpalladi bodies of the endothelium. And after that, they are released into the circulation. This huge protein has to perform a number of important functions, especially in primary hemostasis, where it is important because it recognizes the GP1B alpha receptor on the platelets for platelet adhesion at the site of injury. And it can also adhere to the collagen, which is exposed when there is injury to the vascular endothelium. Other than this, it acts as a carrier of factor 8, and if there is no von Willebrand factor, then factor 8 will disappear from our circulation in no time. There are some other functions which it performs, but they are not relevant to today's talk. So if we are to diagnose von Willebrand disease, we need three things. We need a personal history of bleeding, we need a family history of bleeding, and the appropriate laboratory abnormalities. If you look at the bleeding signs, so that's how we start when our patients come to our clinicians, and it's been noticed that VWD is one disease which, though being autosomal in inheritance, more women present to the hospital as compared to men. And the usual presentation is heavy or prolonged menstrual bleeding. When you take a general look at the bleeding symptoms, epistaxis seems to be the most common presentation, and this is what we see in our hospital as well. Other than that, there may be easy bruisability, there may be bleeding in the oral cavity, there may be bleeding on prolonged bleeding from minor cuts and following surgery or childbirth. There may be bleeding in the upper and lower GI tract, and very rarely there may be bleeding in the joints like we see in hemophilia. So what you can see from this table of the signs is that these are all non-specific. Anybody with any kind of bleeding disorder can have this presentation. So it gives me really no clue what I'm dealing with. And the bleeding associated with von Willebrand disease can be seen in non-coagulation defect disorders also. So other conditions may present in the same way. So it becomes a challenge and we need to recognize it. When we take history, it's somewhat subjective, and as Dr. Namrata very nicely showed us today, we need to make it more objective so that we know who to investigate and what to expect.
So for that, there is this ISTH bleeding assessment tool, which you saw in the morning. It has a whole number of symptoms, and we have to ask in detail from the patient and score the severity from 0 to 4. Now, in children, any score above 2, in males, any score above 3, and in females, any score above 5 is considered abnormal. And people have found that this tool is quite helpful in excluding von Willebrand disease or in including von Willebrand disease. So it has a good specificity and a sensitivity index. So this protein is coded for by a huge gene which sits on chromosome 12 on the short arm, and it has 52 exons, so it's tough to sequence. And this gene codes for a huge protein which which is organized into these domains which perform different functions. There is a domain for binding to the platelets, the GP1B alpha, and to collagen. Then there is a domain which is responsible for binding to factor VIII, and there are domains on either side which are responsible for dimerization and multimerization. So easy to understand that if these domains are affected by any kind of mutation, then this molecule becomes non-functional. And also you can make out from this that there never will be one test by which we can diagnose von Willebrand disease very clearly. There may be a problem in any of the domains, and that may not be picked up by one single test. Despite this, the easy bit is that the phenotypic classification of von Willebrand disease is relatively simple. So there are essentially 3 types. Type 1 and type 3 are the quantitative defects. Type 3 is a very severe defect where actually no von Willebrand factor is being synthesized, so it's absent in our laboratory tests. Whereas type 1 is a partial deficiency. We can find it, but it's below the limits of normal. Type 2 is qualitative, where either the binding function to the platelet receptor, GP1B alpha, is defective, or its binding to the factor VIII, that domain is affected. So when it affects the factor VIII binding, it's type 2N. When it affects platelets, it can be 2A, 2B, or 2M. And 2B is one very interesting variant, where instead of binding weakly, which is what we would think if the molecule becomes non-functional, it binds so avidly that it makes the circulating von Willebrand factor very low, so gives result to a bleeding phenotype. And what is the other interesting part about this subcategory is that if a similar defect is present on the platelet receptor, GP1B alpha, the same clinical phenotype and lab phenotype will be produced, so producing a real big challenge for us sitting in labs trying to diagnose the type of von Willebrand disease. This is called platelet type von Willebrand disease. So platelet type von Willebrand disease and type 2B can look absolutely alike. Those who work in coagulation labs are well aware that these are the 6 tests we usually use as screening tests whenever we have history of bleeding. But it's good to remember that they may all be normal in patients with von Willebrand disease. At times, because of the poor factor VIII carrying capacity, the factor VIII level falls, so the APTT may be prolonged. And in some types, that is the type 2B, there may be a low platelet count. So these 2 tests may give us that information. Otherwise, there is a limited role for this. So what we need to always drum into the head of our clinical colleagues is that if you're thinking of von Willebrand disease, please specifically ask us to screen for them. And these are the tests which we will use for screening for von Willebrand disease: the von Willebrand factor antigen, an activity assay, which can be dystocitin cofactor, that's the classical one, or its modifications on our analyzers, the GP1B-R and the GP1B-M, where we are using latex particles which have been modified in such a way that either with or without dystocitin, we can see agglutination, instead of having to use platelets. And the VWF collagen binding assay, which looks at the collagen binding activity, and the factor VIII assay. So if we have these 4 tests, and if we get a VWF level of less than 30 in any of these tests, that patient has von Willebrand disease. So just these 4 tests are enough to help you to think of von Willebrand disease. Of course, factor VIII, remember, can be isolated low in hemophilia A. If we want to further subcategorize, and it's very important that we do that for von Willebrand disease, because some forms of treatment that we use to treat mild von Willebrand disease may not work at all in the severe forms or in some forms of type 2. So we need to decide whether it is 2A, B, M, or 2N. So for that, we do additional tests. There is the factor VIII binding assay, which will identify type 2N or the Normandy type von Willebrand disease. The RIPA, which will identify type 2B von Willebrand disease. multimer analysis, where we will see that either the multimers are absent, as in type 2A, or present, as in type 2M. A pro-peptide assay, which we use to work up for acquired von Willebrand disease, and the variants which are cleared from circulation very fast. And thankfully, genetic analysis is not mandatory for the diagnosis of von Willebrand disease, except in some circumstances. In type 3, when we are planning an antenatal, and in some forms of type 2, as we will see. So using this data, we in the lab can derive ratios. This is essentially to differentiate now between type 1 and 2. 3 is severe, so we don't have any antigen or activity. Now we have to decide if there is a type 1 or 2. So what we do is we take these tests and we put the antigen levels in the denominator, and whichever activity we have done, we put it in the numerator. So you can get any kind of ratio like this. Now, if we take this example, if the antigen and activity are both proportionately reduced, then the ratio will go greater than 0.7. So this is called a concordant ratio, and this actually indicates a type 1 von Willebrand disease. If, however, it is less than 0.7, which means activity much lower than antigen, then this is type 2. But we never need to use these ratios in type 3 von Willebrand disease. So this is only to differentiate between type 1 and type 2. So you diagnose your von Willebrand disease if the levels are less than 30. Then you look at your ratios to see whether it is type 1 or type 2. And using this, people have come up with very good algorithms how to classify von Willebrand disease, some without using multimers. And one of them is this one from Westmead, Australia, where if you get very low levels of von Willebrand factor, less than 2, that is somewhere near the bottom. I don't know, I can't use the pointer here. Yeah, can you see it? Yeah. So if it is very low, then it is type 3. And if the activity is also low, then it is more like type 3. If both the antigen and activity are low and the ratios are normal, that is the top one, then it is type 1. Type 1 is further categorized into mild and moderate or severe, depending on how much antigen levels are there. Less than 15, it is severe type 1. 15 to 30, it is mild or moderate type 1. If there is a difference between two ratios, that is the dystrophin cofactor to antigen ratio and the collagen binding to antigen ratio, then we are likely looking at a type 2A, type 2M von Willebrand disease. Whereas if both of them are both of them are reduced, then we are looking like at a type 2B. So, sorry. So in resource limited settings, something like ours, we can't use all these tests. So we had a sort of a limited repertoire when we didn't have collagen binding assay, and we would use these tests, that is the antigen, the dystrophin cofactor activity, and the REPA test to classify our patients into severe, type 1, and for type 2B and all other 2s, because we could not do A and M or the type 2N assay, the factor VIII binding assay, to differentiate between these two. So for a long time we were using this, now we have the collagen binding assay. So I am going to use this to show you some cases. The first was a 23-year-old female who had menorrhagia, which soaked through bleeding. This is how many patients come, with easy bruisability since childhood, but there was no family history for bleeding disorder or transfusions. The screening coagulation profile was normal, the BWF antigen is low, and the activity is also low. So the next thing we have to decide, is it 1 or 2? We make the ratio and we can see that it is greater than 1. So this is a type 1 von Willebrand disease. Now I told you we need a good family history. That was not available. That doesn't come these days so easily because we have small families. So we have to rely heavily on the test to diagnose type 1. An 11-year-old boy with sites of multiple bleeding, including ecchymosis, epistaxis, and hematuria, came to us for investigation, and his APTT was prolonged. The mixing study suggested a factor VIII deficiency, which was confirmed on assay to be 3%. So I labeled this patient as a moderate hemophilia A. We had got a new analyzer with this dystrophin cofactor activity kits at that time, but since we never seemed to be getting too many patients, we were storing samples of all kinds of bleeding disorders just to get an idea of how the kit worked. We stored a sample of this child, and 1 month later, when we ran all those tests, we found that his von Willebrand factor antigen and activity assays were very low. So this was actually a von Willebrand disease and not a hemophilia. And now I understand that it's important to exclude von Willebrand disease in all cases of moderate and mild hemophilia Since in patients with severe von Willebrand disease, they can have factor VIII levels between 1 and 10%. So before you give mild or moderate, please remember to work up for VWD also. And again, now with small families, you may not get a good history to give you the clue that this is not X-linked and this is probably going to be an autosomal recessive disorder. A 5-year-old girl came with ecchymosis on and off since 2 years. There was no history of transfusions, and she had come with her mother who said there was no family history of bleeding. She was being investigated for a bleeding despite a platelet count of 69,000, and the pediatrician suspected a platelet function defect or von Willebrand disease. So when we did the screening coagulogram, we can see that the APTT is prolonged, which was due to a factor deficiency seen on mixing study, and this was confirmed to be factor VIII, which was low, 33% in this patient, and of course the platelet count was low. So now we have a female with a low platelet count, and we have a prolonged APTT with a low factor VIII. So obviously VWD comes high on the list. We did the test, and here you can see that the antigen is almost twice that of the activity. So the ratio is less than 0.7. So this fits well into the diagnosis of type 2 von Willebrand disease. Now, which type of type 2? The way to go about it is to do a multimer analysis and see if the multimers are present, then it is type 2M. If they are absent, then it becomes type 2A. But this is not available and it's not even required most of the time. So, what we had at that time is the ristocetin-induced platelet aggregation. So we thought at least with a low platelet count, we should exclude type 2B von Willebrand disease. So what is this REPA test? Here to the patient's platelets, we add varying concentrations of ristocetin. And in normal people, if you look at the top 2 lines, there is a flat curve. They don't respond to low dose ristocetin. And at high dose ristocetin, close to 1 and 1.5, there is good aggregation and you can see a nice curve. So most of us don't have access to so much plasma to do 5 tests. So we do an abbreviated RIPA, which you can see in this graph. The blue line is the 0.5, the low dose, and the black line is the high dose, 1.25. And in a normal person, the blue line is flat and the black line indicates a normal response. So in this child, instead of getting a flat blue line, we can see that there is aggregation. So this is not expected. And what this means is that there is hyperaggregation at low dose ristocetin. So now the likely differential diagnosis at this stage for this patient is either a type 2B von Willebrand disease or the corresponding defect on the platelet surface on the GP1B alpha receptor, which binds to von Willebrand disease, either that is hyperfunctioning. So either type 2B or platelet type von Willebrand disease. Now we thinking of how to differentiate them, we did a mixing studies using the patient's platelets and plasma against normal platelets and plasma to see which one was defective in the patient. So when we used patient plasma and repeated the test at 0.5 milligrams ristocetin, we can see that we got the normal curve back again. So this made us think that there is no problem in the patient plasma because we got the normal curve. But when we repeat it with the patient's platelets, we get the curve back again. So this suggests to me that something is wrong in the platelets because the curve is again abnormal. So this showed a pattern of platelet type von Willebrand disease. We told the mother that this is what it is. Thankfully, the child's bleeding was not serious, so the patient went back. And every time when we give an abnormal diagnosis, we like to read, what else we can do. So we realized that we need to do a molecular diagnosis to confirm that. We didn't have the capability then, but we started collecting the DNA of these patients. And when my colleague in the genetics lab started this test, we thought we would run this sample as well. So before we go there, let's look at the von Willebrand factor gene. As I told you, this is a huge gene and it codes for a number of domains, which is seen in those blocks in the third row. Sorry. Yeah, these are the domains. And whereas the mutations for type 2A are found all across all domains, the mutations for type 2B are only present in exon 28. So very easy, we told our colleagues to just sequence exon 28 and see if there's any problem. Now remember, we thought that this was a platelet type von Willebrand disease, so I expected that this genetic run would be normal. I don't expect to find a mutation because I had labeled her as a platelet type. But what happens is when we did the genetic testing, we can see that in the B panel, this is the normal sequence. In the A panel, this is of the patient, the C is replaced by the T. And this is a very well described mutation, including from India, which is responsible for type 2B von Willebrand disease. So now what I labeled as a platelet type von Willebrand disease on mixing study was actually a type 2B von Willebrand disease. And like us, I'm sure many people who are doing this test must have faced this problem. And currently, the recent guidelines say that genetic testing is mandatory for differentiating between these two types with any degree of surety. Now, when you have this diagnosis, we expect it to be autosomal dominant. This is one of those disorders. So again, we went back to the mother and said, gave us negative family history. Now she was more forthcoming, and she said that she had been having epistaxis since 2 or 3 years of age. She had puberty menorrhagia, which needed admission. She complained of petechiae and ecchymotic spots on her legs, including recently 6 months back. She had had 2 episodes of hematemesis. This is all probing history. When you are not reaching any answer, go back to the patient again and try to get some more information. And worst of all, because she had low platelet counts, she was being treated as an ITP, for which she had been put on steroids for long term, and only when her bone density went down had they stopped steroids. So she was being treated as ITP. Then she also gave us history of being transfused platelets during her delivery. So we thought that this is now the patient's, this is the parent who should be carrying the autosomal dominant mutation. So we did her von Willebrand factor panel, which you can see in the second column. But as you can see, nothing is less than 30 in the VWF panel. So how can she be the affected parent, though her platelet count is 69,000? So now we were a bit confused. We called her again, checked her again, and found that when we checked her again, we found that the results were still not there. So we asked if we could test the father, thinking that maybe that is where the problem was. The parents had separated, but the father was very cooperative, and for the daughter, he came. And when we tested the father, which you can see in the orange column, again the VWF panel is normal. Now, this is so annoying for the VWF test that you expect to get, the mutation in one of the findings in one of the parents, but you don't get it because there are a number of modifiers which can change VWF levels, and we should be aware of. So, but her mother had low platelets and she had large platelets. In the meanwhile came COVID, there was a lockdown, the patient never reported. In 2023, this index case, the child came with profuse epistaxis needing admission. And the mother accompanied the child when she was admitted under pediatrics. In the hospital, the mother told us that she has ecchymosis now on her legs. So at this time, when we tested her CBC and VWF panels, we find that she has large platelets. She continues to have thrombocytopenia. And now, in the 2 blue columns, you can see that when we did her VWF panel, it's all deranged. Now it fits well into a type 2B von Willebrand disease. We repeated this a month later. That is the second blue column. You can see again it's abnormal. And I put the index cases finding in the green column on the right just for comparison. So what I learned from this case is that besides having to resort to genetic testing, repeat testing is required in all non-type 3 von Willebrand disease cases. And this is mentioned in most of the algorithms, except for severe, we need to repeat test our patients in case we don't get a clear-cut picture. And what I think is my learning lesson from this case is, mostly we advise testing when the patient is not bleeding and in a stable state. But here this patient's correct findings could only be picked up when she was bleeding. So maybe what we read in books, sometimes we should, question. A 41-year-old female came with excessive bleeding during dental flap surgery. There was no past history of bleeding, and other than anemia, she had normal screening coagulation profile. Her von Willebrand factor antigen, which was done on 2 occasions, and the activity were both low. But as you can see, this is not less than 30, so I can't label her as a type 1, and it is not more than 50, so I can't say she's normal. So she's sitting in that gray zone between type 1 and normal. Now, if you see her ratio is also normal, and she has blood group A. So this used to be called low VWF levels, and patients with low VWF levels seems to have more representation of O blood group, which was not seen in this case. These patients respond well to desmopressin, and if we do a mutation analysis trying to get an answer by what is this? Is it low VWF or is it truly a VWB type 1? In 60% of the cases, we may not find a mutation. So in the recent guidelines in 21, it was said that anybody who had values between 30 and 50 were to be labeled as type 1 von Willebrand disease if they had abnormal bleeding along with it, so that these patients could get benefit of therapy. Now, this works well in the Western world where there will be therapy. In our country, we are still struggling to reach a diagnosis. And in a recent update, which is appeared in the International Society of Thrombosis and Hemostasis, now what we have to do is, if less than 30, von Willebrand disease; if more than 50, normal; if it is between 30 and 50, observe. If there is a hemostatic challenge in between and there is no abnormal bleeding, then that patient is to be labeled normal. But if they do bleed, then they are to be put in the category of type 1 von Willebrand disease. So you just don't forget your 30 to 50 VWF labeled patients. You tell them that you please, keep in touch with us because you may need therapy in case you bleed abnormal. So this is the recent update. A 74-year-old male came with loose stools and bleeding PR with easy fatigability. He had undergone a right femur operation 5 years back. He now had pallor, and in the hospital which he had been investigated previously, before coming to us, the endoscopy showed nothing. But when he came to us, there was some small erosions in D1, D2, the lower GI mucosa was normal. And in one of the investigations, they could see a small polypoidal lesion in the jejunum with ulceration and some proximal and distal bleed to that lesion. So he had undergone, loop jejunostomy. Post-operatively, he developed hypotension and they noticed a bleed in the stoma bag. So a bedside enteroscopy was done through the stoma and gut ischemia was identified. There was an active bleed at the stoma site, which was ligated by the suture ligated by the surgeon. So this patient continued to bleed from the stoma site till it was ligated. So we were asked to investigate if there is a bleeding disorder, and of course there's anemia, as you can see here. PT and APTT were both abnormal, but the fibrinogen was normal. D-dimer assay was a little bit elevated. So when we get a abnormal prolongation PT and APTT, we usually do mixing studies, and in this case, we did a mixing study on the patient's plasma PT test on the patient's plasma. The patient's PT is prolonged. When we mix with normal pool plasma, it comes to 11.7, which is corrected, 13.7, which is corrected. And when we mix with factor 2, 5, and 10 deficient plasmas, we see a sort of an in-between picture. It doesn't seem to be getting corrected fully or prolonged markedly. So this kind of a picture we usually get in mixed factor deficiencies. So we did a factor assay, and of course we saw that there was factor 2, 5, and 10 deficiency in this patient. So I gave out this report saying that please exclude secondary causes of multiple factor deficiencies, most likely liver dysfunction or DIC. DIC was not being considered at all at that time. LFT was a little bit deranged, but the gastroenterologist, she was persistent. She says this is not the cause of bleeding. I'm very sure. We've seen so many patients. It can't be because of that. Why don't you please work up for a bleeding disorder? So, and because it's not responding to plasma transfusion. So what do? We go back to the patient and take more history. Now we are told that he has recurrent bouts of epistaxis that were controlled well without consultation. Coming to hospital, he could manage at home, but multiple bouts during a year. And in that hip surgery which he had, he needed plasma transfusions. So now we were requested to do the workup for von Willebrand disease, and we can see that both the antigen and activity are reduced. So what we had got was a prolonged PT and APTT, making it look like a multiple coagulation factor deficiency. But there was an underlying bleeding disorder which may have gone missed had our clinical colleagues not insisted. So keep your ears open and listen to your clinical colleagues. What your tests are telling you may not be what is the complete picture. So now to label which kind it is, it's difficult because the patient has received plasma. So I'm really not sure, maybe a type 3 or maybe a type 1. So VWD needs to be investigated, re-investigated if the clinical suspicion is high, even in the face of confounding screening coagulation tests. None of us here in this room would go for VWD testing if we saw a prolonged PT. So this case is that don't forget, if your clinician is requesting for it, you need to exclude it. It may be one in a many cases, but where you need to diagnose that one case also. So what do? This is the question we ask ourselves all the time. I have nothing, you have everything. You have a coagulation analyzer which does, the ristocytin cofactor assay, does the collagen binding assay and everything. I don't have even these basic facilities. So what should we do? If you have nothing, use the BAT, the bleeding assessment tool, to evaluate for the presence of a bleeding disorder. At least make out that there is an abnormal bleeding present. look for the inheritance pattern. Most of them are autosomal dominant, except the type 3, which is autosomal recessive, and the type 2N. Okay. If you have bleeding time, which is available everywhere, and I have Dr. Sukesh Nair sitting there who believes so deeply in this test, this is a very good test for type 3 von Willebrand disease and the severe clinical phenotype, but it won't tell you whether the patient has BWD or he has another platelet disorder. But at least it will tell you that there's something wrong. The challenge we face, most of us who don't do BT, is that lack of trained personnel, and many times our patients are children. It's very difficult to control them by doing the BT test, and we know that we need to have the patient, absolutely relaxed while doing this test. If the APTT is prolonged, we can think of a type 2N von Willebrand disease, but remember this is also prolonged in hemophilia, and if the PT is prolonged, then it may be a common pathway defect, as we saw in our last case. Platelet count, if it's low, then you can think of a type 2B von Willebrand disease. And if you have a manual reaper, if you're otherwise looking at platelet aggregation disorders, then you can look at the pattern and see that flat curves in high concentrations indicate type 3 or a type 2A or a type 2M, whereas type 2B usually shows aggregation or may even show a hyperaggregation pattern. So it's good news for all of us that the NIH Mumbai has developed a lateral flow immunoassay for which can pick out severe von Willebrand disease like a point of care test. So this is a line chromatography assay which can be used with whole blood or with plasma, and they have control lines which will be positive before when you put the sample. And in patients who have von Willebrand disease, both the factor VIII and the severe von Willebrand disease, both factor VIII and BWF antigen lines, the test lines will be missing in either whole blood or in plasma. So the advantage is it can be really done at our PHCs if the storage of the kit is right, and we can train our workers there to just identify these lines, just like a pregnancy test. The cost I'm not sure, but I think it will be around 400 rupees. So this will act like a good first step to exclude severe von Willebrand disease. It would be good if we could put all the different tests that we need, the antigen, the dystocitin cofactor activity, collagen binding assay, factor VIII binding assay, propeptide assay, into one ELISA plate. And this was designed by a group of workers, but somehow it's not picked up at all. We'd like to get everything in one plate and with one sample and to get the diagnosis fast. But till that happens, I can tell you that accurate assignment, to quote Dr. Paula James, accurate assignment of von Willebrand disease type and subtype is a form of torture for junior trainees. But it's important because it can influence treatment decisions and the understanding of inheritance within a family. Assigning VWD phenotypes at presence requires many different specific types of VWFA assays, which are at times cumbersome. You can see that you may need to resort to multimer analysis. Sometimes these are difficult to standardize and are only available at specialized laboratories. As a result, repeat testing is a norm, and a definitive diagnosis can sometimes take weeks or months to achieve, or may sometimes be even remain definitely elusive. So I'd like to end my presentation with a big thanks and for my institute, for the lab, my colleague Dr. Narendra, the technical staff over there, the team of clinicians for their faith in our testing, and the opportunities to send those patients back so that we learn from the mistakes that we have already made before in our previous diagnosis. With that, I'd be happy to take any question, and I thank you for your attention.
The house is now open for questions.
Just
Sir, what's the age, maximum age where you've seen VWD disease?
The age? Yeah. So 74 years is my oldest patient, which I shared with you just now.
Long time back, Dr. Sonia Nityanand had come as an examiner in AIDS, PhD man, you remember? Yes. Dr. P.K. Gupta had his topic in BWD. Dr. must be aware of this, and she was at that setting up the dystocitin cofactor assay, Dr. Sonia Nityanand, the whole hand. There were very, very few labs who had RICO-F, AIMS did not have it. And Dr. Gupta had to go to Germany to complete his PhD, with the data. So the present analyzers and the dystocitin cofactor assay is now in range to be tested as a little bit more. for people like us who like to set up a VWD lab?
So most of the big analyzers which can do immunological assays can pick up the von Willebrand factor panel. They can do the ristocytin cofactor activity by its modified form, the GP1BR or the GP1BM. Currently, the only hitch that we face, and the antigen, of course, they can do by latex immunoassay. The challenge with them is that their lower limit of detection is, very high. If I have to diagnose severe von Willebrand disease, we want the levels to be unmeasurable, so less than 2. But their lower limits may sometimes be 4.4 or even 7. So how do I distinguish whether this is a severe type 1 or it is a severe uh, type 3 von Willebrand disease? The number of times I think about it, my clinical colleagues tell me, don't break your head, Jasmina. We are still going to give treatment. We will give plasma and we will give factor VIII as is required. So don't bother. But for us in the lab, it's always a challenge. We need to know ye kya hai. The last final label, because it may have a bearing later when an antenatal may be planned in that family for whatever reasons. So we currently use the ACL top latex immunoassay just for factor VIII assessment of this entire workup. The other 3 assays, that is the collagen binding assay, antigen assay, and the GP1BR, which is equivalent of ristocytin cofactor, we do on a chemiluminescence immunoassay platform, the AccuStar. It is expensive, but it has a very low level of detection, 0.3. So I'm now more sure of my severe type 3 von Willebrand disease. And the best part is I can do one test a day. You can just run one and put the cartridge back into the fridge. So that is the method I'm using. ELISA is a very good method if you can't do anything. There is a very good technique which has been perfected by Dr. Nair's lab, and that can be done by people who are willing to take on the challenge of putting up an ELISA. In our government hospitals, less I say, the better it is.
I have this one question. In the last slide that you showed that for severe von Willebrand disease, now your point of care test, is it commercially available?
It's coming anytime, Dr. Vijay. They've done, I think, their preliminary testing in various centers. I think there is an issue of, they're trying to market it abroad. What I understand from the team is the people who are going to take it abroad, those regulatory agencies have some queries which they want addressed. The cost is probably going to be close to 400. This is just off record. But I'm pretty sure that once it gets to be used more, the cost will come down and it will become a very easy way of at least screening it down. The rest of the gamut, all the big labs who have analyzers can take that up for their patients.
For the low dose recall, do you do it for all patients or only for patients having thrombocytopenia?
Only for patients who have thrombocytopenia, because I face, this is one of my cleanest cases. But there are many times when the curve goes here, the second time when I repeat it, it will come flat. So there is a challenge.
Thank you.
Next, one question. So as guidelines says that less than 50%, we have discussed earlier also. So less than 50% of antigen, then only we should look for the recall for another activities. If the antigen level is less than 50%.
Okay.
So recently we have got 3 cases where the antigen is more than 70, 80 or something. And the cough is somewhere around for 30, 40, so the ratio becomes less than 7. So I name it as type 2.
Type 2.
Because maybe I am unaware of it. So, but later on discussion, I recorrected the diagnosis. It may not be type 2, but the patient is bleeding. So somehow we sent the NGS, and all 3 cases we got the mutation in type 2. So how we should take these guidelines? Like they say, if the antigen is 50, then only you interpret your recall or collagen binding assay. Before that, whether we should interpret the.
I think we have the privilege of step testing where you have time and you want to do it like that. We put all 3 assays at one go because I think it's very crucial that you do all 3 tests on the same sample. So if you are planning, I'll do one test today and then I'll see the result and then do it on another date, that may not work. The second thing we need to remember is the variation with the physiological state. So a repeat test is very important. Did you do repeat tests in all your patients?
On repeat testing is same.
On the same, you got the same result.
Antigen is always 60, 70 and more than 70.
Yes.
And recall is always low.
So that looks like a type 2. And where did your mutations come?
It's exactly we don't remember, but it is second grade mutation. It is not US.
Yes. So did you do collagen diamine?
No, we don't have that.
You did. So I would label your case as a type 2 non-DUBI. Type 2 non-DUBI. The antigen level is still normal. Because all said and done, the more we think that our patients should follow guidelines, they don't. And in that case with the mother, you remember how many times we tested again and again, thinking that now we'll get a picture. Here in fact, I didn't tell you, but we did the genetic mutation of the mother much before that. I was still so annoyed with this test. I said, why can't we get the correct thing that I should get in this patient? It came on the third try. So sometimes it is like that. You just have to do repeat testing. And there are so many other modifiers and other genes, your hormones, exercise, your blood group, which will decide how it will go. So I don't wait for that. I do all three tests at the same go. I don't do stepwise.
We do the test on the same sample.
Yes, same sample, same day, same sample. Because now on the chemiluminescence platform, one sample, we put it on that, all three tests available on the same day. It's expensive. Thank you.
Thank you, Doctor.
Thank you so much, ma'am. I request Chief Guest of today's function, Honorable Vice Chancellor, Ma'am, King George Medical University, Professor Sonia Nityanan, ma'am, to present a memento to Dr. Jasmina, ma'am, as a token of her appreciation and love. I request Honorable DC ma'am to present the memento to Dr. Lily ma'am. I also request ma'am to present the token of appreciation to Dr. Vijay sir. Thank you, ma'am. Thank you, sir. Rest of the lecture of session 3 will be carried out after or later, and now we will proceed for the inaugural ceremony. I would like to invite the distinguished dignitaries to the dais.
I consider it a great honor to welcome the chief guest of today's function, Honorable Vice Chancellor of King George Medical University, Professor Sonia Nityanan ma'am, to come and kindly grace the dais.
I am very much delighted to invite guest of honor of today's function, Professor Sukesh Nair sir, Department of Hematology, CMC Vellore on the dais.
It is my honor to invite a special guest of today's program, Professor Tathagat Chatterjee sir, to come on the dais. I also request Professor Suresh Babu sir, the organizing chairperson of today's event, to join on the dais.
I request Professor Rashmi Kushwaha ma'am, of the organizing secretary of today's event, to join on the dais.
Flowers are a way to express gratitude and respect. Therefore, I request my colleague to present floral welcome to our dignitaries.
Anjali. Thank you, Dr. Anjali. Let's elevate the spirit of this occasion by remembering Ma Saraswati, goddess of knowledge and embodiment of wisdom and learning. I request our distinguished dignitaries to light the lamp and officially inaugurate the ceremony.
वो बहुत लंबा है
या कुन्देन्दु तुषारहारधवला या शुभ्रवस्त्रौधृता या वीणावरदण्डवन्दितकरा या श्वेतपद्मासना या ब्रह्माच्युतशङ्कर प्रकृतिभिः देवैः सदा वन्दिता सा मां पातु सरस्वती भगवती निःशेषजाड्यापहा शुक्ला ब्रह्मविचारसारपरमा आद्यां जगत्रापिनीं वीणां पुस्तकधा
Thank you all the dignitaries. Thank you all the dignitaries. At this juncture, I would like to invite Professor Suresh Babu sir, organizing chairperson, for the welcome address.
Good afternoon, everybody. I welcome to our Honorable Vice Chancellor, Professor Sonia Nityanan Ma'am, and I also welcome to our guest of honor, Dr. Sukesh Chandra Nair, and our special guest, Dr. Brigadier Tathagat Chatterjee. I also welcome to all dignitaries, our participants, esteemed faculty members, and our students who came to attend this Coagulation Update CME, and that will be followed by workshop from 21st and 22nd March 2022. The goal of today's session is to provide a platform with a comprehensive update on latest development in the bleeding disorder as well as the practical steps for applying these advances in clinical practice and to minimize as well as resolve the challenges of the bleeding disorders. The interactive workshop on next 2 days will provide you with hands-on training on diagnosis of hemophilia and bleeding disorders. The workshop is intended to target young doctors and technical staff of different medical colleges of Uttar Pradesh, and that will also community health centers staff is also trained to him diagnosis of hemophilia and bleeding disorders. Thanks you for being here and for your commitment to advancing your expertise in this vital area of healthcare. I encourage you all to engage, ask questions, and make the most of the discussions today and workshop. Again, I welcome all of you. Enjoy this academic feast update of Coagulation CME. Thank you very much.
Thank you, sir. May I request Professor Sukesh Chandra Nair, sir, guest of honor of today's function, to address the gathering.
Thank you very much, Dr. Rashmi, for this rare honor because I am not used to doing talk other than coagulation. Respected Honorable Vice Chancellor, first of all, heartiest congratulations for your Padma Shri honor, and we feel that all the hematologists were honored simultaneously. I think I also thank for this big honor for coming to the Takshashila of coagulation in India right now. I would say Mecca. Mecca is a place of worship, but Takshashila is where all the there's one place where you get a lot of experts. You know, we have Dr. Rashmi, and now with the fact that she is going to conduct a full hands-on coagulation workshop, I'm sure this is the first of the many she's going to conduct. Like Dr. Dinesh has done in SGPGI along with Dr. Ruchi. So in another institute, then Dr. Namrata, who has been trained many years back, but she unfortunately doesn't feel she's empowered to do it because she doesn't have many patients. But I think she got that feeling in between when Dr. Sonia was the director of RML to do much more. But I'm sure she will get there because I know she's a big expert in coagulation. And now with the addition of Dr. Bhushan and Dr. Rama, Lucknow is become the Takshashila of coagulation. Yeah. No place in India has so many experts in one particular place. So Takshashila is where not only you have experts, but who are willing to transfer their expertise to others through education and workshops. So thank you very much, Dr. Rashmi, for inviting me again. And I wish the program as well as the workshop hold success. Thank you very much.
Now, may I request our special guest, Professor Brigadier Tathagat Chatterjee sir, to come forward and share his views.
Good afternoon, ladies and gentlemen, and such an honor. And like Sukesh Nair said, I was not used to, being honored so much. But Dr. Sonia was my examiner in DM. Another, I'm sure you remember, and I did well in my DM. But what I still remember is her compliments, where she thought that I was a better clinician than a lab. Yeah, do you remember? Yes. So yeah, and I still remember that comment. So I started improving the lab thereafter. So thank you, what an honor, and I wish Dr. Rashmi the very best for this feast. And Lucknow now is the epicenter of coagulation, but too many experts spoil the broth, as it is happening in leukemia. I only hope you don't come with newer classifications, which is happening in leukemia and disturbing our peace day and night. So I wish you a very happy consensus get together where you work on a uniform approach to coagulation, and may the MD students, that is our target, the MD students in pathology who are actually very weak in hematopathology. So our target is that learn the coagulation and do well in the future. Thank you very much.
Thank you so much, sir. Now, may I request Chief Guest of today's function, Honorable Vice Chancellor Ma'am, Professor Sonia Nityan Ma'am, to share her views.
Thank you. So, our special guest today, much against their wishes, I would say, Professor Sukesh Nair and Professor Tathagat. And of course, the Dr. Suresh Babu, Dr. Rashmi Kushwaha, Dr. Vijay Tilak, and our very outstanding coagulation, lab coagulation expert, Dr. Jasmina, and all other esteemed faculty members who are in the audience, and all the participants. So first of all, a very warm welcome on behalf of the King George's Medical University to all of you, to this institution and to this beautiful city of Lucknow, which, as you all know, is famous for its historical buildings and for the cuisine and, of course, for the etiquette. I hope, apart from the CME and workshop, you get a little time to go around the city. I'm sure Dr. Rashmi will make sure of that, and also enjoy the cuisine. It's actually a great honor that we have the stalwarts. I mean, it gives me a great joy also of coagulation who have been brought together here by Dr. Rashmi. So I begin by congratulating Dr. Rashmi that the stalwarts of coagulation are here from India, are here today. I would like to begin with Dr. Sukesh Nair. I mean, his understanding, his deep understanding of coagulation is something which I think most people here will not even be able to fathom. We've known him for years, and it's not just that he gives good lectures and conducts good workshops, but he has a very, very deep understanding. And we are very grateful to you that you've come today, and you're sharing your expertise here. Dr. Tathagat, I hope I have pronounced it properly, Chatterjee is an outstanding educator, teacher, and he has a passion for teaching. And I'm very, each one of us has a different flair, and this is his special flair. That he is so passionate about teaching an art which is actually dying down in today's era because of the modern technology and digital infrastructures. So thank you again for being there. And we have Dr. Jasmina, who is again an outstanding coagulation lab expert. And of course, Dr. Vijay Tilak, who's really trying to promote hematology in the state of Uttar Pradesh. So I'll tell you my little story on coagulation. I'm not a coagulation expert. My field of interest is hemato-oncology, which started when I was in SGPGI in the Department of Clinical Immunology, where there was a wing of hemato-oncology. And then I was asked to set up the Department of Hematology as a composite department with both clinical and laboratory components. And of course, that was very, very important because hematology is incomplete without a lab component. Lab is an integral part of clinical hematology. That's why it's called hematology. And I can see Dr. Ruchi and Dr. Dinesh sitting here, and they are a witness to my focus on developing the lab component of the hematology in the Department of Hematology at Sanjay Gandhi PGI. And I was a little lost with the development of the coagulation part of the lab. And then walks in, of course, Dr. Ruchi joined first, and since she found that the interest of the department is in hemonc, so she started by setting up the laboratory services for hemonc, the flow cytometry and advanced flow cytometric techniques, molecular hematology. And then comes in Dr. Dinesh. And I would like to take this opportunity to, appreciate his passion again for coagulation, the area of coagulation, and my unfulfilled dream of setting up the coagulation aspect of the lab in the department was fulfilled by him and Dr. Ruchi Gupta. And they have set up a very beautiful and a very deep, diagnostic lab in the hematology department at SGPGI. And Dr. Dinesh and Dr. Ruchi have gone on further each year, adding on more and more tests. And coagulation is like, I would say, it's like molecular genetics. You need a deep understanding. You have to digest about the whole coagulation cascade of the body. And it's an integration of lab tests with molecular tests. And that's what you have to understand, you have to digest it. And as Dr. Jasmina was highlighting through her cases, that each day you learn something new, and it's through patient, through cases that you learn the new things. And then I move, in the last, from 21, I moved on to RML, and I find Dr. Namrita there. And as Dr. Nair already highlighted, she has a deep interest again in lab hematology and in the coagulation. So it was a bonus to me that there is another faculty member in another institution who is so involved and at least has the desire to set up and take further the coagulation lab of the hematology setup in pathology. And then I come, in 23 with 6 months where I was holding a dual charge into KGMU, and I find that Dr. Rashmi Kushwaha and Dr. Mili Jain, they are very, very interested in the coagulation aspect of hematology, and that gave me immense joy. And I really wish that with all the, you've got now Dr. Sukesh Nair on board and Dr. Tathagat on board and Dr. Jasmine on board, that this area is advanced further in the KGMU. It's a difficult area and it needs, it needs the infrastructure as well as the understanding, and a perseverance. So I am actually very overjoyed today to see that this workshop is being conducted, the CME is being conducted. And I would have loved to attend it, but because of March 31, which is the financial year ending for government institutes, there's a lot of pressure of, closing the budget of this year. So I am occupied, but I can see that there is a line of very, very good lectures by the stalwarts, and I agree with what the previous two guests of honor have said, that this is becoming, Lucknow is becoming a kind of hub for the coagulation disorders workup. And I deeply want this to go on further under your guidance, Dr. Sukesh Nair. We want you to help us and Dr. Jasmina to help us, and all of you to help us to take this field further, develop it further in Lucknow. So welcome all of you, and I hope you have very stimulating and knowledgeable 2 days. Thank you, Dr. Rashmi, for organizing.
Thank you so much, ma'am.
Now, I would like to request our Honorable Vice Chancellor Ma'am, Professor Nityanand Ma'am, to present memento as a token of appreciation to Professor Sukesh Nair Sir, our guest of honor. Again, I would like to request Ma'am to present a memento as a token of appreciation to our special guest, Professor Tathagat Chatterjee Sir.
I also request ma'am to present the memento to Dr. Suresh Babu sir, organizing a chairperson for today's event. Thank you, ma'am. May I request Professor Suresh Babu sir, organizing chairperson of today, to present a memento to Honorable Vice Chancellor Ma'am Professor Sonia Nityanand ma'am. I also request sir to present the memento to Dr. Rashmi Kushma ma'am, organizing secretary of today's event. Thank you, sir. I invite Professor Rashmi Kushma ma'am, organizing secretary of today's event, to deliver a vote of thanks.
A very good afternoon to Honorable Vice Chancellor Madam, esteemed dignitaries on dais, Professor Sukesh Chandra Nayak, Dr. Brigadier Tathagat Chatterjee, RHOD, Professor Suresh Babu sir, and dignitaries of the dais, Professor Jasmina Ahluwalia, Professor Vijay Tilak sir, Dr. Bhushan Asthana, Dr. Kundan Mishra, and all the delegates and faculty members. As we come to the conclusion of today's inauguration, I would like to extend heartfelt thanks to the distinguished individuals who have made this event very special. To our chief guest, Padma Shri, Honorable Vice Chancellor Professor Sonia Nityanand ma'am. Ma'am, we are deeply honored to have your presence here today. Thank you so much for taking out time out of your busy schedule to be here with us today. And you have always been a very encouraging and always have been a role model to many of us. Thank you so much, ma'am. To our guest of honor, Professor Sukesh Chandra Nayak, sir, your support and encouragement are greatly appreciated. Especially your dedication to come all the way from Vellore for taking out time for 3 days for this CME, as well as to conduct the workshop. He will be here with us for 2 days. Initially, we had only 14 participants, and now we have 29 participants in the workshop for next 2 days. Thank you so much, sir, for accepting the invitation. As you rightly said, right now we have Takshila of Coagulation in Lucknow in KGMU. Thank you so much, sir. I would like to extend our heartfelt gratitude to our special guest, Dr. Brigadier Tathagat Chatterjee, sir. Sir, it has been a privilege to have you with us today. Your wisdom, insight, and enlightened perspective have truly inspired us all. And today morning, how you managed the situation when there was a technical glitch by having a short quiz, it was really appreciable. And I would like to extend the heartfelt thanks to Professor Jasmina Ahluwalia, PGI Chandigarh, for graciously accepting our invitation to be a part of today's event. Madam, your presence has added tremendous value to this occasion. Thank you so much for coming. My thanks to all the speakers of today, Dr. Sujata Rai Chaudhary, Dr. Varun Kaur, Dr. Priyavadna, Dr. Ruchi Gupta, Dr. Dinesh Chandra, Dr. Namrata Avasti, Dr. S.P. Verma, Dr. Bhushan Asthana. I am thankful to all of you for having come here. My special thanks to Miss Reena L from CMC Vellore and Mr. Sukumaran, who are with us to help us in the workshop. My thanks to all the faculty members, chairpersons, delegates and students. Thanks to Faculty Department of Pathology. Our HOD sir, Professor U.S. Singh sir could not be here because of ill health. Our acting HOD, Professor Suresh Babu sir, my team from Hematology Lab, Dr. Mili, Dr. Geeta, Dr. Sanjay, and all other faculty members. Thanks to all of you. Finally, a big thank to all the sponsors and partners for their continued support for this CME and workshop, the POCT team, Team Stago and Novo Nordisk for making this event possible. And towards the end, I would like to thank all the hemophilia patients who volunteered to come and give their samples for the workshop. And this could happen with the help of Mr. Vineet Manchanda, who is the President of Hemophilia Society, Lucknow. So thanks to Mr. Vineet Manchanda, thanks to all the patients who volunteered, and approximately 20 inhibitor negative and 15 to 16 inhibitor positive patients came to us in last 2 days to give their samples. So that is like quite appreciable. And towards the end, I would like to thank all my residents who have been behind managing this hall. Dr. Soumya, Sana, Mantasha, Ashi, Anjali, Preeti, Saloni, Abhishek, Madhulika, Diparthi. Thanks to one and all. Thank you so much. And before finishing the inauguration, if Ms. Reena L is here and Mr. Sukumaran are there, I would request VC ma'am to give a moment to them, because they are the experts for workshop and for conducting the workshop, and I'm really thankful that they have traveled all the way from Vellore to be here with us for helping us. And Miss Reena L has been like conducting the workshops for WFH as well as for the EHAD. So thank you, madam, so much for being here. Thank you. And Mr. Sukumaran, sir, please. He has got very fine knowledge of coagulation, and we are really honored to have you here, sir. Thank you so much.
Thank you, ma'am.
Thank you, Honorable Ma'am. Now we will have a lunch break for a short duration, probably 30 minutes, and the remaining two lectures we'll have after the lunch, because I think it's already the time for lunch. Thank you so much. Thanks to one and all.
He is a dear friend of my husband. Anything but a dear friend. I tell you. What you said is so true. There's something that's it. Okay, Rashmi. All the best. I have to go.
अभी तो लंच है Two talks from the pre-session lunch are remaining. Like one is of Dr. Sukesh sir and other is of Dr. Then this will start.
Start around 3 o'clock.
Yes, I think so. सर आ ही रहा हूँ मैं इस बार सर
अच्छा तुमने याद दिलाया
ओवरव्यू ऑफ ग्लोबल
हीमोस्टैसिस टेस्टिंग हाँ
यही है मैम वो ओवरव्यू ऑफ यही होगा ना हीमोस्टैसिस में
हाँ सब ये
यही खोल के रखते हैं
अब हेमाटोकॉन का अनाउंस कर देते हैं
नहीं ऑटोमेशन की वेन हीमोस्टैसिस है ये वाला तो यही है
नहीं ये नहीं है इसको बंद करो एक बार ये अनाउंस कर दें हेमाटोकॉन हेमाटोकॉन
नाम आप लोग
Good afternoon to all of you and welcome back after the lunch. So I'm going to announce this like 2025 Hematocon is going to be held in Lucknow, organized by Uttar Pradesh Hematology Group. So website is already functional and you can have a look at the website and start the registration process. Please log the dates from 6 to 9 November 2025. The venue is near the airport, Hotel Holiday in Lucknow Airport. So please visit the website and get yourself registered. It's a 3-day conference preceded by a pre-conference CME as well as we are going to have 10 workshops.
Now I would like to request session 3 chairpersons, Dr. Vijaytila sir, Dr. Milijan ma'am and Dr. Namrata Vasti ma'am on the dais.
May I now invite Professor Sukesh sir for his next talk on global hemostasis assays.
Yeah. Okay. So the globality of post-lunch session can also be fulfilled in the post-lunch session. So let's start with a 45-year-old lady awaiting a coronary bypass surgery, referred from Coimbatore by one of the most senior-most cardiothoracic surgeons due to a prolonged APTT. So CMC also, the APTT was prolonged, 113 seconds, reference range you can see. The PT was normal. CBC with the platelet count was normal. Prothrombin time is the time taken by recalcified citrate plasma to clot in the presence of tissue factor. It looks after the extrinsic pathway. And already you must realize that the results of a PT should be resulted along with the reference range of the lab, not against that day's control time or as a ratio. It has to be against the reference range as per the standard. APTT is a time taken by a recalcified citrate plasma to clot in the presence of negatively charged contact activators like silica, kaolin, or ellagic acid, and phospholipid. Phospholipid in the old days used to be called as partial thromboplastin because it used to be extracted along with the brain. The brain will give you the tissue factor. Tissue factor is rich in phospholipid. Then you precipitate the protein, remove the protein, and that becomes the phospholipid. So partial thromboplastin is the reason why APTT is got that name. It looks after the intrinsic pathway, and again it has to be resulted along with the reference range in the lab. So the next step after a prolonged time is called mixing studies. This is a particular test that is the most important test in coagulation. Without this, management of any bleeding issue in a hospital cannot happen. You need to do this test. Without that, you cannot transfuse the patient any blood or blood products. This basically means mixing the plasma which give the abnormal time with normal plasma. The rationale is that if the prolongation in time in this normal plasma is because of deficiency of coagulation factor, when you mix it with normal plasma, the deficiency will be overcome, and when you repeat the time on the mixture, it becomes normal. It's deficiency of coagulation factor. But if the deficiency of time is because of some antibody or inhibitors like heparin, which blocks the coagulation pathway, or antibody to a coagulation factor, that will also block the normal plasma which is going to be mixed with it, and the repeat APTT will remain prolonged. So correction of time on the mixture is deficiency of factor, non-correction is inhibitor. So this patient's mixing study shows band normal result 32.3. So which basically means the patient has got a deficiency of a coagulation factor. Now, which coagulation factor? PT is normal. So we are looking at 12, 9, 2, 8 and factor 9. So we do the factor assays for that, and we find that 8 is not normal, it's high. 9 is also high. Factor 12 is normal, but the patient does not have any 11. This is severe deficiency of factor 11. In the old days, factor 11 deficiency is to be called as hemophilia C. But this patient has got no factor 11, so obviously we can call it hemophilia C, but that's the old terminology, not the new terminology. So she has got severe deficiency of factor 11. So what are the screening tests for hemostasis? Platelet count, prothrombin time, APTT. Agreed? There is one test which is the most important test in hemostasis. The most important test. Dr. Jasmina did mention about that. It's history. This patient has no past, 45-year-old lady, no past history of bleeding. Her last hemostatic challenge was when she delivered a child 22 years back. Did not bleed, did not require transfusion. So there is some problem with PT and APTT. There is some limitation to the existing standard laboratory method. We now know that in vivo clotting is not stimulated by contact pathway or large doses of tissue factor that you see in PT agent, but very small amount of tissue factor, which is exposed during injury, which starts the process initiation, which takes on to what is known as amplification. I'm sure Dr. Namrata must have alluded about that. Then after amplification, where you have the formation of the tenase complex and the prothrombinase complex, you have the, which actually is enough to produce 100,000 molecules of thrombin. Just to make sure that's 100,000 and not 90,000, there's one more step called propagation, where factor 11 activated during the initiation process will create another tenase complex, prothrombinase complex, ensuring that there is going to be 100,000 molecules of thrombin. So from this pathway, it's very clear that if suppose 100,000 molecules of thrombin are created in the amplification, there is no need for propagation. So factor 11 may not be required. So you can also understand the sheer importance of factor 9 and 8. Without 9 and 8, no thrombin. So clotting driven by minute quantities of tissue factor is a more accurate reflection of in vivo hemostasis than PT and APTT. Then, of course, conventional clotting tests like PT and APTT will only show the initiation of the clotting through one limb, either the intrinsic pathway or extrinsic pathway, and not the entirety of the coagulation process. The rate of thrombin generation, the rate of clot formation, only the time. The acceleration, the velocity of clotting process is completely missed out. So basically, it does not assess global hemostasis, only the time. But at the same time, APTT should not be underrated. I still consider APTT as a fairly global test because prolonged APTT is good for coagulation or bleeding disorders. A shortened APTT can be an independent risk factor for venous thromboembolism. If you add activated protein C to the plasma and do an APTT, it can identify a very significant factor for venous thromboembolism. Very significant factor. It identifies antiphospholipid antibody. It's useful in monitoring heparin. And by doing APTT-based factor assays, it can confirm factor deficiency. It almost is completing coagulation, thrombosis as well as bleeding. But is it a complete hemogram, or can we make APTT little bit more global, as we found deficiency in the earlier slides? So people have been talking about other global tests like viscoelastic testing, which is done by two machines, either by thromboelastogram or Roten. It's basically a pin which is suspended in a cup full of blood. Either the pin is in motion or the cup is in motion. You activate the blood to clot, either the help with tissue factor or contact activator. Initially, the blood is in fluid state, the pin does not move along with the cup. But the moment the clot starts forming, the cup is connected to the pin, and you can slowly see the clot forming like that, gaining strength and creating a nice pick pattern, giving at least four important parameters. Clotting time, which is the time taken for the clot to start forming, which is same as PT and APTT. Then you have the clot formation time, that is the time for the clot to become slightly big to at least 10 millimeters, 20 millimeters. And then you have a parameter called as maximum clot firmness or maximum amplitude, which is basically the width of the clot. Now, one thing everybody knows that 80% of maximum amplitude or MCF is created by the platelets. 80%. 20% by fibrinogen. So if you have thrombocytopenia, your MCF will come down to 20%. If you have Glanzmann's thrombasthenia, your MCF will come down to 20%. So if you want to treat a patient with the Glanzmann's thrombasthenia by recombinant factor 7A, look at the MCF. MCF will become normal. Then there is something called the clot curve analysis, which is something that CMC has helped the world develop. Vellore has helped the world develop this clot curve analysis. We started first by just doing ourselves manually, getting data and then creating this, recreating the clot. So thing is, if you see, most of the PT and APT are timed here. That's all. That's all you see. But there is a lot of clotting process that's happening in this graph, which is called the clot waveform. Now, waveform is basically looking at the waveform is formed because of the rate of reaction. The rate of reaction is conversion of fibrinogen to fibrin with the help of thrombin. So it is measuring thrombin generation. So if I do the first derivative, that means a change of the reaction every second, I create a graph like this, which is called the first derivative graph. And I find a parameter called maximum of first derivative. Then I look at the maximum first derivative and I recreate another derivative of the first derivative. I get the second derivative, which is looking at also the rate of change of the first derivative. Now the first derivative will tell you the velocity of the clotting process. Of course, looking at the curve, okay, you can see, thoda acha hai. But if you do the first derivative, you get an objective value that this is good. That's the velocity of the clotting process. Velocity means the way the slope changes. And the second derivative will tell you the rapidity with which the slope turns. And that is called as acceleration. That indicates a burst of thrombin. Because if the curve has to turn suddenly like that, it can only happen if the burst of thrombin. And the second derivative maximum will tell you the burst of thrombin. So the first derivative maximum is velocity. The second derivative is the acceleration. And this is just on any APTT that you do on a coagulometer, which can show you the waveform. Many of the companies, we have helped them develop first derivative and second derivative, and they have got it on their coagulometer. Some people don't have, doesn't matter. You can do it yourself. You can download the data and do it yourself on an ordinary Excel sheet. Now, if you look at the first derivative of this is a roten, this is the first derivative of the roten. This is the first derivative of clot curve analysis. They look similar. Now there is one more graph which also looks similar, and this graph is from a machine called as thrombin generation test. This is real-time measurement of thrombin after stimulating the plasma to create thrombin. As the thrombin is being generated, it will act on a substrate, and the substrate signal is basically released. So you can see that, the thrombin, and it's a very fast reaction. The thrombin reaction is a very fast reaction. So you can see the amount of thrombin that is produced. The green one is actually the reaction, and the blue one is actually the first derivative. So you can see that in thrombus it's high, in bleeding it's low. And it also will show you the first 5%. Usually the clotting assays are in the first 5%, but the thrombin generation test will tell you more about later part of the clotting process. So it gives you 5 parameters. Lag time, that's the time before the thrombin will start getting generated. Then it gives you what is known as the time to peak. There's a peak thrombin where the thrombin peaks, time to peak, then the peak thrombin, which is the maximum amount of thrombin that's produced. And then it gives you the time when the thrombin will start dissipating. And then the area under the curve, the whole curve, is the total amount of thrombin that is produced. So 5 important parameters of direct measurement of thrombin. Now the first derivative of thrombin generation test looks like that, and these are all the various parameters. Now, what is the clinical application of thrombin test? It's used for hemophilia and bleeding risk, use of hemophilia treatment agents and monitoring them, because PT and APT will not be able to monitor them. Thrombophilia, recurrence of venous thromboembolism, and identification of bleeding risk due to DOAC. So here you can see patients with hemophilia. As the degree of hemophilia decreases or factor decreases, the thrombin generation becomes sluggish. And you can see those people who have severe symptoms have lower endogenous thrombin potential compared to those hemophilics who have got less symptoms. And these are patients who are being given 6 patients on whom they have, these are all inhibitor patients who have been given either bypass agents or recombinant factor 7A. And you can see that a particular value of ETP of more than 1200 indicate that these patients will not bleed during surgery. Less than 1200, they could possibly bleed during surgery. Now comes the thrombin generation related to thrombophilia. So here you can see this is a patient who is normal, the patient who has got no factor V Leiden, thrombophilic condition like factor V Leiden mutation, and this is a patient with protein S deficiency. Now what I do is I activated the protein C in this particular patient by snake venom called or thrombomodulin. I activate the protein C, and once I activate the protein C, you can see that the protein C, what does it does? It destroys factor V and factor VIII. So the normal patient, factor V and factor VIII is low, it becomes low. But patient with factor V Leiden mutation, you can see the thrombin generation is much better than the normal. And patient with protein S deficiency, it's very significant. So just adding APC makes a huge difference in identifying patients who real time can possibly a thrombophilic than just doing a thrombophilia workup. Then talking about recurrence, one of the most difficult things for a physician or a hematologist or a obstetrician or a cardiothoracic surgeon or a cardiologist to decide once the patient is on anticoagulation when to stop. Good percentage of them never stop. I've got a colleague who had pulmonary embolism. Okay, first pulmonary embolism, you have a certain period of treatment, maximum lineage 1 year. Then of course the theory is when will if suppose the recurrence happens, will it be a killer? Can be a killer, we don't know. But will it recur or not? Nobody can predict. But there are certain tests which can predict. And one of the tests is ETP, endogenous thrombin potential. There are 3 tests which actually predicts recurrent of venous thromboembolism in patients who have already had thromboembolism, and we can identify patients who may benefit from prolonged treatment. And this is patients who are on DOAC. We can identify whether the anticoagulant is working and the patient is bleeding because of the anticoagulant by looking at the thrombin generation test. Now look at the first derivative of thromboelastogram, first derivative of the clot the CWA, and look at the first derivative of thrombin generation test. Yes, see? Thrombin generation test requires a proprietary equipment. I think I am the only lab in the country which has thrombin generation test. Not because I wanted it, because we do a lot of projects. If you do projects, you can do. But I have never used this test to interpret any scenario because I am quite happy with my PT and APKT and routine test. I have a thromboelastogram, again because I am doing a lot of projects. It also requires a proprietary equipment. Did I need thromboelastogram to save a life? Not to this day. But I use it. I use it for certain other reasons because, one of the assays that's very expensive is factor 13 assay. Every patient who sounds like factor 13, I will not do the assay if I don't see the thromboelastogram pattern. The moment I see the thromboelastogram pattern, I select those to do a factor 13 assay. I can save money for the lab. But a waveform analysis, look at the curve. A routine coagulometer, I am able to see the same thing that is being derived by the rotem as well as by the thrombin generation test. What is it? It is action of thrombin on fibrinogen, conversion of fibrinogen to fibrin, which is dependent on thrombin. Okay, now look at the waveform. This is not waveform analysis, waveform on samples which we have spiked with factor concentrate to give a value between 0.1% to 30%. We have calculated the amount of factor VIII concentrate in the plasma to get 0.1. We know that most of the assays will not measure less than 1%, but doesn't matter. करते हैं इसको 0.2%, इसको करते हैं 0.3%, and we created those plasmas and looked at the waveform, and you can see there's a linear relationship between the waveform pattern as the factor concentrate increases. And interestingly, we actually assayed these less than 1% and found that we could find linearity of factor VIII levels up to 0.2% on all coagulometers. That means if suppose a coagulometer gives you 0.5%, we will classify the patient as less than 1% severe hemophilia. But he has got 0.5% factor VIII. That is when we realized 0.5 may be dumb hai. Okay, we'll report as 0.5. Okay, the hematologist can call it as less than 1%. So up to 0.2, coagulometers can measure one stage assay. And on these plasmas, we found that relationship between the TEC parameters, the TGT parameters, and CCA parameters had a very good correlation. Here for TEC parameters, we use CT or R time and factor rate levels. For TGT parameters, we use peak thrombin and factor rate levels. And for CCA, we use maximum second generation and factor rate levels. Now, between the machines, that is CCA versus TEC, correlation was good. Between TGT and TEC, correlation was fantastic. And between, these are on spike samples. Between TGT and CCA, the correlation was fantastic. All 0.9, nothing less than 0.9. Now let's look at these parameters in patients with grades of hemophilia, mild, moderate, and severe. So this is in TEC. Look at the R time, look at the K. This is CT, this is CFT, and this is alpha angle. So you can see that as the grade of hemophilia worsens, that is factor rate level decreases, you can see the median of the R time is prolonged, the CFT or the K time is prolonged, and the angle decreases. Similarly, for TGT, the ETP and peak thrombin also proportionately decreases as the severity of hemophilia increases. So also is the acceleration parameter of clot curve analysis, which is maximum. We used to call it clot curve analysis at that time because CWA was a patent on another machine, so we couldn't call it CWA. Now everything is called CWA. So they are also quite significant. Now let's compare these technologies with each other. Let's compare TEC with factor rate in these patients, and not bad. Let's compare TGT with factor rate in these patients. R value of 0.8, not bad. This is patients, these are not spike samples. Now between, and of course TGT also you can see good correlation. So how do I use this in routine clinical practice other than hemophilia? In some cases, it helped me identify a patient and also taught me a little bit of hemostasis, not a little bit, quite a bit of hemostasis. This 48-year-old male has been coming with a history of bleeding even before I joined CMC. As a 14-year-old boy, he has been worked up by Robert Carmen, he has been worked up by Annie Surashanam, by Uma Kanduri. They just said that his APDT is abnormal. All the time his APDT is abnormal, but all the factors are normal. So again, his APDT is abnormal. Now this guy is now coming all shaken up because he is going for an ophthalmic surgery for cataract. And he knows that if he bleeds like a tap, he will become blind. So now he's shattered that he has got an abnormal bleeding tendency and his bleeding score is not small. His bleeding score is significant. His APDT is abnormal. There's an abnormality, but nobody is able to identify how to treat it. So we did all the factor assays. All the factors is normal. PT is normal. So we started looking at literature. So somewhere it came that if you have a bleeding patient who has got a prolonged APDT and all coagulation factors are normal, it's called Pesovoid factor deficiency. Have you heard of Pesovoid factor? Yeah, literature search, I learned about it. But some of my colleagues who were training with me at that time, they knew about it. Obviously, they read better than we did. But they didn't know what it was. And they didn't want to know also because for them practice was going on very well. But I started questioning it. If suppose Pesovoid factor is so significant, because this patient was a significant fellow for me, he was crying. And if Pesovoid factor was really deficient, where does it come in the coagulation pathway? It has to come somewhere. Then I said, I will not take all this crap. Let me look at his clot waveform. Okay, now this is his APTT. His APTT, as long as you see, is prolonged. And you can see the waveform is slightly sluggish compared to normal plasma. You see that? That's quite sluggish. When I look at his PT, both look similar. Normal plasma and patient's PT, time-wise as well as shape-wise, the waveform looks similar. But then I do the maximum of first derivative and second derivative. APDT on the patient is definitely 1/3 of normal. But interestingly, on that same clot curve, the patient's PT maximum of second derivative was also 1/3 of normal. So he has a problem with the common pathway. But all the common pathway factors are normal. 10, 5, and 2. So I did what, we know that PT is, uses 100,000 times molecules of thrombin, thromboplastin to create a clot. So let's dilute the PT and see. So when we diluted the PT, of course, normal plasma also gets prolonged, but the patient almost looked like a hemophilic. You see his curve, this almost looks like a hemophilic. His AP rate is 100, his dilute PT is 131 seconds. And his clot curve also reflected 1/3 the acceleration parameter compared to normal plasma, as was reflected by his APDT as well as PT. So the conclusion was that this patient can form an extrinsic tenase with the help of lots of tissue factor, but cannot form a intrinsic tenase because APDT was abnormal. But when you dilute the PT, the intrinsic tenase was not forming. We know that PT has too much tissue factor. But diluting the tissue factor, we could discriminate the patient sample from normal. We also know that PT-based factor assays also have too much tissue factor. So we decided to do a factor 10 assay, factor 2 assay, and factor 5 assay based on APT. Factor 10 was 1.3%. And we gave the diagnosis factor 10 variant. Then we looked at literature on factor 10 variant, and we found that this patient fitted with factor 10 variant. Then we looked at literature on Pessoa factor deficiency, and it was describing my patient. So all the Pessoa factor deficiency was actually factor 10 variants, mistakenly called as Pessoa factor. It was first described by Robert Montgomery from Milwaukee, and then we actually presented this patient in IST at Geneva, and he came specifically to read this poster. And I was standing there, and the title of the poster was Pessoa factor does not exist. And he told me, I always knew it did not exist, but somebody had to show me that. Yeah. Now I realized that this is a mutation on factor 10, which it attracts to factor 8. This particular pathway, this particular area, the green area, which attracts factor 10 to factor 8, goes missing. So factor 10 does not have the ability to attach to factor 8 and will not be able to form a tenase complex. So intrinsic tenase is not formed in this patient. This patient, we finally told the patient we have a diagnosis. He was so thrilled. He danced in front of us. So we told that previously when you bled, you were getting FFP. Even now also you will get FFP. Nothing is going to change. But after that he sent 3 of his relatives with bleeding disorders. All of them had the same problem. Okay, utility of CW every day, especially for labs which run PT, APDT and have a lot of headaches with prolonged APDT. If you have a waveform which has got a biphasic waveform, if it's early biphasic, it is because of lupus anticoagulant. And if it is late biphasic, the patient is undergoing severe bacterial sepsis or severe SIRS. In fact, this was almost becoming a criteria for DIC before the machine was being out of production. So that is the person. This is the person whose successor was the chair of the DIC subcommittee, Jako Tachil. Now, shortened APDT, and we know that there is a significant relationship between shortened APDT and venous thromboembolism, something that Tripodi has been following up. And he almost correlates it with the study that was done for D-dimer, 1 month after stopping anticoagulation. So a shortened APDT was mostly associated with very high levels of 8 and 9, even 11 also. And they also found that APDT in the non-blood group O and the blood group O group usually have low factor rate. Non-blood group O have APDT is usually shorter than O group. Now, can that have an impact on the rate of thrombin generation? So this was a study that was done by Legani, which showed that after 2 years, probability of recurrence of almost 17.5% in patient with a shortened APDT compared to 7.5% those who were normal APDT. So these are the three tests which are important for identifying recurrent or rethrombosis. D-dimer, thrombin generation test only in pediatric population at this stage, and increased levels of factor VIII. So can the waveform reflect hypercoagulation in those who have shortened APTT? Now here you have a patient with shortened APTT and you can compare their minimum first derivative and minimum second derivative. Velocity and acceleration parameter is almost twice another patient who has got shortened APTT. So this can be a variable. This can identify those who are more hypercoagulable than others who may have a shortened APTT. Similarly, another one shortened APTT here. This is actin FS, and you can see that 3 times the velocity and acceleration parameter compared to another patient who's got. So these are all possibly hypercoagulable patients. Thromboelastogram similarly can identify hypercoagulation. So here both are very hypercoagulable pictures. Now, are they thrombophilic? Are they hypercoagulable? Are they patients undergoing thrombosis? Are they thrombotic or have they developed thrombosis? So the question is very much evident when you see a graph like this. So we actually did a study. You know, the orthopedic department has one problem: thrombosis after hip replacement, very high. So they put them on standard prophylaxis, 20 milligram of flexin, which is nothing. In fact, during COVID also there was on 20 milligram standard prophylaxis, but it's nothing for us. But for the cardiothoracic, I mean for the orthopedic surgeon, it's a pain because 20 milligram there is increased bleeding. A surgeon wants a clear field. That 20 milligram crosses bleeding, not bleeding, but the field needs to be kept on, patted with a gauze every time. They were not happy about it. So we did a study to find out a pattern like this, will those people develop thrombosis? And that study was negative. The patient, those who had very hypercoagulable thromboelastogram did not have thrombosis. Instead, those who had thrombosis actually did not have anything like this. So now the study has been finished sometime back, 3 years back, where we said that, okay, the philosophy is that the surgery is the one which causes thrombosis. So let's study the patient post-surgery, whether the impact of surgery has any effect on thromboelastogram. So data is with one guy is having a good time in UK on study leave. So okay, now looking at these patients, we are not sure whether, so D-dimer is something that we must look at, because thromboelastogram is blood, you add an activator outside and activating the blood. This is totally a in vitro test. We are wanting to show an ex vivo phenomena. We are not sure because it's not an entirely ex vivo phenomena. We are stimulating something from outside. So if you want to see something ex vivo, it's D-dimer. D-dimer is something that's happened inside the patient. So the top patient has got a very high D-dimer value. So I immediately called the vascular surgeon. I said, there is a patient who has got this, who came and gave the sample in the morning. He's got a very hypercoagulable thromboelastogram. His D-dimer is this. Is he already in the ward? So he said he's not in the ward. So I said probably he'll land up in emergency with a bad thrombosis. And yes, he did land up with a thrombosis. And the registrar went and asked, how did you know that this patient is going to come with a thrombosis? So he said that God works in the Asha building 5th floor. So will a thrombophilic individual always reflect a clot pattern on routine? Does an identification of risk factor correlate with such a pattern? And this test then will be reflecting the sum of interacting factors. If so, it can be the best and the most simple predictor of hypercoagulable state. That is a great potential to clot when stimulated. And with the help of a D-dimer in your armament, play God. Thank you. So my guru, Emmanuel Favaloro, SME, he always says, hemostasis equals love. Everybody talks about it, no one understands it. Thank you. Any questions?
I think the house is open for questions.
Okay.
Thank you, sir. So
I request ma'am to announce our next speaker.
have the next talk by Dr. Varun Paul, Professor of Pediatrics and Clinical in Charge, Thalassemia and Hemophilia, GTS and SET, Faridpur. The expert area is pediatric hematology, especially thalassemia and hemophilia, the regional NRP trainer, and pediatric endocrinology, especially pediatric diabetes. He has won several awards and honors.
Ma'am, thank you very much, ma'am. Ma'am, thank you very much. I feel so belittled in front of the doyens of hematopathology and hematology over here. So, it's out of the box that I'm coming here as a pediatrician and trying to say something about, some, drugs which sir has already used and probably forgotten also in his career, because sir was talking about so many projects, and I believe that all these extended half-life projects sir has already used and utilized them in his common practice. So greetings from the Department of Pediatrics in Baba Farid University of Health Sciences, and from the holy land of Baba Farid ji, that is Faridkot. I come from Faridkot. And thank you very much, Dr. Rashmi ma'am, for giving me an opportunity to be here and present to you this topic, and also Dr. S.P. Verma for being a support. And we have conducted two conferences over there, wherein we had the support from KGMU over there for our pediatricians as well as pathologists as well as the medicine people. So my topic for today is hemophilia management and treatment individualization with EHL factors. So before we go with the presentation, so I would like to discuss some basic tidbits about hemophilia. So I believe most of the people are here from pathology. So clinicians maybe less, but I believe what Dr. Tathagat said, that bench to bed and bed to bench. This is where we have to actually be running. And if somebody has a card to play, and then we clinicians can be very easily we will be actually treating the patients, and the magic is working in the lab, and we are making the patients all right. So unless and until we have people like Nair sir behind our back and telling us and giving the equas for majority of the laboratories, and we are also having one talk with yours institute, so that we also want to have equas with CMC for our institute also for the coagulation labs. Yes. So last 50 years of hemophilia, this is a very beautiful paper by Dr. Tulika ma'am, and lot has changed in the field of hemophilia in the last 50 years. So it's a golden era if we summarize it. So there has been a lot of development in the field of hemophilia, right from the plasma initially, which was used, then cryo, then the different types of plasma-derived factors and all, and now we have non-factor based therapies which are coming up in a beautiful way. So if we talk of the current status of hemophilia in world, so this was the annual global survey which was done in 2023, and all these surveys and all the World Federation guidelines, we are blessed to have, as Dr. Nair already said, that Dr. Alok Srivastav is the flag bearer, torch bearer of these guidelines. He is the primary author for these guidelines, and we're blessed to have sir as our mentor in the field of hemophilia. And all these guidelines are basically coming from all of the world, but under the chair of CMC Vellore under Dr. Alok Srivastav sir. So in this survey, we have seen that around 10% of the population, world's population of hemophilia, it's contributed by people with hemophilia in India. So global population percentage, as Dr. Nair already has emphasized, coagulation is not easy. Coagulation can be done by anyone, but to have it in a standardized format, it's very difficult. So we have the tip of the iceberg in terms of patients diagnosed all over the world. That includes India also. But even if in that tip we are having 8 to 10% world's hemophilic population, that is huge. So as we discussed already, there is a hell lot of progress going on in the field of hemophilia, and right now we are blessed to have almost all the therapies which are present world over with us in our treatment armamentarium. If we talk of the non-factor therapies, yes, we are having emicizumab with us, and it is being used all over the country right now. And I was coming to know that we are also having to have concizumab very soon. It has been given the permission by the CDSCO, and probably in 1 month we'll be having the permission to use it for hemophilia B for both inhibitors and non-inhibitors. So let's talk about the management of hemophilia comparison of SHL versus EHL. So EHL is extended half-life factor and SHL is standard half-life factor.
So, what are the key unmet needs in hemophilic persons? I dare to use the word patients because these are basically persons with hemophilia just deficient in a factor which God has not given them. And of course, if we give them the factor from outside, they will have a normal life just like any other individual. So that's why these are persons with hemophilia. So, when we talk of the world standards, the World Federation of Hemophilia, last time I remember when we were in NHU, Dr. Alok sir said that we came to this conclusion a little late in giving this guideline that prophylaxis should be the standard of treatment. So probably we came too late, but it's never late. So prophylaxis is the treatment and the way forward, whether it is in the form of a factor or whether it's in the form of a non-factor therapy. Prophylaxis has to be the way forward. But prophylaxis in terms of factors, when we say in the standard half-life factors, it's a big injection burden. So you have to give at least 2 to 3 pricks in a week, which amounts to a lot of injections we'll discuss. Now, second thing is that is the drug which we are giving having the particular control of having those micro bleeds being stopped. We are talking of the actual bleeds or the hemarthrosis which is being stopped. But is the micro bleeds getting controlled by what we are giving? And even if the persons with hemophilia will get access to factors, but in terms of prophylaxis or regular replacement therapy, but surgery is there. Surgery will remain there. They will have trauma. They will have surgeries. So appendicitis anybody can have. Persons with hemophilia are not immune to that. So road traffic accidents anybody can have. They are not immune to that. So at that time they need a factor which is fast acting, which is trustworthy at the same time. So the conventional factor dosages have been divided into 3 types. That is high dose prophylaxis, intermediate dose prophylaxis, and low dose prophylaxis. So what we have been fortunate enough in India in most parts is that we get only low dose prophylaxis for our persons with hemophilia, especially children. And it is very difficult to actually persuade the government for giving these factors for these persons with hemophilia. Now, whenever we use the word prophylaxis, so they tend to say, why prophylaxis? What is prophylaxis? We don't want to give, you are giving on-demand treatment, that is more than enough. We will not give you money for this. But when we try to, get to them, like, okay, if we titrate down the dosages and at the same time, your factor usage will be almost equivalent to on-demand and the price will be almost equivalent to on-demand. So there come the papers which Dr. Verma has also already published also in terms of EHLs also, and we are also in the process of publishing one paper with SHL. So we are having a very good data with respect to these children, especially what we did was in adolescents, sir. So we have a comparison of the money actually they were incurring prior to enrolling in the trial and after trial. So it is almost similar, but the quality of life and the bleeds, they're phenomenal. So we are not talking of high dose and intermediate, we're just talking of low dose prophylaxis. But if we talk of the actual real sense in the world, so we have to give dose which should at least be, when it's the nadir or the trough levels should be at least in the mild to moderate. We are taking moderate, 2 to 3%, at least it should be 2 to 3% when we go to hit the nadir. So with this low dose prophylaxis, it usually tends to go into the again severe hemophilic range. So we already discussed that with SHL based prophylaxis, there is a high frequency of infusions, and this often leads to poor compliance. And as of yet, we as a global standard, when we are giving prophylaxis, it has to be in the form of home based therapy. Now, children or any person who is working or is going to school, you cannot call him day in and day out. So every third day you should come to the hospital. So they have to come from 50 kilometers, 100 kilometers, maybe 150 kilometers. So you will tell him, don't go to school, come and get the factor. So, one example which has been done and which has been given by, Dr. Bilal, he is from Srinagar. So they have given home-based therapy to all the kids and they are doing phenomenal. And they have had zero bleeds. And most of the patients are like all inhibitors are on non-factor therapy also. And here, the annualized bleeding rates are not always zero with this prophylaxis. And joint disease, as I already said previously, they're microbleeds. So microbleeds cannot be controlled by low dose prophylaxis. So they tend to cause the irreversible joint damage in the coming times. Now, if we talk of the prophylaxis with EHL versus SHL products, so the trough level is the most important thing which we have read. Now, In terms of the EHL products which are available right now in the country, we have two products which are available. So one is N8GP or Esperoct, and another is Adinovate. So there is Eloctate, which comes from World Federation or HF. We get the from the World Federation grants. So they are those near expiry factors which they give to HFI, and they distribute it to the different institutes and different societies. But as a government, we are getting these two types of factors. There is one factor which is also available in the world. It comes by the name of von Willebrand conjugated factor with pegylation, that is Altuvio. So which is not available right now in India. But we are having this 1.4 times to 1.6 times half-life elevation, wherein we can get the factor, half-life from 12 to 18 to 19 hours. But for factor 9, this has changed dramatically. So factor 9 half-life has gone up to 93, 96 hours. This is something which is beautiful. Like 18 hours to 93, 96 hours. So this is, one thing which has given a best possible treatment outcome for persons with hemophilia B. So if you see in this, slide, the reduction of infusion number is 30% in case of hemophilia A and around 60% in case of hemophilia B if we give them regular replacement therapy. So as already discussed, the benefits with EHL are huge. So we were talking regarding this non-factor therapy versus EHLs and versus SHLs. So we had a talk with Dr. Guy Young from US and Dr. Jerry Dolan. He's also from Hemostasis and Thrombosis Center. So when they did the Haven 7 trial in which they included infants, so it was a very beautiful thing which came up. Like they said, some of the parents refused giving non-factor therapy to the children. So they were afraid of the consequences of inhibitors, or if inhibitors will develop, what will we do if they have a life-threatening bleed? What should be done? And some of the patients even shifting back from non-factor therapy to EHLs because they have a life which requires more of factor in their body. So with non-factor therapy, the maximum will be around 16 to 20. But with factors, you can go even up to 100%. So those who are actively engaged in high velocity contact sports, they want a shot maybe daily. So they are getting that and they are shifting towards that. But if we talk of prophylaxis in this part of the country, so definitely there is a decrease in the injection burden. There's a decrease in the joint bleeding rates. And as we will see in the different trials which we see with these two products. So we have N8GP and N9GP, that is Turoctogog alpha pegol and Nonagog beta pegol, that is EHL factor 8 and EHL factor 9. So I will not go into the details of pegylation because most of you know pegylation better than me because it's a part of the pathology and pharmacology. But yes, because of the pegylation, there is a decreased clearance from the body and the factor remains for a longer time in the body. And PEG is a inert moiety. So there were a lot of concerns regarding PEG leading to different problems. But we are playing with PEG from so many years because first PEG was introduced with interferon while treating HCV. So we have had a long experience with PEG-related products and they are not having that kind of toxicity or any kind of carcinogenicity. So N8GP has a half-life which is 1.6-fold longer than the previous factor 8 products. And this 60% longer half-life contributes to the ease of giving this drug, and as we will see in the following slides. So if we see the PK parameters, so what is recommended is 50 IU per kg every 4 days. So it's not twice weekly; it is every 4 days. So the days will change in the subsequent, administrations. So if we see that the nadir or the pre-dose factor rate before we give the second dose is 3%. So the patient or the person with hemophilia will go into the moderate range. He will never be a severe hemophilic while he is on this regimen of 50 IU per kg every 4th day. So what was the primary endpoint in terms of N8GP? So when we are talking of a person with hemophilia, the biggest problem or the biggest curse he faces is a bleeding. So how do we measure it in the part of our scientific practice is an ABR or an annual bleeding rate. So you can see the ABR interquartile ratios along with the main phase 50 IU per kg every 4 days, and there was one more extension phase wherein they used a 75 IU per kg every 7 days. So it reduced to 1.18 and 0.8 in the main phase and extension phase, and 1.67 in the 75 IU per kg extension phase of. You can see the ABRs were continuously decreasing over time with the factor exposure to these patients in the two arms. And if we talk of the zero bleeds for the every fourth day and every seventh day, it has been gradually increasing in both these arms. And 64% of the adolescents and adults, they had zero for these patients in majority of the patients. So fewer injections. If we talk of, we discuss that there are 52 weeks in a year. So if you give every seventh day, it is 52 injections only, as compared to EOD doses of 182 injections. It's too much for the annualized bleeding rate and target joint resolution. Now, target joints are something which is, we as pediatricians, as well as any person who deals with adult hemophilia practice, we fear these patients. So they come with a spontaneous joint bleed and they are crying in pain and agony. So if we talk of using NHGP, 70% of the children, they had zero bleeds at 5th year of treatment. So the crux in this NHGP was that there was an overall reduction in the target joints. And if we talk of the resolution in terms of percentage, 100% of these patients, they had a target joint resolution. That is, they did not bleed in these target joints for more than 6 months. SHL products, you have to give at least 2, 3, 4, 5 days of therapy, maybe sometimes twice in a day, therapy for controlling the bleeding, 2 injections. So they also saw the response to surgery. So major surgery in these previously treated patients. And for path residents over here, there are 2 kinds of patients for hemophilia when we talk in the terms of clinical practice, when they have not been exposed to any factor product. So PTPs, at least they have completed 150 exposures of the drug. So exposure days for factor 8 used to be, if you give 2 times, because 12 hours is the half-life, if you give 2 doses in a day, it still counts 1 exposure day. For factor 9, because it's to be given only once, it's 1 exposure day. EHL is to be given 1 day, so that will count as 1 exposure day. So hemostatic success rate was 95.5% on completion of surgery. So this is the break of surgeries which was done. So only 1 patient had a hemostatic response missing, and that was because of one of the complications of hemophilia A, that is inhibitors. So this patient had inhibitors. So there was no fatal event. All adverse events were in line with the expectations, and no lab safety data was seen, and no vital signs of physical examination data of concern was seen. So there is a real world experience also. So we have been using factor 8 EHL and factor 9 EHL for last 1 year now also in the state of Punjab, and we are having very good results. Right now we are using only on demand therapy. So we have not been given permission for using these factors for regular replacement. So factor 9 has been specifically asked, maybe only few vials for surgical patients. So we are planning to take up surgical patients on factor 9. And as we'll see in the factor 9, that is N9GP, it has got a class leading PK characteristics. So you can see 1 dose of factor 9, you give it 40 IU per kg and you forget. So it will last for 1 week and it will go up to 20%. It will be in the range of around 15 to 20%. It will not go beyond that. And if you talk of going into the non-hemophilic range, it will take around 23 days. So we have seen this response, when we had given this factor as a, because Punjab is having a coordination with PGI. So some of the patients, when they go for a surgical procedure over there, so they just give 1 dose of factor 9 and the surgery is done. Major surgery is done with factor 9. So we have given, you can see, so mean steady state trough levels with factor 9 and 9GP is 27.3%. That is mild hemophilia. And as we know from the clinical practice, what we see, these mild hemophilics, they rarely bleed. Spontaneously, they don't have any bleeding. And with 10 IU per kg, if we are giving once in a week, it is 8.56%. Still a mild hemophilia. So even if we decrease, we can have a good life in terms of the ultimate bleed outcomes. So factor 9 levels will be above 40%, means normal range, almost normal range for a mean of 5.4 days out of 1 week. So time to 1%, as I already said, is around 22 days. So again, the metrics in terms of the measurement of efficacy of this drug is in the form of ABRs. So it has been widely tested in adults, adolescents, and children. So there was a trial in Paradigm trials. They have seen that the median ABR reduced to almost zero, with a spontaneous ABR reduction of zero and median ABR of around 1. So if you talk of prophylaxis, it has gone to less than 1, for majority of the patients. And for spontaneous ABR and traumatic ABR, it is again on the lower side. So if we talk of overall safety analysis with N9GP, so we know that factor 9 patients usually do not have inhibitors. Even if they are inhibitors, they are mostly transient, and even if they have inhibitors, before they develop inhibitors, they have hypersensitivity reactions, they have anaphylactic reactions. So out of around 60 patients of hemophilia B in our state, we just have one inhibitor positive, and he was diagnosed in PGA. So he had a high titer inhibitors. He's now on on-demand therapy with a factor 7. So no thromboembolic events were seen, no safety concerns were seen, no neurological concerns were seen. So how do we individualize these doses? Now comes the role of what we call as PK-based dosing. So, when we talk with the government also in terms of giving factors or regular replacement, our main target is children, because we don't want them to suffer the crippling which, the adult persons with hemophilia have. So if we have a line in place where we can individualize the dosing, so there are some calculators available, there are some, factor assays by which we can actually individualize, because, children, they are fast metabolizers. They require more doses as compared to, adults. So we can have a dose titration based on the type of bleeding, because the phenotype and genotype, they don't have always a correlation. So we have to classify or divide the treatment on the basis of phenotype and the PK. At what level we want to keep the factors, and at what level that person with hemophilia or that child with hemophilia will have that factor nadir, maybe around 2 or 3%. We can target 2 to 3%, and then we can get the factors which is based on actually PK based characteristics. So treatment individualization can result in improved protection in bleeds, and at the same time save the state exchequer. As Dr. Dinesh was talking in the morning only in the first lecture, that we in India are always after the government funds, and government does not have funds for just one disease. So they have to take care of, if we talk of the more burgeoning problem, it is diabetes, tuberculosis, it's infective diseases. For them, probably hemophilia is a handful of 20,000 patients. So they don't want to spend, crores of rupees at the cost of other diseases being mismanaged. So we have a small quantity, small budget allocated for this disease, and we have to accordingly manage. And if we will give the government a plan by which we can individualize and we can keep the cost factor also in play, then these children can be saved from the ultimate crippling. So what we are aiming is that we should have a hemophilia wellness throughout India through establishment of, not just EHL, but other non-factor therapies. So there's a lot of, developments coming on in the coming years. So we have emicizumab, we have concizumab, which have already gained the marketing acquisitions, and we have Mymate, which is coming. We have fitusiran trials also almost completed. There's martesizumab. So there are a lot of non-factor therapies in which you just have to give subcutaneous injections, and the person with hemophilia, child with hemophilia, is happy. And ultimate clinical outcomes, the bleeding frequencies, the injection frequencies, and the social outcome. And I'll tell you, with these non-factor therapies, these children, they usually say that we don't have hemophilia. So they come to us, they come in a playful mood, and if they are on the right therapy with the right duration and the right type of rehabilitation done for them, they forget they have hemophilia. And this is the ultimate, achievement of any clinician and any person from the lab also, that once we work together in cohesion, along with having these patients have the best of the life in terms of the treatment. That is our ultimate outcome. So with this, I'll thank you. So any questions?
Thank you, Dr. Paul, for finishing the environment with that. Any questions from the house?
Yes, sir.
You mentioned about measuring factor levels, especially in the pharmacokinetics.
Yes, sir.
Were you able to do that?
Sir, we were not able to do that. There is one PK-based calculator which was given by, I think, Takeda. So we tried to, but we do not have, as I already told, sir, we are in the process of establishing the coagulation lab. So we'll require your help in that, sir.
Sure. The only thing is, chromogenic assays are not very commonly used in our country. And chromogenic assays have been highly recommended by those who have chromogenic assays because they have not done any other work. They could have. So the thing is, these coagulation factors can be measured by one-stage assay without doing chromogenic assays using a different type of standard, which actually now the world is also doing for emicizumab.
Yes, sir.
So they are using a factor deficient plasma, adding emicizumab and using that as a standard. Similarly, if you use these factors in a factor deficient plasma and spike it to 100%, we can use one-stage assay. You don't need chromogenic assay. So maybe we should all various centers work together and develop data and show that that's enough. Because I know the people who promote chromogenic acids, and there is a huge conflict of interest. It's not just huge; it's very huge.
Thank you, sir. Sir, I remember the wordings from Sir Robert Hutchinson, who is considered as the father of modern medicine. So he has briefly summed this thing into a single paragraph, which all of us have read in the clinical methods. So from inability to let well alone, from contempt for what is old and for contempt for what is old and too much desire for what is new, and from inability to let well alone, and from making the cure of the disease more grievous than endurance of the same, good Lord deliver us. So probably, sir, you are right in saying that we should know when to stick to the basics and when to follow the newer things. Thank you, sir.
Thank you so much, sir. I would request Dr. Vijay sir to please present the token of appreciation to Dr. Varun sir. I thank all the chairpersons for the session 3. Now I would like to invite chairpersons of the session 4 on the dais, Dr. Sanjay Mishra sir, Additional Professor, Department of Pathology, KGMU Lucknow, Dr. Nishant Verma sir, Additional Professor, Department of Pediatrics, KGMU Lucknow, and Dr. Geeta Yadav ma'am, Additional Professor, Department of Pathology, KGMU Lucknow on the dais.
So, our next speaker is Ruchi Gupta ma'am. Ma'am, slow introduction. Ma'am is looking after the Department of Lab Hematology in LGPGIMS, and she has 14-year experience in hematopathology with special interest in hemoglobinopathies, coagulation disorder, aplastic anemia, and MDS. Ma'am has approximately 90 publications and 16 book chapters. Thank you, ma'am. Over to you.
Thank you, Geeta. And as Dr. Varun said that in the presence of the doyens of coagulation, actually I find myself standing nowhere. I'm more of a jack of all trades, which can be fitted everywhere. So in my past, though I do agree that I am a little plateletophilic, so I have some experience of working with platelets, and that is why I thank Dr. Rashmi for selecting this topic for me. Where I have to talk about platelet aggregation studies, conventional versus flow cytometry based techniques. So, just a little basics for the students over here. This is one very important cellular component of coagulation. which is approximately 2 to 4 micrometer in size, and we all know that the normal levels are somewhere between 1.5 to 4 lakh. It is a very dynamic structure which has a very short half-life. And when we talk about platelet-related defects, they might be either related to the counts or they may be related to their function. And whatever the reason be, either the count is low or their function is defective, they usually tend to present with mucocutaneous bleeds, and the degree of severity naturally being correlating with the underlying defect. So once we are sure that thrombocytopenia has been ruled out in terms that we have seen the CBC reports, we have seen the smears, we have ruled out thrombocytopenia due to anticoagulant effect and so on, if we have a mucocutaneous type of bleed, there are usually two kind of defects which we commonly think of. One is platelet-related disorder, and the second is a von Willebrand disease. Though I frequently also say that the rare bleeding disorders also tend to frequently present with epistaxis. So there you need to really do a PT, APT also. And before somebody starts thinking of a platelet-related functional disorder, all other tests, including counts, ideally should be normal. So when the moment you think of investigating platelet-related functional disorders, there is actually a armamentarium or an array of tests which are available. And naturally, I think it goes by default that the first test starts with the history. And naturally, you expect that all other basic coagulation screens and your lab parameters like platelet counts, as I just stressed upon, are normal. And the patient has come to you with some kind of a mucocutaneous bleed. Bleeding time, Dr. Jasmina talked about, is one of the very commonest, I will not say it's not one of the commonest tests, I would say it is one of the tests which does not really require any infrastructure, though it requires a lot of training, and it will pick up a severe type of platelet type of bleeding disorder. But again, the point is that it will not classify the type of defect which we can do with the help of more advanced techniques. So then we have the point of care testings, that is the platelet function analyzer. Then we have the light transmission aggregometry, flow cytometry, then verify now for drug monitoring. Then Sir talked in length about the global tests in hemostasis. And when we talk about platelet related disorders, then you will always find a mention of electron microscopy to study at the platelet ultrastructure, the granules and the granular content to diagnose the storage pool defects or the granular defects. So if you look at the ISTH recommended guidelines for investigating a patient with suspected platelet function disorder, once you are done with a good history, CBC population screen, which I just emphasized, including a VWD workup, the next important tests which are to be done, which are related to the platelets, are light transmission aggregometry, flow cytometry. These are your initial investigations, and a extended panel of these tests would be considered as a second line of investigation, followed by genetic testing. So these are some basic investigations which one needs to carry out when we are suspecting a platelet function defect. So my today's agenda, I'll focus more on light transmission aggregometry versus flow cytometry, because I think when we are actually specifically talking about diagnosing a platelet-related functional disorder, these are the two most commonly or widely used investigations. I'll talk in brief about their principles, their strengths, their weaknesses, and at the end, a competition or basically what is the degree of agreement between the two techniques. So before I move on to the test specifically, a little basics again for the students, because I feel that to understand what a test is doing with the platelets, you really need to know that how complex this small anucleate structure is. It has a lot of surface glycoproteins. It has three different type of granules. It has those actin and myosin filaments which get activated which transform when the platelets are activated. And this is what is happening in vivo, that initially whenever there is an injury, the subendothelium is exposed, and the interaction of the group 1p95 is important with von Willebrand factor and the interaction of the collagen receptors with collagen, so that there is a platelet adhesion. This is followed by inside out signaling, which is where we call platelet activation, and subsequently there is aggregation because the 2b3a receptor gets activated and helps in the cross-linking of fibrin, and all the platelets they start coming together and forming a platelet plug. So whatever the investigation tool which we are using, they are trying to replicate what is happening in vivo. So we try to see whether is there an adhesion defect, is there an activation defect, or is there an aggregation defect, and that is how is also we use to classify the platelet related disorders. And to simulate in vitro to see what happening in vivo, we use different agonists. Like we use ATP for the receptors for ATP, that is P2Y1 and P2Y12, which are there on the platelet. Then you have thrombin or TRAP for the PAR receptors. We use collagen or convoluxin or CRPXL, which are basically collagen related peptides to stimulate the collagen receptors on the platelets. Then we have ristocetin, which facilitates the interaction between group 1B95 and the mononucleotide factors. And then we have arachidonic acid and thromboxane A2 and its mimetics, which help us to understand the downstream pathways. That is what happens once these receptors are activated. There is this cyclooxygenase pathway and so on, because of which the platelets are activated, the granular content is released, and the platelet undergoes all those adhesion, activation, and aggregation. So again, a little just for the benefit of the students, this is how a light transmission aggregometry principle works. You have a light source, you have a platelet to a plasma, which will allow all the 100% of the light to pass. Sorry, and then you have your platelet-rich plasma, wherein the light is diffracted. When you add an agonist, your platelets will start clumping, and more light will be allowed to pass. So what we are recording in this equipment is the transmission of light through a sample, which is stirred by basically which is a stirred PRP at 37 degrees centigrade, and which is activated by the addition of an agonist. And now how much light is allowed after the platelets have activated, that is compared against the light transmission which was happening at 100%. And this is somehow what the plot looks like in a chronolog aggregometer. This is where the peaks over here are reflecting where you have added your agonist, and these are your aggregation curves. So these curves are telling you the initial shape changes which happen on the addition of an agonist, the primary wave, which is usually appreciated when you do an epinephrine based or a low dose ADP. Then you have the release of the granular content, because of which you have the secondary aggregation, and finally this is stable. So any aggregation response which is more than 50% and reaches up to 95%, and then which is stably there. Like once the platelets have aggregated, they should not disaggregate. So this is a normal pattern. And you have used different agonists which the machine is telling you, like each of this graph is just reflecting the different agonists which you have used to develop this normal aggregation pattern. So once you know what is normal, any abnormality can then be picked up, and which helps in the diagnosis of the common disorders like Lanzmann thrombocythemia, Burnout-Schauer, and some storage pool disorders. So anybody who feels that light transmission has gone out of fashion and now flow is going to replace it or something, let me tell you, in the past 10 years, there are more than 300 publications related to light transmission aggregometry. There have been so many publications and guidelines which have tried to ensure that there is minimal inter-lab variability in the results of light transmission aggregometry. And this is a very recent French position paper which has actually compared what different guidelines are stating. So if you go through these guidelines, all of these are telling you about the very important three analytical variables: when to test the needle, do not use a tourniquet, do not use a PTS system, avoid tell the patient that you should refrain from any smoking or physical activity before sample collection, and so on. So there are a lot of recommendations and lot of publications and guidelines which are actually actively telling us how to proceed when you are suspecting a platelet function defect, how to collect the sample, and how to go ahead with the test. It is also giving us a list of agonists. These are the first line agonists, which includes ADP, collagen, epinephrine, and ristocetin, which are the first line agonists to be tested. And this is a chart from this French positional paper, which has actually compared what is the dose concentration of the agonist to be used. And different guidelines have some variability, but at the end of the day, if you see, they are largely lying between 0.5 to 10 micromolar. Like we are consistently using a concentration of 5 to 10 micromolar in our lab. Similarly, there is recommendation for collagen, epinephrine, and ristocetin. And once you are done with the first line agonist and you still suspect that there is a functional defect, you may go ahead with the second line agonist, which includes TRAP, CRP, convoluxin, ionophores, and so on. But we have limited experience and we have really not used any of these for light transmission aggregometry in our lab, except now that we have started using TRAP in flow cytometry. So this is a good tool when there is absent response to almost all agonists. I think it will very beautifully pick up Lanzmann thrombocythemia. Similarly, when there is absent response to ristocetin, while all other agonists are showing a good response, that is usually in favor of Burnout-Schauer, provided 1 milligram has been worked up. We have checked the smear is showing giant platelets and so on. And if you can complement this with the luminescence mode of the equipment, where the ATP secretion is also simultaneously studied, then if you see the graph down over here, this is from a paper published. We are not using this essay in our lab, but here what we can do, a luciferase complex is being used, and the release of ATP is also being simultaneously measured when you add an agonist. So if there is a storage pool defect, if the ATP is not released, then this graph, if you can see, the green is normal and the black is abnormal. So you can also go ahead and pick up storage pool disorders. So not only are we able to measure the degree of aggregation, but also release of granular content with the help of a light transmission aggregometry equipment, specifically chronolog, which is also simultaneously measuring this luminescence. All looks good and rosy, but still the light transmission has its own issues, in the sense that there is a lot of almost all thing is manually done. So the people have the newer advances in light transmission is that now we have some coagulation analyzers where this has become automated, like 6mix CS210 2100 is one such equipment, and this is taken this from the net, and I personally don't have any experience, but we have heard a lot about this equipment and this is giving very good results. There are publications to support that the CS 2000 2100i has shown excellent repeatability, strong correlation with the Chronolog 700, which is one of the most commonly used equipments. It can work with relatively lower platelet counts. Like normally for a standard light transmission aggregometry test, your platelet count should be more than ideally 1 lakh or at least more than 80,000. So it is being claimed that this equipment can work with a relatively lower platelet count. The amount of sample which is required for putting up this test on this automated platform is also low. Like when we are using Chronolog, we need at least 500 microliter of PRP per agonist. That makes up to approximately 2 to 3.5 ml of the PRP which has to be prepared. So you need to collect at least 10 to 15 ml of patient sample, or we routinely collect at least 3 citrate vials from each patient. So that becomes challenging when when you have a pediatric patient. So if you can reduce the sample volume, if you can go down to relatively lower platelet counts, then definitely this is something to look forward to. And I think this in the times to come, when there are more such analyzers available, this definitely looks like a very attractive option to me personally. So problems with LTA. First, I spelled out that a large volume of sample is required. It is not recommended for platelet counts when it is less than 1, or I would not say 1.5 lakh, less than 1 lakh. It can miss mild storage pool defects. It is recommended to do the processing within 4 hours of sample collection. And then it is genuinely not the ideal method of testing. Why? Because you've taken the whole blood, then you have prepared the platelet rich plasma. आपने इतना centrifuge करके पहले ही platelets को इतना agitate कर दिया है. Then you are telling कि now you put it to rest and then you test, and so on. Though I think all said and done, though it gives good results, but when we see all these problems are getting solved by flow cytometry, and hence flow cytometry seems to be a very attractive or a lucrative option. This amount of sample which is required for flow cytometry is very small. If you ask me, per agonist, I require only 5 to 10 microliter of the sample if the count is above 1 lakh. It can be used for thrombocytopenic samples. You need not dilute your sample if there is thrombocytopenia. You can use it neat. It is a more sensitive technique to pick up storage pool defects. You can process samples up to 24 hours of collection. We have a paper from Vellore, Dr. Rupri has published that platelet function testing by flow cytometry is stable up to 24 hours of collection. And then if you see you are using whole blood citrate over here, so it seems a little more physiological and more closer to what is actually happening in vivo. And then flow cytometry can actually study multiple aspects of platelet function simultaneously, which are not being done actually by light transmission aggregometry. So, just in brief, how does a platelet activation study is being done by flow cytometry? So, if you see, this is a resting platelet, as I already mentioned, that it has some surface receptors which are there on the surface. And when the platelets are activated in the presence of an agonist, it undergoes shape changes. There is a release of the granular content from the lysosomes, from the alpha granules, from the dense granules. So there is an expression of LAMP1, CD63, CD49, P-selectin, NXN5, PAC1, which is not there in a resting stage. So what you can do is, theoretically, you can imagine you have a sample, you put your antibodies, acquire at baseline, there is no activation. Second sample, you add your agonist, add your antibodies and acquire and analyze whether those activation markers are now expressed or not. So this is how, so you have so many markers or so many antibodies which can be targeted against these receptors to see whether your platelet is now activated after the addition of an agonist or not. So besides this, as I just mentioned, that you can study activation markers, you can study the alterations in the platelet plasma membrane. That is, I remember Dr. Lutfi showing a case of Scott syndrome wherein NXN5 was able to pick up that there was no binding of NXN5 even after addition of an agonist or when the platelet is activated. You can study storage pool defects using MIPA-crene assay. Then you have, in research, we have platelet microparticle analysis, drug monitoring, and surface glycoprotein was basic thing, that is the CD41 and 42B expression to rule out Glanzmann and Bernard-Schauer. So if you see the publications related to platelet function testing and flow cytometry is actually far more than light transmission. It's like almost double the number of publications which were there for light transmission. So this is a very, I will not say this is a new tool, it is there for quite some time, but despite there for being some time, it is requires a fair degree of standardization across the labs before I think people can switch over completely to, or at least we can switch over completely to flow cytometry based platelet function testing. Again, a series of publications. I'm so sorry, this was supposed to be animated one karke aana tha, but then there are these guidelines. Like the second one is actually a consensus guideline from the ISTH Society as to how platelet flow cytometry is to be done. This was published in 21, and then recently in 2023 they have published another report of flow cytometry for platelet function testing in thrombocytopenic patients. So again, in these papers, they have spelled out a series of pre-analytical things which have to be taken care of, which when I went through, I personally felt they are quite similar to what is being given for light transmission. Your sample collection modalities, your refraining from drugs, activities, caffeine, all stays the same. What is changing? The type of agonist which you are using in flow cytometry is slightly different from what is being used in light transmission aggregometry. Like ADP is common. Then for collagen, type 1 collagen is usually not recommended. They say it is better to use CRPXL or convolution as a group GP6 agonist to test for collagen receptor defects. Then instead of thrombin, because thrombin is a very potent agonist, rather TRAP6 is being recommended. Then the question mark is basically for the because of the concentration at which this agonist is to be used. So they have given a range that you can use it between 5 to 10, 0 to 80, and I think till we get a little more specific values, the results between two labs may or may not actually be interchangeably interpreted. So this is where you have to set up and do everything and in your own lab and standardize across your reference ranges before it can be applied to any other lab or setup. So if you look at the surface, if sample preparation for just surface glycoprotein expression, so all you need is just 5 microliter of the sample, irrespective of your platelet count. So where I was asking for 500 microliter per agonist, here I am asking only for 5 microliter of the sample, which is to be dissolved in the buffer. And then you can do staining for these markers and easily diagnose Glanzmann and Bernard-Schauer. So this is just how I would say this is a linear scale. If you see, we are analyzing the platelets. So here we have depicted the data in a linear scale here, whereas this is in the log scale, and you can see that this is how we are identifying the platelets, which are much smaller. This is a singlet gate for the platelets. So when I see this graph, I feel this is what I was doing when I was alone in the lab, and this is the exponential way the coagulation lab has grown when Dinesh has joined. So anyways, again, seeing those platelets on forward scatter, side scatter, you ensure that your platelets are being collected. And to again truly confirm that these are platelets, you are using CD41 as your gating marker. And you can then study the loss or presence of any marker, like this is Bernard-Schauer where 41 is being expressed but 42B is lost. Whereas in Glanzmann thrombasthenia, 42B is being expressed while CD41 is being lost. So this is one test which you can do in a child who is less than 1 year of age. You have hardly 1 ml sample or even a 0.5 ml sample. All you need is to just dissolve your sample, run it on the flow cytometer, add these antibodies, and less than 1 year baby, you can go ahead and diagnose Bernard-Schauer and Glanzmann, which are actually amongst the severe platelet related functional disorders. Whereas when you are doing activation testing or more functional testing, you need to increase your panel. You have your control tubes in which first is unstimulated, meaning thereby there is no agonist. Then you add different tubes. In one you are adding ADP, in the next tube you are adding TRAP6, in the next tube you are adding convoluxin or CRPXL, and then you have your activation markers and gating markers. Like CD41 is your gating marker, whereas PAC1, 62P, 63 are your activation markers, and this is where you have added no agonist, and here you have added your different agonists. You would put up the same for the patient samples, and these are my baseline results. CD41 पे gating करी है, इसलिए CD41 का peak positive है. CD63, 62P में there is no expression, and you can see when you have added an agonist, you can appreciate that there is an activation. So we are trying what we were seeing on light transmission aggregometry as a curve and with 50% amplification. Here we are trying to see a reaction after addition of an agonist. So at baseline there was no 62P expression, there was no 63 expression, whereas after activation you can see that there is a expression of 62P and 63, indicating that your platelets are activated. Similarly, these are other graphs with ADP. So it is like you have to, the shift in peak, you can measure the percentage of platelets which are becoming positive, or you can appreciate the change in the MFI. For example, this is again with TRAP6, and here we can see that the 62P expression is there, and simultaneously 63P size 7 expression is there, and my platelets are activating, and so this will corroborate with what I would like expect to see on a light transmission aggregometry. And this is with collagen. As I just said, either you can give your results in percentage platelets which are showing a reaction, or you can show a change in terms of MFI, like 62P at baseline was 1000, whereas after activation the MFI is 6500. So what we have been struggling is like to establish a reference range for your own lab first. Then only you can apply this to a patient and say कि इसका कम आ रहा है. And then you can say that probably the patient platelets are functionally defective. So far we have not really found any defective. पता नहीं हम सही कर भी रहे हैं कि नहीं. So if we look at what is the reporting mechanism, what does this consensus report on flow cytometry or platelet function? Though there is this consensus report article, personally when I went through it, I felt that there are some more things I would have expected them to, give, which would have guided me to run my essay in my lab. What they have mentioned is there are, I think, almost 28 points or even more recommendations which are there. And important ones were that, like in any flow cytometry based test, you need to adjust your platelet count. So normally, if you expect your platelet count to be 3 lakh or something, when you are running per tube 30,000 events per microliter, जो हम normal बोलते हैं, उस तरह से करना है. So you need to dilute your sample. And if there is thrombocytopenia, you can reduce the degree of dilution. Similarly, they have said that for patient-related results, interpretation should be local reference ranges. But exactly how am I supposed to establish those reference ranges? Are they based on percentages, or are they based on MFI? Or should I take a MFI ratio of after activation and before activation? I am still struggling with it. But then again, what they have given is that they have given that your panel should at least include these agonists like ADP, thrombin, U46619, CRPXN, and so on. And these are your standard activation markers which should be there in your panel, like PAC1 or anti-fibrinogen binding antibodies, P selective, that is CD62P, CD63, which is actually your indicator of lysosomal release, and NXN5 or lactaderin if feasible. So all these things we have to understand will also add to the cost of your test, and standardizing and things like those will be important before you are actually ready to roll this out for patient testing. Another good thing which can be done on on flow cytometry is studying the storage pool disorders. The dense granules are rich in nucleotides like ADP and ATP, and if you incubate your sample with mipaclin, these granules will take up mipaclin. So, and once you add an agonist, it will release and become negative again. So this is how the sample is being prepared. In the first tube, there is no mipaclin. You just have your sample and your antibody. In the second tube, you are adding mipaclin, so the platelets will take up mipaclin and show a positive signal. And when you add an agonist, there will be a release, and this mipaclin should release, and your platelets should become negative again. So this is how again the gating strategies. The platelets are gated on CD41, and if you see, this is the first tube. Mipaclin is being read in the 510 channel, So without mipacline, there is no signal. Whereas when you have incubated your sample with mipacline, there is a positive signal, meaning thereby that your dense granules have taken up mipacline. Now, when you add mipacline and trap, this pink peak is because mipacline has been released and this positive peak has now gone back again. So this is uptake and this is release. And I'm actually really thankful to Ruti because I think this is I heard her for the first time doing all this, and it was very inspiring to go back and procure reagents. Though I think this has taken almost 2 years, maybe when I last heard her, and where we are today. So another additional advantage, again, I would give the credit to Ruti, where she has shown that for flow cytometry based testing, your samples can be stable for up to 24 hours. They have studied 121 control and 66 patients with suspected platelet function defects, and they have shown that this activation by flow cytometry has excellent aggregation with light transmission aggregometry. It is pretty sensitive and specific. Even a flow cytometry could pick up additional 14% patients with a platelet function defect where there was thrombocytopenia or lipemia, where LTA was inconclusive. And again, one of the important conclusions was that pack was stable for 24 hours, sample stored or transported at 2 to 8 degrees centigrade. Again, now coming to comparison, now I've shown flow cytometry, I have shown light transmission. So one of the papers where Ruti has shown comparison, this is another paper where they aim to compare the flow cytometry based platelet activation versus the results of light transmission aggregometry. So again, if you see the agonists which they have used are more or less the ones which I have already mentioned, and the antibodies for activation are these. And the agreement which they found was up to 82% in their Cohen's kappa analysis. So there were approximately 6 patients which are picked up additionally by flow cytometry, which were not abnormal by light transmission aggregometry. Similarly, we have a paper from PGI Chandigarh. Here they have used a slightly different principle. They have used platelets stacked with PE and platelets stacked with FITC, and after activation, they are showing that because of the aggregation, the FITC and PE dual positive events will increase. So even in this paper, they have taken 24 patients and 40 healthy controls, and they have observed that in 2 patients, they were additionally able to show that flow cytometry was able to pick up 2 abnormal patients which were not picked up by light transmission aggregometry. Problems with flow cytometry based platelet function testing. So I've talked about light transmission, I've talked about platelets, I've shown that there is a good agreement between this. But the first and the foremost problem is you need a flow cytometer in your lab. You need fair degree of expertise to design the panel, put up the panel, standardize the assay, concentration of the agonist, the voltage at which you want to acquire, amount of antibody which has to be added, the markers, the minimum number of markers which have to be studied. Plus, I feel platelet बहुत ही दुष्ट होते हैं. मतलब there is a lot of variability in day-to-day samples also, and probably there will be a wide reference range when we are putting that by flow cytometry. And this is one thing again which is important, is that each lab will have to set up their own reference ranges by studying at least 40 healthy controls before they can apply those cutoffs for patient testing. Plus, flow cytometry will not discriminate between a receptor defect and that pathway defect, क्योंकि हमें बस ये पता है कि agonist is functioning through the receptor, so we don't know if there is no result. It is either a receptor defect or is there a downstream pathway defect. And finally, adding to it is the cost. This is always a problem कि पैसा कहाँ से आएगा to buy everything. So to conclude, there is no single gold standard test for platelet function defect, and unfortunately, though LTA has been there for so many years, still we all know that it can miss out a fair degree of patients with mild storage pool defects. The biggest challenge in flow cytometry, on the other hand, is there is still lack of standardization. And I read this in one paper that you are not really sure कि जो flow ने abnormal पकड़ा वो actually abnormal है, means is it truly positive or is it a false positive abnormality, because you're not sure which is to be taken as a gold standard. So the need of the hour, I don't know. I feel LTA is at least more or less people who are using it for a longer time is kind of still fairly standardized, and I think we'll find some degree of harmony between the labs. But when we talk about flow cytometry, I think we have a long way to go. My personal small opinion is that light transmission aggregometry based results are slightly more consistent. And जब तक vendor ने हमें reagents के लिए परेशान करना नहीं शुरू किया था, we were very happy running LTA alone. But when we started doing flow cytometry, we realized that LTA can be supplemented with flow cytometry. And for patients less than 1 year of age, for diagnosing Lanzmann thrombasthenia, for diagnosing Burnout-Scholier, even flow cytometry one single 41, 42B is a very sensitive tool, and at least that much you can tell the clinician कि ये है या ये नहीं है. And then you can supplement flow cytometry as a second line of investigation where you can study for NXN5 to rule out Scott syndrome, MIPA-clean assay to rule out storage pool disorders, and further in research you can do many more things. So I'm thankful to my team in the department and the people in the lab who help us to do flow cytometry and yeah. And as far as a personal experience is concerned, there is one case of a recent patient who was a 5-year-old male, who was a 30-year-old male, but he had a bleeding history since 5 years of age. And on 41, 42B, he showed a heterogeneous expression of CD42B. So we were not really very sure where to put that patient, and the sample has been sent for NGS. But when I was discussing with Dr. Jasmina, she said there is a Bolzana variant of Burnout-Scholier syndrome where you can see such heterogeneous expression of 42B. But so that is something where the patient had thrombocytopenia, so we could pick that up on flow cytometry, but light transmission could not be done. So both these techniques actually have to kind of complement each other for till the time we are really confident to switch over completely from LTA to flow cytometry. Thank you. Any questions?
Thank you, Dr. Ruchi. So, if there are any questions from the audience?
So, to flow cytometry based assay, there is no lower cutoff for the platelet.
No, ma'am. We have worked for up to platelet counts of 10-20,000 also, and it's just that normally when we are doing flow cytometry, if we have a count of, as I said, 3 lakh or 2 lakhs, we just dilute it with the buffer to bring the count to 30,000, and then take that up. But if you have a count of 10,000, I tell my technician to pick up 50 or 100 microliter neat of that sample so that we have sufficient events to acquire. That is all. And one added advantage, and I just observed it in one patient, ma'am, of ITP, where simultaneously on the same day we had 2 patients of ITP. One had a 20,000 count and he was still bleeding, and one at 20,000 was not bleeding. So when we just did a ADP based activation, and we saw that the patient who was bleeding was not showing 62P expression, whereas the patient who was not bleeding had a activation pattern similar to a healthy control. So that way you were able to, I thought we can pick up additional functional effects in patients with thrombocytopenia, and that can help us to discriminate patient that he is likely to bleed or why is he bleeding, and that might be we might be able to explain.
If I just have to rule out Burnout-Scholier syndrome or Lanzmann thrombasthenia in my flow cytometry, so do we require तो लाइक जैसे हम लोग बोलते हैं कि एलटीए में कि ये दवाई नहीं खानी है, ये नहीं खाना है?
नहीं, I don't think so. In fact, because it's an antigen-based test, and you can just take a citrate sample. In fact, we have done it on EDTA samples also, though it is said that sometimes QB3A can be shed off in an EDTA sample. So I would suggest that better है कि हर कोई whole blood citrate पे ही करता है, so you can do it either on PRP or whole blood citrated sample. There is no hindrance to do the antigenic test.
आपको कभी क्या करते हैं साइमल्टेनियसली एलटीए पे भी करते हैं फिर फ्लो पे भी करते हैं?
We are trying to do that. We are at least putting up 2 agonists, ADP and TRAP6, and in the pipeline to add collagen also. So for patient who is paying for light transmission ka panel, we are taking just some nominal charges for flow cytometry also, so that मतलब lab को run भी करना है, पैसा कहाँ से generate करें. And then we are putting up these so that at least जिस बहाने से हम एक normal reference range करना शुरू कर दें, establish. I think, thank you.
Thank you, ma'am. I would request Dr. Nishant sir to present the memento to Dr. Ruchi ma'am.
The next talk is on automation and QC in coagulation. Dr. Jasmina Das is absent due to some reasons, so it will be taken by our favorite teacher, Professor Sukesh Nair, sir. So once again, thank you, sir.
Yeah, this will be, I'll tell you. Yeah.
Last time you needed a pointer. Should have laser pointer is here. Sir.
It's all right, all right. Okay. Okay, thank you, Dr. Mishra. So automation and QA. So these are the tests that generally possible on a coagulometer, which can be either coagulation testing or testing for thrombosis, thrombophilia. And of course, platelet function test, if done on coagulometer, completes the roles of hemostasis in a laboratory. Basic test is a plasma-based test. So tomorrow in the wet workshop, you will be getting an experience on how to do a plasma-based manual test, where you add the activator and getting the plasma to clot at 37 degrees centigrade. There is a lot of skill involved in trying to identify when the plasma will clot. There is two methods that we look for formation of the clot. One is the movement of the plasma stops when the plasma clots. So oh, sorry. Yeah, so the movement of the plasma will stop and the color of plasma will slightly become turbid. So these are the two observations that we look in manual when we do the clot manually. Now, thing is, sometimes it's not easy. So this same thing can be done on a coagulometer. Coagulometer either does the mechanical part, which is the movement part, or they look at the turbidity part. So it doesn't do both. Though the new coagulometer that's come out from Stego does both. So that's why the manual clotting method is still considered to be the gold standard in coagulation testing. So you have the mechanical principle, which looks at plasma viscosity. It's an electromagnetic field where there's a metal ball and the metal ball moves across the plasma, and moment the clot forms, the movement stops and that clocks the timing. While this photo-optical method either looks at transmittance, which is decrease in transmittance, because as the clot becomes turbid, the transmittance decreases, or it looks at increase in absorbance when the turbidity increases. Then, of course, you have the chromogenic principle, which is basically getting the enzymatic reaction. All coagulation processes are enzymatic reaction. So each enzyme or each part of the enzyme is given a substrate, a specific substrate. And substrate, once it's acted upon by the enzyme, will release a chromogenic substrate, which basically adds color to the thing, which is read at 405 nanometer. So increasing amount of absorbance by that color indicates the directly proportional to the amount of enzyme or the amount of factor. So mechanical, of course, there are advantages because you can do the test on lipemic plasma, on hemolytic plasma, but sometimes very, very lipemic plasma also mechanical fails. It requires probably small sample volumes. It can also possibly do whole blood analysis. But only problem with this is you can't see the process of waveform. There is no waveform you can see in this particular process, or no clot waveform analysis possible. Optical, of course, problems with hemolytic sample, lipemic sample, because it is looking at either transmittance or absorbance. So this interference can interfere with it. Then, of course, the advantage can be, or this particular can be overcome by using some transparent reagents, but still it's a issue. Advantage of chromogenic is that it's a very specific assay. So all enzymes are directly acting on the substrate. So it generally does not get affected by interference like lupus anticoagulant or antibodies to some other factors. Like if you want to do a factor 9 assay, you can do a factor 9 assay without the help of, if suppose there's a factor 8 inhibitor. It basically overcomes a lot of high titer lupus anticoagulant also. Only thing is the reagents are very expensive and not commonly available. And even if it's available, the cost is fairly prohibitive, and there's a low shelf life for the reagent. So if you open the reagent, you need to use it fairly soon. But yeah, that's what the product insert says. But in Vellore, we have been doing something. Whatever reagent is required for the test, we use that. Rest of the reagent, we freeze it in aliquots in -80. And we find that the reagents are very good. The quality control, the controls are very good. Even at the end of, even we take out the reagent, thaw it one time, we only thaw it one time. And that's enough because one set of plus test will require one particular set of reagents. Even after 28 days, even after 48 days, it gives you very good results. But that's if you freeze it and you start doing chromogenic assays. Then many of the coagulometers also do immunoassays because immunoassays generally are associated with biochemical instruments. They call it as CLIA, EIA. So similarly, coagulometers can also do because it's again transmittance and turbidometry, immunoturbidometry. So most of the assays like D-dimer, they are immunoassays because it's looking at an immunological reaction, antigen-antibody reaction. Some of the coagulation factors like protein S is also a antigen-antibody reaction. So they are, but here they started as latex immunoassay, but slowly now most of the coagulometers are now introducing CLIA or chemiluminescence assay into their system. So Stego, IL, Werfen, Sysmex, they all have got CLIA into their system, which basically means the repertoire of a lot of immunoassay which used to be done in biochemistry and probably microbiology will come back to the hands of hematologists, especially anti-phospholipid antibody assays, some of the assays like PIVKA1, PIVKA2. Biochemists are good. Some of the biochemists who get involved in coagulation are good because there are some parts of the country where biochemists do the coagulation, like Andhra Pradesh. But most of the other places, it was predominantly with the pathology, hematology section. But if you remember, coagulation was actually part of biochemistry. If you look at all the old hemostasiologists, Robert Macfarlane, they were all biochemists. And the first coagulation test called prothrombin was part of LFT. I don't know whether you remember that LFT. Prothrombin was part of LFT. And in Europe, coagulation is still under the biochemist. In UK, Australia, and US, the coagulation is under hematologist. So whenever you get an automation, you have to be careful. You need to evaluate it properly. First, you have to look at a national level, then see how many equipments are participating in an EQUAS program. Maybe ask the EQUAS provider, and also see some other user, have their experience been good. See, there is nowadays there is nothing much to choose between an equipment as far as their maintenance part is concerned, because most of them are equally low maintenance. Only thing is, finally, it comes to cost, and most of these equipments are maintained well by their service engineers. So spares are easily available in our country. So downtimes are very low. So downtimes and maintenance wise, there is nothing much to choose from, but finally it is a cost that will help you choose an instrument. So these are the various stages of evaluation, preliminary information, then how to plan an evaluation, preliminary assessment, then performance assessment like carryover and everything, and finally, the turnaround, not only turnaround time, how many tests per hour, that's efficiency assessment. The other thing that is not much of a problem with people in the developed countries, but maybe later on they copy us also, is that using the principle that is available on a platform, can you adapt something which is already being done, but slightly more tedious manually? I mean, slightly more tedious with manual effort, can be adapted into the coagulometer. So in 2004, we adapted ristocetin cofactor assay on a turbidometric platform on the ACL 10,000 platform on IL, which has never been done before. We thought anyway this light pass ho raha hai. Anyway, Rikoff is based on aggregometry. Aggregometry is also a light transmittance aggregometry. Why not we try it? And it worked very well. And we could create a good standard graph. Only thing is, the machine was not programmed for it, so standard graph was not there in the machine. We had to plot a standard graph outside. So every time we get an OD value, we have to take the OD value and put it on the standard graph and then derive the results for that. It worked very well for us. We used to manually wash the platelets and use the platelets. So cost to us for doing ristocetin cofactor, the only cost was ristocetin. So we used to only have, the cost to the lab was only 40 rupees for ristocetin cofactor assay. And you must realize in aggregometry doing Rikoff, we use 500 microliters of the reagent. In the coagulometer, it only uses 100 microliters. So we could, in the same volume of platelets, we could do 5 tests. So the cost was really good. So life was very nice. Only thing is, it was still fairly manual because you had to look at the value and then get the value out of the standard graph. We published this and it was finally copied by IL into their platform. Then, of course, CS 2000 came with their aggregation area where they could do play aggregation. So, Ristos cofactor assay was available as an aggregation test. So, here it will be like a classical aggregometer. You can see that the graph is also like the Ristos graph is also like an aggregometer. And when we, so this is when they launched it first, we actually, even before it became a program, we started doing it because we were desperate. We just wanted to move out of ACL 10,000 to something which had in the system a standard graph, and you just put the sample, the value of the recoff will come out. So you can see that with 100%, you can see the aggregation response to recoff. 50% it becomes lesser, 25% becomes more less, and then you can get a beautiful linear standard graph, which we can use for measuring the recoff of any patient sample. And this is what we compared between the antigen and recoff. It had a very good correlation on the CS 2000. And also the limit of detection, as Dr. Jasmina was mentioning for the recoff. Oh, I thought somebody was making a comment here. No problem. She was telling that limit of detection is not very low, but in the recoff we could even come down to 7%. Linearity was up to 7, because now there are more automated assays available on coagulometers like glycoprotein 1BR, 1BM, on Sysmex, on Stego and Werfen. Now, because the coagulometer was doing recoff based on platelet aggregation, because washed platelets, we said, why not we do platelet aggregometry? So we helped Sysmex develop aggregometry. Now you must realize one thing, having a fully automated aggregometer is so good, because otherwise when you have an aggregometer, you're standing there, you put that, you adjust the light, then you add the agonist, look at the response, then finish this thing, and then you take the next tube, put it there, add the agonist, 30 minutes gone. So if you have 5 samples, by the time you reach the 5th sample, probably the 4 hours is also over. So the deadline of 4 hours is finished. Here you just put the platelets in the machine, walk away, you come out and see the graph. So we started doing this. We put this as a poster in the Kyoto ISTH, and Sysmex was shocked because they didn't even start thinking that they were planning to do aggregation. And I do between 1 to 12 aggregometers every day, platelet function test every day. Probably the only lab in the world. I see a lot of consanguineous in autosomal recessive disorders. I diagnose at least 50 to 60 new Glasmas thrombasthenias every year, 10 to 20 Bernard-Soulier syndrome new patients every year. So, and of course, many platelet function disorders like P2Y12 defect. We think that only clopidogrel will cause the deficiency. No, we see inherited P2Y12 defects. And there are many other platelet function defects. I don't think so. The people in the West have seen it, or they may have seen it, but have not given a name to it. Probably they are waiting for us to give some name to it. So there are so many platelet function tests that we identify. So probably my lab will require a fully automated aggregometer compared to, so this particular point may not be a selling point for a manufacturer, because tell me one lab which does more than 5 aggregometers in a week. There are not many. So anyway, we did this, and then of course we helped Sysmex develop this program on. So we are used as a lab to help develop programs for other coagulometers. So we are an alpha testing lab for some of these manufacturers. So advantage of automation in a coagulation laboratory, it improves the capacity and flexibility of professional time spent, reduce costs in the amount of sample and reagents used, allows data storage, automatic replay of results, possibility of running different tests using one single sample, sampling from a closed tube, which is also possible, capacity to dilute samples and calibrators. And it actually makes a lot of complex procedure that existed, which we were doing, Simple, which can be dangerous. You just leave a sample, you will get a result. You will not know the limitations of that method, you will not know the variabilities of the result. So the interpretation part requires that much of awareness. Otherwise, you can give wrong information to the physician or like for example, because a machine is available, it does antithrombin, but it does antithrombin antigenic assay. You say, I do antithrombin assay, you send me sample for thrombophilia. You do antigen, you are going to miss 90% of antithrombin mutations which will cause thrombophilia, 90%. Because 90% are functional mutations. Antigen is going to be normal. So therefore, automation can make complex procedures easy, but it also can bring in a lot of white elephants. So only experts who have probably worked in some places of, certain number of samples, you don't have to be experts. You just have to work with them, and then slowly you can work yourself and expertise will come in. Now, quality assurance will cover, so thing is, this is only for analytical part, but quality assurance covers pre-analytical part, analytical part, and post-analytical part. So let me talk about a story about, this is a story which happens to you probably every day, 2 or 3 times a week, especially in a hospital where you have an ENT surgeon. They will refer a patient who has an abnormal APTT, a boy who is waiting for adenoidectomy or tonsillectomy, and APTT is abnormal. So this patient was admitted for adenoidectomy and APTT is 51 seconds. So what will you do when you get an abnormal APTT? 51 seconds. This is a 7-year-old boy. First of all, you have to see whether it is in the reference range or not, whether it is actually prolonged. Because some of the children reference range is having higher APTT. Should never use adult reference ranges in pediatric population because an APTT of 50 may be normal in a 6-month-old child. So, okay, now you have agreed the 51 is for a 7-year-old boy is a prolonged APTT. What is your next step? Once you have decided your APTT is abnormal. You say mixing studies? Yeah, possibly yes. But one most important part is that whether the sample was collected properly or not. Because sample collection process itself can affect the test, and the timing of the test can also be important. So this hospital only uses evacuated tube system. And all the sample collection area, they are using the evacuated tubes. The sample collection area in the OPD is under the control of the lab. So lab collects from the sample and they are all well trained and they only use evacuated tube. So evacuated tube is not only just the tube, it's also the needle and the needle holder. Now the rule that is there, a lab should only use a system where the sample comes directly in touch with the anticoagulant. And that's only possible evacuated tube. So the biggest advantage of evacuated tube is that sample, when it's out of the system, it comes directly in touch with the anticoagulant. A syringe will never come in touch with an anticoagulant. Okay, so this is the evacuated tube needle. Then you have the needle holder into which you attach the needle. And then using the tube makes it the evacuated tube system. So when you say evacuated tube system, it's not just the vacuum tube. It is also the needle and the needle holder. And then this hospital also has, pictures in the SOP where they show the process of tourniquet application, the insertion of the needle, and when the blood comes into the hub of the needle, and then you have to insert the tube. And I think they have taken their own picture. You can see that most of the SOPs will have nice Caucasian hands, but this is a nice bangled hand also. Probably they've used their own pictures here. And inversion, everything is very, very nicely shown. And the lab uses the same procedure. But the nurses in the ward, you ask them, they said that they send the sample in evacuated tube system to the lab. But if you ask them, do you use the evacuated tube system? No, we send the sample in evacuated tubes, but they don't use the evacuated tube system. They use syringe and needle. 99% of the hospital nurses only use syringe and needle, even if they have been trained on, not 99%, 100%. I can't be that nice. So we asked them, how do you transfer the blood from the syringe into the tube? Open the cap, convert the vacuum tube into a non-vacuum tube, add the sample. So 4 rupees loss had already happened. Because the normal non-vacuum tube is 1 rupee, vacuum tube is 5 rupees. And then you ask them, how many times do you mix? That's not very sure. Normally say that 3 to 4 inversions. They'll say that like this. Inversions have been shown as in pictures. It's like that. So evacuative tube system is the best system of sample collection because the sample comes directly in touch with the anticoagulant. Risk of clot formation, 0. Risk of underfilling, 0. Risk of overfilling, 0. But with syringe and needle, risk exists for clot formation, underfilling, overfilling, and in coagulation, there is a lot of intolerance for underfilling. Fairly intolerant. We have to, sample reception area, you have to have a tube, mark the tube, and say if less than this, don't accept the sample. So the issues with this chance finding of nurses doing syringe and needle collection have an impact on the lab. So we went to the lab's sample collection register and we found that all the samples that were rejected by the lab were actually from the board, not by the lab people. They were collecting with syringe and needle, and obviously there were clot formation. This is clots which can be seen. There are many clots which can't be seen. And underfilling and overfilling. So the nurses started getting worried because an audit finding shows that they are the people to blame. So they actually came out with a training register. They said we have been trained on vacuum tube system. Everybody has attended the training. Everybody has passed the questionnaire. So we said, who does the training? The lab head. We call the lab head. कैसे train करते हो? Video दिखाते. I said video दिखाने से फायदा नहीं है. You have to show what are the impact and mishaps that can happen if you deviate from what is shown in the video. Okay, large lab. Probably he claims the largest lab in the country. They have issues. This lab was not able to get accreditation for a long time. So they have issues in samples being received in the lab. Samples either have leakage, hemolysis, clot in the sample, and therefore they had issues with coagulation testing and platelet counts. And frequent needle stick injury for the operators. So these are our problems. Now, if a lab requires accreditation, they should have a quality system which should identify problems, do a root cause analysis, and bring in corrective action so that there is no recurrence of the problems. Once a problem happens, it should not recur. Now, this problem has been happening every day. It's recurring. So, what is the quality system? So, 15% of the samples are collected by people who they have employed as sample collectors. They even have their own sample collection areas, or they go to various villages and collect samples and send to the lab. And they have been given a pouch which has got a syringe and needle, and they have got a 6 ml tube for clotting and a 2 ml EDTA tube. And they have also been trained and given the instruction, don't open the cap of the tube. Now, how do you collect the sample? They have given syringe and needle. They will only collect, and the syringe and needle is only 5 ml into 6 ml clotted tube and 2 ml of EDTA tube. So, with the 5 ml tube, because they have been told don't open the cap, they have to poke the needle into the cap of the tube. So once they pierce the tube, the vacuum will suck the blood. But in the process of piercing, they're almost like recapping the needle. They get needle stick injury. So cause of needle stick injury, identified. Now once bitten, twice shy, this guy is not going to do this sample prick again. He's going to open the cap and add the sample. So chance of clot formation. Now, from a 5 ml syringe, how is he going to fill a 6 ml tube? The lab is doing some thyroid test, some serum test. He doesn't require 6 ml. So he tells, not written on the procedure, when it is 3 ml, baki EDTA में डाल दो. Because then your order of draw में EDTA comes after the clot tube. So in the process of abruptly stopping the procedure and withdrawing the needle, you get hemolysis, which I learned because of the audit system. When you abruptly withdraw when the sample is being sucked, you get hemolysis. Okay. So that is the reason for the hemolysis. So now he's adding with the cap open. So these are the two causes. So now once he opens the cap, adds the sample, there is no uniformity in recap. So if he doesn't recap properly, when the samples are transported, cap will open, sample will leak. So he had one problem, leakage of sample. Then he had needle stick injury. So two of the reasons identified, and hemolysis also identified, and clot in the sample also identified. So what is the root cause? Because when you have a problem, you have to do a root cause analysis. What is the root cause? There's only one root cause for all the 4 problems: syringe and needle. Syringe and needle. So once the root cause was identified for them, they stopped giving the syringe needle. Instead of that, they gave a evacuum tube systems needle and needle holder. 4 problems which are happening on a daily basis did not happen ever again in that lab. They have other headaches, that's a different issue. But this never happened in the lab again. So the biggest failure of implementation of evacuum tube system in our country is syringe and needle. I also face the same problem in CMC. So now coming back to my patient, APDT is 51 seconds. We want to find out whether the samples were collected properly because it's come from the ward. So we call the ward where the samples collected properly. What is the answer going to be? What do you think? So we stopped asking that question. Instead, we said, why don't we look at the tubes themselves? Because we don't remove the cap. Now we have the cap piercing system. If suppose the cap has got blood, that means it was collected by the evacuum tube system. If there is no blood, they opened the cap, added the sample and recapped and sent the sample. So when we identify this, we put in a rider, kindly interpret based on the sample collection method. So then nurses started getting worried with those comments. So the nursing superintendent came and negotiated with us and said that don't put that comment. So yes, the samples were collected correctly. So what next? Mixing studies. Now at least you can say mixing studies. Now mixing studies was done. We talked about mixing studies. Mixing study does not show any correction. 49 seconds. So what is it? 7-year-old boy, prolonged APTT, not correcting. We have to give a diagnosis. No? We are an expert coagulation lab. Yeah. So thing is, no correction can be any of this. Heparin, obviously 7-year-old boy happy, no heparin. And not bleeding, very happy. D-dimer FDP, no DIC. Lupus anticoagulant, 7-year-old boy, very happy. What lupus anticoagulant? Lupus anticoagulant is a test that is done on patients who have got clinical criteria to order the test. No Tom, Dick and Harry should be called as lupus anticoagulant. There's a clinical criteria and there's a scoring system. So he doesn't have any clinical criteria. So what next? Repeat the test. Repeat the test, same problem will happen. No, everything was proper. Till now everything was proper, but we can do it properly again also. Same problem will happen. Yeah, so, because we are an expert coagulation lab, we want all the best reagents. So our APTT reagent also, we wanted to be like FSL, Automate, the most sensitive APTT reagent. We were using Synthesil. And the APTT has many objectives. Unlike PT, which is only for oral anticoagulation, it is for looking factor deficiency, identifying inhibitors, monitoring heparin, and as well as lupus anticoagulant. So this is 1 month statistics, 7,174 APTTs, of which 28% were prolonged. It's a huge headache. So I said, let's stop using a very sensitive APT reagent. Let's do it with a low sensitive APT reagent. And I found that among 28%, 80% the APT became normal just by using a different reagent. Was within the reference range for that APT reagent. So now only 7%. 7% is also a big number. Needs to be sorted out. So with CK press, the APT was 31 seconds. Now tell me, what should I do next? All this tamasha has happened. It is a recorded event. What should I tell? So lupus insensitive reagent means a lot of phospholipid. Maybe this is a lupus itself, because lupus sensitive reagent positive, mixing positive, confirm negative. Screen over confirm very high. Should I give the report as lupus anticoagulant? You can't give a result of lupus anticoagulant. Normal happy boy. Just because he's snoring in the night, his parents want the tonsils to be removed. So ENT surgeon wants, so you tell the ENT surgeon on the phone, transient lupus, that lupus anticoagulant, worse than hemophilia. He said surgery postponed karte. Then the child will recover from tonsillitis by himself, stop snoring, and so APTT reagent has saved quite a lot of adenoids and tonsils in this world. Does this happen to you at least once a month? It happens. And if you are working in a pediatric hospital, for sure it happens. You will get consults. This is called transient lupus anticoagulant. The most common cause of transient lupus anticoagulant is CRP. In adenoid inflammation, in tonsillitis, the CRP goes up. If you do APTT during a CRP, high level of CRP, so now in Europe, whenever an APTT is prolonged, they do a CRP. They won't repeat the APTT. They will, because CRP is a reimbursable test, while APTT is not a reimbursable test. They do a CRP. If CRP is prolonged, answer okay, transient lupus anticoagulant. But India, ENT surgeons require a huge amount of education to make them understand what transient lupus anticoagulant is. There was a patient who required a tracheostomy, liver transplant patient. Platelet count is low. The ENT surgeon will not touch. So we said there is a peripheral consumption. Do tracheostomy. We will support. So we gave 2 platelets with kit and one, because sometimes FFPs also help. So 1 FFP. While doing tracheostomy, he'll call and say, "Oh, the patient is more woozy than required." Actually, it was the anesthetic said it was same amount of bleeding, then you can see. But because this background information is there, he feels it's more woozy. So I said, no problem. Tell him that we are giving him 1 FFP right now and bleeding will stop. And he believed it. Bleeding stopped, tracheostomy was finished. So, surgeons require a little bit of, I know that surgeons require a clear field for sure. But this one also, if you assure them that field is the same and clear, whatever was the bad field will become good, they are very happy. So what was the mistake that our lab made? Selecting the wrong APTT reagent. For routine screening, never pick up a lupus sensitive reagent. So these are all still pre-analytical. Automation will not help here. So this is another scenario. A neurosurgeon says the INR of 1.2 was reported in a patient who is going for meningioma removal, and they collected a fresh sample. It was still abnormal, while APTT was normal. Then they found that they changed the lot of the reagent. It was still abnormal. They found that a lot of PTs in other patients were also abnormal. So they asked us what to do. I said, change your reagent. Or with the existing reagent, you have to do certain correct things, but you don't have the capability of doing those correct things. So you must realize that certain PT reagents are very particulate. They are made from thromboplastin, rabbit brain thromboplastin. They all get from one place. Czechoslovakia. That makes a lot, I don't know, a lot of rabbits are there or not, but a lot of rabbit brain thromboplastin is produced there. So tulip, all the Indian makers of PT reagent get from the same place. Then they dilute it, make as emulsion, and the only thing is those, they are particulate. After half an hour or 1 hour, it settles down. At that time, when you do a PT, the reagent is down, but you are picking up the reagent from the top. So if you don't mix the reagent properly, every time, you will get an abnormal PT. Yeah. So coming back to the 4 pillars of quality assurance is precision, accuracy, sensitivity, and specificity. Precision, of course, you need to use controls. For accuracy, you need to use standard reference method, calibrator, or a primary standard. External quality assessment scheme, if you are participating in a good one, gives you a chance for accuracy because you are getting yourself compared with a true value, which may be the consensus value of a good number of participants. So it's a chance for accuracy. So UCAS can identify problems a laboratory has with a particular test, problems with a particular method, or maybe with a reference plasma, or with an interpretation of results. So there's a major hemophilia treatment center where the lab is performing very badly all the time. So this is the lab. You can see the expected result was 29.3. Lab was getting 44. Dangerous. This lab will never pick up a mild hemophilia. A mild hemophilia, this lab will call it as normal. And this lab has been performing high levels of factor rate regularly. You can see that here. The last 3 performance has been bad, and that's why the lab gets a love letter from the EQUAS provider. So this is how the results are spread. If your results are in the median, of course, this is your value. If you're close to the median, you get A. If it's lesser close, then B, C. D is far away from the median. So D and E is a bad result, but we don't allow one bad result to affect you. We need 3 consecutive bad results to be said that you are an outlier. So this is an outlier. So now this lab has been an outlier consistently. So that's why the lab gets a letter from Steve Kitchens. This is a UK EQUAS program. So then it was sent to the nearby lab committee member to sort out this issue. That happened to be me. So what is a factor assay, factor rate assay? Factor assay is defined as the ability of various dilutions of the test plasma to correct the abnormal APTT of a factor deficient plasma, severe factor deficient plasma, which is a substrate plasma, and compare it with a correction obtained by a standard reference plasma where the factor rate is 100%. And then based on that, you create a graph on various, so ability of various dilutions to correct, see abnormal factor deficient plasma, the APTT is going to be more than 100. But as you dilute normal plasma 100, you will get 45 seconds, 50 seconds. So based on that, you can create a standard graph. And this is a standard graph. And the patient plasma should also give you a standard graph, a graph. So the rule is that the various dilutions, so there are 3 rules to say that factor rate assay happened properly. That is, all the points of the dilution can be connected by a straight line or a best fit line, whether it's be the standard or the patient. Both have to have a standard straight line. That's why you need to have multiple dilution, not a single dilution. And the third and the last rule is that both the lines should be parallel. That's why it's called parallelism. Only if these 3 are qualified, then only you say your factor assay is good. So we call it is another country, so we called them and said, we know them. So we have been doing for training programs for them. So they sent all the information, everything looked perfect, good reagents, good machines, everything within expiry period. Then what's the problem? So we said, why don't you send us the raw value? So they sent us the raw value and we plotted it on our graph. So this is their 1 in 10 dilution, 1 in 20 dilution, 1 in 40 dilution. Standard graph, straight line. This is the sample that was used for the factor, this particular survey. That also various dilution, straight line, and they are parallel. So all 3 criteria are fulfilled. Okay, and they were also happy because it's fulfilled. So they sent the results and you can see that this is 30, this is 40, this is 50. They gave a result of 44. Okay. Now, Obviously, we said, okay, let's compare it with the same sample that we send the results, and we plot. We have got an automated system. We don't plot manually, but we thought, let's look at our value and let us plot it manually. And this is our value. And it's not that every time we get the same value as the median. This is probably one of those days when we got the same value. And we plotted our graph. We, of course, have an additional dilution. So this is our dilution timings, again plotted by the same straight line. This test sample was also a straight line by connecting all the points. So straight lines, two straight lines, and they are parallel. So my assay is also good. Now let me put the standard graph, the graphs next to each other. The graph from the other country and graph from my lab. Now tell me what the problem is. You don't have to look at the graph. The graph is very, very abnormal. The slope is totally gone. Their slope is completely gone. But look at the 1 in 10 dilution timing. There is a 71 and mine is 53. My 1 in 5 is 47, but my 1 in 10 is 53. There is a 71, which basically means the 100% dilution, the factor rate in the graph or the standard has deteriorated. It is not 100%. In mine is 100%. Theirs is not 100%. It has deteriorated. That's why it was 71 seconds. Now the second problem, the slope. Look at the difference in the timing between 1 in 10 and 1 in 20 dilution. Theirs is about 12 seconds, 13 seconds, mine is 5 to 6 seconds. The difference in timing between the dilutions, which is a property of the factor deficient plasma, which basically means the other factors in the factor deficient plasma has also deteriorated. And that's why they're getting such a difference in the timing. So calibrator plasma is gone, factor deficient plasma is gone. So we give them that information. Now what's the solution? We have to give them the solution. Reputed manufacturer. So they said, let's get fresh reagents. It's coming through a distributor. Whatever reagent you tested with and send the result, you will get the same reagent from that fellow only. That fellow has not kept the reagents properly. He has let it to deteriorate. You know what these distributors do? Anybody here? There's a spy there. But you know what they do is, transportation from Europe in euros. So they get the whole lot for the 1 year, they will get it together. So they don't have to pay every 3 months to get, so they pay everything for 1 year and they keep it somewhere in our country. So in our country, if they have a good system of storage, no problem. But if they don't have a good system of storage, this will happen. So this was happening in that country. It's a small country, only one distributor. So all the hemophilia treatment centers in that country, maybe about 18, 20 of them, they are having the same problem. But only this lab is participating in INQUEST. So we said, okay, you're not going to get any solution by getting fresh reagents. Why don't you make your own reagents? They said, oh my God, lot of effort. And basically, they are lazy fellows also. But we said, okay, let me see, what is the own reagent? You can make your own calibrator plasma. You can make your own factor deficient plasma. Calibrator plasma, get 20 normal people, pull it, you get your calibrator. I mean, you'll almost get close to 100%. So calibrator is pooling of normal plasma, and factor deficient plasma catch hold of, just now in the morning, Dr. Rashmi was telling so many people came and helped contribute their sample. That's enough. 1 or 2 patients are enough, but we don't know whether their plasmas are good. We can find out. So here we found out that if you pool 40 normal plasma, of course, it's a lot of effort. You have to aliquot, and then because of the effort, you have to store it also. Okay, let's make a smaller pool, 5. Maybe you don't have to store it. Use it that day and discard it. 100% ho hi jayega. Factor levels will be only 100. So we compared 40 pool normal plasma, 5 pool normal plasma, 3 pool normal plasma, 3. We put this effort, and we found that assume the standard plasma has got 100% factor, and it is close to 100%. Not major problem. So we said, okay, just use 3 pool and discard it after you finish the assay. Don't store it. And then we got 16 severe hemophilia A patients, and we did 1 in 10, 1 in 20, 1 in 40 dilution with all these plasmas that we made, including the calibrator plasma. And we found that most of the 1 in 10 dilution ranged from 47 to 58 seconds. 1 in 10 dilution. not 71 seconds. And the difference, even if it was 60 seconds, 1 in 10 dilution, we will not use that factor deficient plasma. Even if it's 1 in 60, the difference between each dilution was not more than 6 seconds. Difference between 1 in 10, 1 in 20, 1 in 40 was not more than 6 seconds. You can see that. That was consistent. Though 1 in 10 dilution was abnormal, but difference was. So, after, obviously, when we put all this effort, sent this data to them, they were also feeling quite guilty that we are putting all this effort and they have not done anything. So they decided they will make a pool normal plasma. They caught hold of the blood bank person. They said, can we use space in your minus 70 freezer? And they made their own pool normal plasma and factor deficient plasma. And we told them that factor deficient plasma is good if you get between 1 in 50 to 1 in 55, 1 in 10 dilution timing. And difference between timing is not more than 8 seconds. That means your factor deficient plasma has no factorate, no inhibitor, and all the other coagulation factors, which we also tested, will be acceptable. So that was the corrective action they did. They made their own plasma, and after that, they never failed the Aquas probe. And never did they buy the reagent from the same distributor. So after 6 months, the distributor came and asked them, you have not ordered reagent for a long time. Then they told this whole story. So this distributor realized he made a big mistake. So he discarded all the reagents. He started correcting his problem. He created a good storage system in his an inventory system in his storage area. And after that, this country has never had any problem. So one Equas program not only improved the lab, it improved the whole country. Yeah, so that was the criteria we gave. So once you improve your reliability, then you have to reduce the risk of failure by using controls regularly. Now controls, many labs say, oh, controls, normal controls, abnormal control. Very easy. Make it on your own. Pool normal plasma is your normal control. Just keep it in the freezer. You do INR on patients regularly. All the INR of 2, take the plasma, put it in the freezer, remaining plasma. Every day. After 1 month, you open the freezer, you will find a lot of plasmas. Pull it, aliquot it, that becomes your abnormal control. How do you think these companies make it? They make it the same way only. From the abnormal APT, abnormal INRs. They make it like that only. But only thing is you must have a good storage system. And also for factor assays, you can make your own abnormal plasma by diluting the spiking the factor deficient plasma with pool normal plasma. Now, minus 70, minus 80 freezers are between 5 to 10 lakh rupees. Minus 20 is about 2 to 4 lakh rupees. But ice cream freezers, 10,000 rupees. But you have to be lucky. So this is a freezer being used by one of my students who is providing hemophilia care to patients in Kolhapur. She does inhibitor assays. She identifies factor 7 deficiency using plasma stored in this ice cream freezer, which is only 10,000 rupees. But she makes sure that, so you must realize that these freezers have to be frost free. So like, for example, you go to conduct workshops in countries like Oman and all, they say, oh, we keep the plasma, it's frozen, but next day the value is abnormal. I said, when you're sleeping, the fridge is thawing because it's a frost free fridge. In the night when you're sleeping, it thaws. And when in the morning you open, nicely frozen. So never use a frost free fridge for keeping this. It has to look dirty. It has to look full of ice. That means your storage system is working very well. Fortunately, there's another person very close to Kolhapur in Miraj who is using this freezer, which is minus 32, which is only 28,000 rupees. This is minus 32. This is definitely better than the ice cream freezer. Ice cream freezer doesn't go below minus 20. Not minus 20. It doesn't go below minus 18 also. But she has been using, so one day she said, sir, I even diagnosed factor 7 deficiency with the plasma that I kept in the fridge. So I said, how long? I kept it only for 1 month. I said, tell me the truth. And she said, we kept it, that plasma, for 6 months. And she diagnosed factor 7 deficiency. Okay. Last case, I think. Large hospital, 24-year-old male awaiting spine surgery, APTT is prolonged, factor 9 is deficient. This happens in a big hospital in Delhi, B.L. Kapoor Hospital. Diagnosis, mild hemophilia B, isn't it? Factor 9 is 21%. It's mild hemophilia B. Patient has never been diagnosed to have mild hemophilia, 24-year-old. So when you give a chart of mild hemophilia B, he's shattered. So he goes and verifies in other labs, private labs. He gives his blood and comes back with a report to the same hospital that एक लैब ने 55% दिया, दूसरे लैब ने 41% दिया. आपका लैब गलत है. So this is just after when the dengue platelet count, India wants to know happened. Na? The platelet count was different in different places. They were giving platelet transfusion. There's one guy was sitting in the newsroom and saying India wants to know. So that's when this guy got worried and he says that, can you help me sort out this problem? I said, no problem. You just ask the patient to go back to where he gave the sample and ask only 2 questions. Third question is too technical, but ask 2 questions. One is, was the assay done in the same place where the sample was collected? And second, was the sample transported in ice or dry ice? Ice or dry ice? There's a huge difference, ice or dry ice. So because if you transport in ice, there'll be cold activation of coagulation factors. After 4 hours, factor 7 gets activated. After 5 hours, factor 9 gets activated. And when you assay even a hemophilic patient, you will get some values. You can even convert a severe hemophilia into a normal value with activated sample. So moment he asked this question, the third question was, did the lab do parallelism or was it a single point? Most of the private labs only do single point, but that was too technical. So I asked him not to ask the patient to ask that question. Otherwise, the labs will say, Arnab has sent somebody to find out this. That are you doing 3 dilutions or not? So finally, the lab asked the patient, we are sorry, we'll take back our report. And they cancelled their report and the patient went back, was treated as hemophilia B. So you must realize that parallelism is very important because when you have activated samples, this is what the graph you will get. The lower dilution, you will get values higher than the standard graph. But as you dilute out further, you can see it cross and become non-parallel. And then the true value comes out when you keep on diluting out the activated factors. So it's very important that the sample has to be transported at ambient temperature, but the test has to be done within 4 hours. Wow. This is Mufasa or Lion King? So only test the only test that has got more stringent requirement. And I'll tell you one thing. This must have been a big problem with many labs and the treating physicians, pediatricians or intensivists without realizing that this problem was happening during COVID. Is that when you are monitoring a patient for heparin, whether it is anti-10A or whether it is APTT, you have to process a sample within 1 hour of sample collection. You have to separate the plasma out within 1 hour of sample collection. Within 1 hour. No other way. So in our hospital also, anti-10A assay being done. So thing is, very clearly the ISTS has told that if your patient is on heparin, you can't monitor with APTT. And low molecular heparin, don't need to monitor. But if you are giving heparin, you have to monitor with only anti-10A. So now the lab, the ICU is sending samples and we are giving no anti-10A. Anti-10A 0. So the lab started, the ICU started getting suspicious. So we said, okay, one, anti-10A 0. Kindly interpret the results in the background of time of sample collection. One comment put. Then they started reading the comment. They said, what do you mean by that? I said, the rule is that in the slip, we need 4 information when we interpret. One is the time of the dose. When was the heparin or low molecular heparin given? This is not only COVID time, non-COVID time also. When was the sample collected? the sample for monitoring anti-10A or APTT should be done between 3 to 5 hours after the dose is given. Very important, 3 to 5 hours. And when was sample collection? When was the sample received by the lab? And when was the assay done? Only if all of them meet the criteria, we release the report. So all this has to be filled up. Now, my anti-10A assay is one of the best anti-10A assays in the world, because everything happens perfect. But to get this perfection, you have to have some problems. And just imagine so many anti-10A assays happening in the world. Lalpath giving anti-10A results. Metropolis giving anti-10A results. They are not within 1 hour. So only God can help those patients. So in any case of unexplained abnormal coagulation test results, a new specimen should be obtained and the test repeated. As Dr. Rashmi said, she's going to look after Mufasa. Thank you very much.
Thank you so much, sir, for such a wonderful lecture. Any questions from the audience?
Do you have anti-10A for pediatric patients separate and the collection device?
So that's a good question. It's a desirable thing, but it's also a mishap. I mean, it's also a disastrous thing, because the shelf life of vacuum systems which have got less than 1 ml capacity is not more than 1 month. So if you're not able to use it, you will cause problems. So just imagining that it's vacuum and using it and not able to fulfill the function. So 2 ml you can get more than 1 month expiry, but 1 ml tube you will never get more than 1 month expiry. So there can be micro tenor tubes, but one thing you must realize, Dr. Savitri, is that as long as you have the information how the sample was collected, it is useful when you interpret the results. Not all bad collections lead to bad results. But when you have a bad results, at least if you have the information that this is how the sample was collected, it helps in interpretation.
In pediatric population, because very neonate and just born, that I say doing APTT and anti-10A won't be like very reliable.
So, in neonates, anti-10A, heparin, all those is very finicky. Like extremes of age, the anti-10A would not be a good thing. In fact, heparin, low molecular heparin itself is not a good thing. I don't know, what would Dr. Varun is be saying that? No, she was talking about, she works in a pediatric hospital. So anti-10A in a neonate, generally I say that, extremes of age, we should avoid low molecular heparin. And, anti-10A is a story which I would not want to look in these people. Do you agree with that, Dr. Varun? Yes. Okay, thank you very much.
Thank you, sir. Thank you so much.
For the next talk, I would like to invite Dr. Savitri Singh. Madam is a professor in the Department of Pathology at KGMU, Noida.
Too much time gone.
हम आपकी पीपीटी अपने उन्होंने डाला था ना ये वाला अभी तो डाला था ना फाइनल KGMU या मैं देखूँ
I'm making the products there.
और ये किधर स्लाइड कहाँ से आएगा
So, good evening, everybody. My topic today is challenges faced in pediatric coagulation testing. So, all of you know by now, having attended so many conferences,
that there are two times when it is difficult to do some presentation. One is immediately after lunch session for speaker as well as the viewers, and the other when somebody stalwart in coagulation has done 2-3 talks having 40 years experience, then some having 20, and then some 10, and people like us in a pediatric center having lesser experience to take a talk. That too on a topic itself, which is challenges, right? So the greatest challenge in diagnostics in pediatric, newborn and infant group is that remains to be answered at the end of the talk. So hemostasis, all of you know, coagulation system of premature babies, newborn and infant in the first year of life is subject to maturational dynamics that requires a different knowledge of age-related change, reference ranges. Hemostatic system profoundly influenced by age, including gestational age as well as postnatal age. Fetal and neonatal system is different from adults. Coagulation proteins, although present at 10th week of gestation, do not cross placenta. Concentration of majority of coagulation proteins as measured by functional assay vary significantly with the age. Reference ranges in preterm and term baby, infant and children are established so far with so many literature available. Yet if you have to establish at your center, it would be, Herculean task. That's not possible. So neonatal system highly complex, as we all know. Cell-based theory, including role of endothelial cells, platelet and hemostatic proteins, all know. And the PG students tomorrow again elaborate talk will be there on that. So if a neonate is presenting with bleeding symptoms, what could be the cause? If the child is sick term and preterm, then mostly we are dealing with the acquired problem. Could be thrombocytopenia, congenital infection, sepsis, DIC, and catheter-related complication. If a healthy neonate presenting with bleeding symptomatology, most likely we are dealing with a inherited bleeding disorder. So that should be in our mind before we are, thinking what all tests need to be done for. Then this is just, I thought I would be doing presentation earlier, but now I have to rush through. This is for our residents. What proportion of children have bleeding disorders? Less than 5%, 0.5, 1 to 2, 5 to 7, 10 to 12%. If you get right answer, tell to Dr. Rashmi. She will give you chocolate on my behalf. So I hope other this side people may be knowing, but for residents, they must know what is the percentage. Pardon? Oh no, go little less. That's pediatric now, so everything has to be little less. So developmental hemostasis. This term is coined by Maureen Andrew et al. In 1980. There was a landmark paper, multiple papers through this scientist, and he emphasized the need for pediatric reference range specific to their lab analyzer and reagent system. Coagulation testing is known to be sensitive to changes in individual reagent and analyzer, already emphasized by our sir also. So the gist of the article was vitamin K dependent factors that are 2, 7, 9, 10 in term infants are around 50% of the normal adult. So when you get any test for a neonate, you may see PT is usually PT, APTT may be high. So it would be just physiological, not to be, thought of that we are dealing with some coagulopathy. Factor 7 reaches adult value by 5th day. Other factors increase gradually over first 6 months of life. Factor 8 on first day of life, same as that of adult value. Von Willebrand factor increased at birth and after 6 months settles as that of adult value. Factor 5 adult value reaches, there is a slight value at birth, slight fall at day 5. Fibrinogen is normal at birth. Factor 13 is 70% at birth and at day 5 reaches adult value. Physiological variation, reduction of factor 9 in neonatal period. And up to 3 months of life of a, new child, factor 9 would be less. After that, it would be like adult value. So I'll just go a little quickly because a lot of slides are there. PT day one, this is a study from Andrew et al. 1992, where day one PT you can see is 16.4, which appears higher. Day 3 also high, then 1 month and onwards, slightly towards normal side. And APTT results, day 1 not available, again because it's not easy to get healthy term and mother to consent for the normal value to be assessed based on some study protocol. So day 3 again we did not get this Andrew et al. And rest of the values little variable. Then they found APTT done with 4 reagents. There are 2 studies, one in Monagle et al. And another one Andrew et al. Andrew et al. Canadian study and Monagle et al. Australian study. So there were differences in APTT done with 4 reagents. Day 1 increase, day 3 increase. 1 month value in Monagle was higher up to 16 years, while there was no change in APTT results in Andrew et al. In the same range. PT also was variable, and then of course INR. Fibrinogen in day 1 to day 3 was not affected, but 1 month in Monagle et al. It was low, in 5 years also low, then afterwards it was not affected. So if we see carefully, this there are decreased hemostasis, which is like component of coagulation factors, decrease in 2, 7, 9, 10, 13, and 11. And effect of this reduced factor would be decreased thrombin generation. Then another we see neonatal anticoagulation, there is increased alpha-2 microglobulin, which would be giving effect in coagulation form of increased capacity to inactivate procoagulant factor. Primary hemostasis, decreased platelet function, however, increased von Willebrand factor, large multimers, and they would be favoring enhanced primary hemostasis. Then increased hemostasis by decreasing the natural anticoagulant, that is decreased antithrombin, protein S, protein C, HC2, that would decrease capacity to inactivate procoagulant factor. Similarly, for fibrinolysis, the factors plasminogen low and plasminogen activator inhibitor higher, and that would be effect in hemostasis hypofibrinolytic state. So now come to the next, what Sir emphasizes, history, history, history. I would not deal with the left side because that already emphasized by Dr. Namrata and other speakers. I would just emphasize the fact, do you always get the history of maternal drug intake, because that will affect when the child is having thrombocytopenia when born, and we don't know why it is happening and may have some bleeding manifestation. Other is that delivery, what was the site of delivery, was it done at home or in hospital setting? So that will give you a clue whether vitamin K was supposedly given or not. Then clinical, how we get clinical history at our center, I would not lie. If we see that doctor's name is gastro, then we'll say, oh, GI ka patient hai, then we can correlate PT is coming high. Okay, get away with report and we will sign. Then another, if from CTVS, maybe some anticoagulation, APTT is coming high, PT is high, we can let the report go. Only that pediatric hemato-oncology department, which is very well established, we reinforced from day 1 to have a proper questionnaire with all the detailed fill, and then only receive the sample. But that took a lot of time and efforts on our part to get the questionnaire filled. But then the reports are equally correlatable, and they are quick to be released, because then we will not hold any report for want of history. Suspected case of HLS from holding emergency, and then okay, we will release the report, because we know patient is having fever, mild spleen, liver, and TG is high, because lipemic sample we can make out, and we will release a report. ENT, after having ruled out all the causes for bleeding, and then maybe we will think of doing VWD workup. From blood bank, we get QC. Sometimes they would thaw their sample and then put in tube and send. At times, results are very nice and we are happy we can sign it. But sometimes results are very low, especially for factor VIII. Then we need to question them whether you have, after thawing the sample, how many hours the sample was left waiting for some attendant कि वो attendant आएगा तब lab में देगा फिर मेरा lab का attendant will take his own leisure time to give it to madam कि वो some sample has come. So that blood bank QC we have to be very precise. When you get the sample, process it as early as possible, or if preferable, get the frozen tube, thaw it and do it on your own. That I will not touch upon. Tomorrow you'll be, told in detail about the bleeding assessment tool. Already Dr. Namrata has covered. So preterm infant, if there is a preterm or newborn, we may have hereditary coagulopathy, but more common is the acquired coagulopathy, for which we should do more questioning. Then next comes sample collection. Again, sir has dealt so beautifully and reinforcing how it should be done. Who should be doing collection is my very important take, because if somebody who has been posted away 5 days ज्वाइन किया नर्स और उसको कलेक्शन सेंटर पे डाल दिया, she would be doing whatever she has learned. So only the person who has learned the art and given minimum of 1 and 2 years time in doing collection for pediatric patients should be doing collection. Otherwise, newcomers should not dare to do collection and do over or underfilling of tube or doing some clots and all that. So rest you can read, because for want of time I would not. How many of us know beforehand that there is hematocrit value of the patient is this? We hardly ever know. In a pediatric setup, it is very important to know beforehand that our child is not having more than 55 or less than 25. In that case, we have to do correction in the citrate tube volume of the citrate itself, then only to correct sample. Otherwise, if we have done, we may be giving wrong result. So there is a correction formula as well as a table available in WFH guidelines also. Whosoever is doing collection, they can put it, and how much plasma to be removed, they can do that and further do collection. So this is very, very important to safeguard for the accurate results. Then there was one article, Eberyl, Diagnostic Challenges in Newborn with Coagulation Disorders, in which they said what you see in green line. They say even little under collection in the green zone is permissible for reporting. However, the red line where it is touching and covering the area, we cannot release the report. Rest I will discuss with sir how to go about that, but we know for sure if it is overfilled or underfilled, not to be accepted. Then pre-anesthetic checkup we get for any surgical patients, and then they say, Madam, bleeding time and clotting time karna hai. So clotting time is obsolete now. Instead, we can do PT, APTT. Then bleeding time, of course, when less than 3 years of child, we cannot do, because child will not allow you to make pricks, will wriggle and all, and you may not be able to do that standard technique and proper bleeding time. Only in a very specialized circumstances, clinically thought of, we would be doing bleeding time in a children. So what all tests? PT INR, APTT only, PT, APTT both, or a specific test. And it has to go in stepwise manner, not that you will write whole lot of battery and you will ask for investigation. And that's for clinician actually. Then there is a case, 7 days old neonate with umbilical stump bleed. So hemoglobin, okay, TCDC within limits, platelet count again normal, PT 16.4, APTT 36.4, both appear okay. Fibrinogen 2 again within normal limits. Diagnostic suspicion considering umbilical stump bleed in a 7 days old child. So what we will think of, that could be factor 13 deficiency. So at our center, we have only clot solubility test. Factor 13 is very expensive, and as such, this factor 13 deficiency is not that common. So we may not be able to keep the test itself. So clot solubility was positive, and then we got assay outside done. It was 1%. So we have to remember the neonatal age reference when we are interpreting our results. A rare autosomal disorder where patients cannot stabilize fibrin clot results in rebleeding. May present with bruising to umbilical cord bleeding to soft tissue hematoma. Severe phenotype has the highest rate of intracranial hemorrhage in any of the bleeding disorder. Normal PT, normal APTT and platelet count need specialized testing. So delayed wound healing, umbilical stump bleeding, large hematoma if inappropriate for trauma. There are two possibilities, either fibrinogen deficiency or factor 13 deficiency. But in our case, PT, APTT both were normal, so FBG deficiency was ruled out. 13-year-old male presented to PHO department with complaints of not able to open eye and reduced vision. Diagnosis clinically thought of orbital hematoma with proptosis, right eye with sublabial bleed. History of trauma to head and followed by vomiting. So was diagnosed in infancy as hemophilia B. Factor 9 was reported less than 1% when the child was less than 1 year. So what was the cause for that? Maybe when the child was 2 months or so, they had done factor 9, which was less, and then subsequently he was given that treatment off and on for 12 years altogether. So received factor 9 for so many days, and when history was taken by our clinician, who is astute clinician, she immediately said that it is not at all factor 9. She asked for fibrinogen, and that's how we fix the diagnosis. So these are the pictures for this hematoma and right arm orbital hematoma. This test results were PT 120 more than 120, APTT more than 120, thrombin time prolonged. It was done outside because we don't have it. Mixing studies, full correction of PT, APTT. Factor 8, 78%, factor 9, 84, 1v1 antigen 130, activity again okay, clot solubility test normal, fibrinogen was less than 10% and it was actually 7 milligram per liter. Claus method, clot weight test. So worldwide prevalence is very 1 to 2 per million in general population. From India, 25 patients have been reported, out of which 4 are from our center. So in our case, as sir emphasized, most important test in coagulation is history. Had the history been taken in other centers, right time, then the labeling of factor 9 deficiency for so many years would have been avoided. In our case, neonatal period, umbilical stump bleed would have given the clue to diagnosis then and there. In any suspicion of incorrect diagnosis in view of clinical presentation, repeat testing is mandatory to make correct diagnosis and manage the patient, appropriate therapy and saving patient's life. Which of the clotting factors have normal level in newborn relative to older children and adults? Already answer was given in the third slide if I'm not wrong. Anyway, if you want chocolate, you will text your mind, otherwise no problem. Because time is for low glucose now. A normal test yet may not have any associated bleeding. That may be platelet count, pseudothrombocytopenia, coagulation test prolonged APTT, no bleeding, factor 12 deficiency, high molecular kinagen, and lupus anticoagulant. So this is our case. Platelet was very less and lot of large this clumps EDTA-induced agglutination of the platelets were seen. Second one is platelet satellitism. That's also our case. And the third one, large platelets. Then at times your patient may not have any bleeding, yet if you see their PS for very low hemoglobin, thrombocytopenia and clinical suspicion of something else, you might see that it is having APML, and in subsequent days while managing, patient may deteriorate and may have all the abnormal results which were not there at the time of diagnosis. So it is very, very important to see PS for platelet number, morphology, as well as anything else you can catch on PS which you may not think that time. 7 months old male child with history of loose stools, 2 weeks prior history of antibiotics. 7 months child, loose stool, have antibiotics for 2 weeks, not even the stipulated time. Trivial fall at home, swelling left leg, ecchymotic patch. History of delivery at home. no history of bleeding in family, no history of umbilical stump bleed, no history of bleeding during immunization. Child is exclusively breastfed. CBC, hemoglobin was less, platelet okay, TLC okay, PT was 95 seconds, and ABTT 46.7 seconds. Diagnosis, we have heard of this thing, hemorrhagic disease of newborn, right? So it was this, and what could be the cause? Vitamin K, because delivery was at home, long, 2 weeks antibiotic history, loose stools. Vitamin K injections recommended to newborns since 1961 to prevent hemorrhagic disease of newborn. Without vitamin K, infant at risk for bleeding in first 6 months of life from limited vitamin K store and inability of gut flora to produce vitamin K. It is required for factor 2, 7, 9, 10 and protein CNS. There's gamma carboxylation in all these factors at a particular point, and that is what vitamin K is required for. So it is early, classical, and late. I would expect that you can read from your text. I have taken from the textbook itself. In India, it's not only confined to 6 months, it may be beyond that because breastfeeding is here more than the recommendation, and poor feeding, of course, and gut related diarrheal disease and all are quite common in our setup. So if we get very high values of prothrombin time and child is quite sick, we can always think of vitamin K deficiency. If you give a vitamin K shot, PT will be all right. And if injection, then maybe next day itself, otherwise within a week, it can be normal. Known case of hemophilia with a hemophilia, 1-year-old male child, mother brings 2 days old child sibling for testing for hemophilia. Hemoglobin 20, platelet okay, TLC okay, APTT 95 second. Our cutoff, our normal range is 27 to 35. Mixing studies, full correction, 32. Factor VIII assay as done, 0%. So our diagnosis is hemophilia A. So here I would like to say, because factor VIII at the birth was how much was the value. So we have to correlate our test values, what was the age specific reference value for that particular age. So this can be diagnosed. If a child is born, brother is known hemophilia, and you are doing test 0, you can label hemophilia A without any fuss. Known case of hemophilia A on replacement therapy, visited to our hemophilia treatment center. APTT sky high, inhibitor screen positive, Bethesda 13.6 B unit. Inhibitor in hemophilia A with this much unit. So whenever we get history, at times they will write last factor infusion, but they will not mention the time. Was it 1 day prior or just before when sample was sent with that? So we have made it our rule, our own rule. Whenever we get any sample for inhibitor testing, we will do preheat and then only do the testing. So that's how we want to be sure that what we have done, we don't have to repeat after getting history कि नहीं लास्ट फैक्टर मैडम उसको 2 घंटे पहले दिया था, and nurse will say no, हमने अभी उसको फैक्टर देने से पहले ही सैंपल निकाला, but they will not put it writing. I would say you just mention sample has been taken prior to factor infusion. Then we are saying we will release a report, but it will not be. So we have made it that whenever we get any request, we will always preheat and do our inhibitor testing, because then next we have to do Bethesda also, otherwise everything will be wrong. So this is one, when you know the history and you have got the paper, you have done it. What if you don't have the history of whether the child is having hemophilia A or B and sample has been sent, you have to do inhibitor assay. That happened to us. Sample was sent for inhibitor screen and requisition form was left behind, because nurse will collect sample, attendant will be asking for a form मिलेगा, then उसका 2 बजे closing time होगा, they will not wait for anybody. मैंने sample दे दिया है, अब nurse वो जो भी है, attendant will give form never came to us. Mother came for, madam is asking report and child is very sick. So my staff did factor VIII inhibitor, because we are getting that only. If I recall, 99% we are getting factor VIII inhibitor, so we proceeded with that. And to my surprise, it came factor VIII assay came less than 1%, and inhibitor BU units came 28.8 units. And we were happy. I had written report on a small slip because requisition slip was didn't come. Then I got on the slip only something written, dear doctor, we had asked for this and you have done this. Then I was taken aback, what wrong has been done? I said, but I am sure I have done the correct. They said, no, you proceed for factor 9 because the child is known factor 9 deficiency since childhood, and he's been coming here for 1.5 years. So we did factor 9, it came 0%. Inhibitor status 166.4, that was pretty high inhibitor assay. And then 2 weeks later, because they have to confirm who is right, why did it happen. And then I read about literature and we got to know if we are having factor inhibitor, which is very high titer, then against another factor also there will be inhibition and we might get inhibitor also. But then other thought was going, maybe we are dealing with something having factor 8 and factor 9 deficiency, and then we would be writing this and something miracle will happen, but it wasn't the case. 2 weeks later, factor 8 assay was again 0.7%, repeated at another lab. Then next one, factor 8 sequencing was done. Factor sequencing and intron 22 gene inversion, normal. Intron 1 inversion could not be done in that lab. Repeat sent to a referral lab. Factor 9 sequencing done, and it turned out to be pathogenic. So then that's when we understood, okay, so initially what was factor 9? Had we received the requisition slip to begin with that it is a hemophilia B patient, we go ahead with test, we could have saved so many things. Anyway, we got to know that high titer of one particular factor inhibitor can lead to inhibition of other factor, and that's how we can get. So that then we read about a few things and we got to know a little bit about inhibitors, pharmacokinetics. So we had seen without clinical information what all can happen in lab, and we faced so much then. Then we got another patient like that, APTT mixing asked, no clinical information. We did, everything was high and 50% correction. But then I was wondering what is happening. 2-3 patients coming with mixing studies, no clinical information. Then I went to see the patient. I got to know patient is perfectly fine. He has effusion lung, and then I asked any bleeding manifestation or kuch nahi. Then I asked junior resident who has ordered. कहते हमको नहीं पता. Senior resident, nobody is taking charge who has ordered the test. Then I said, would you mind sending me again one sample? They had sent sample. We got PT APT done. It was perfectly fine. So maybe the sample, they have some minor clot or clot, something they removed and they are sent to us. So that can happen when there is nobody to take the responsibility of any wrongdoing. So quiz again, congenital deficiency of which factor has the highest rate of spontaneous intracranial hemorrhage? This again I had written in my text. All the questions answers were open. Fibrinogen, factor 5, factor 7, 10 or 13. कोई बात नहीं. I also don't know many things as of now. Learn it up. Issues faced in lab. First and foremost, history. You have seen so many wrong. History was not available and we were in trouble. So sir emphasizing, and so would I. History. Underfilled tubes, overfilled tube, clotted blood sample, where you can obviously see clot is there. Or they might have removed, we would not get to know. Or at times you can open the dhakkan and you see minor clot is stick here and the results are wrong, right? Then there can be hemolyzed sample, delay in processing of sample, that onus goes to lab. We can't always say clinician galat hai ya nurse ne galat sample kiya. Processing in lab is very, very important, especially temperature of our room. Inadvertent heparin, sample from IV line, change of sample, mixing wrong caps, that can happen. Non-availability of pediatric vial, but now I have understood from sir that there are limitations to that. Sampling collection issues in neonate and pediatric patients are very, very important, and these issues we face off and on. So summarize, children are not mini adults. Hemostatic system evolves with developmental stage. Children have physiologically lower level of both procoagulation and anticoagulant protein in a balance. Abnormal lab values may be physiological, may not be always pathological. Assay reagent and analyzer variations should be considered during interpretation of lab results. All diagnostic labs should generate own pediatric reference region. ISTH SSC committee has recommended if you are not able to make your own reference ranges, at least whatever prescribed in the literature, your analyzer and what reagent you are using, that you can take it as the reference range for your own lab. So like we are using Stagos STA analyzer, so we can take from literature recent one what all described for different ages as per Stego and our region, and that will serve our purpose. Because ethical issues are we cannot collect sample and make our reference ranges. So take home message, what I hurried my talk is history, pre-analytical, analytical variables must be kept at 0, although not possible, but try. Stepwise testing, screening test followed by specific test. All the test results to be correlated in light of patient age, neonate, infant, clinical presentation, history of therapy, factor, extended half-life or any other. Methods in testing to be updated for best patient care, i.e. patient on any other medication, then a specific test has to be done. We shouldn't do our normal test and wasting reagent. Genetic testing is reserved for confirmation of diagnosis and antenatal testing. And this is our hemophilia treatment center catering for roughly more than 800 patients as of now. Hemophilia A560, B113, inhibitor positive 115, 126, RBD 18, and very rare diseases. My special thanks to Dr. Neeta Radhakrishnan, HOD Pediatric Hemato-Oncology Department, my NHM staff too, they have left, but I need to mention them. Department of Pathology, all faculty and staff, Pallavi, Monica, Mahesh, WFH and PGIC Noida, and none other than my dear sir. Without his permission, I have taken his photo and put it here. Sir, I think in one talk, I've copied yours. Hemostasis is like love. Everyone knows it, but no one understands. I wouldn't say here. I may not understand it. It's a difficult zone altogether. And I don't think it means what you think it means. At times it happens in coagulation at least. So that's what I want to say.
Thank you so much, ma'am, for wonderful talk. I think there's a shorter time, so we will move for the next session.
Yeah, that's what I hurried also. Okay, thank you.
Thank you, ma'am, for such a wonderful session. Now, I would like to ask Dr. Suresh Nair, sir, Dr. Suresh Nair, sir, to please come and felicitate Savitri Singh, ma'am.
Sir, please wait a minute. Sir, I request you to please felicitate our chairpersons also, Dr. Sanjay Mishra, sir.
Kindly facilitate our Dr. Geeta Yadav, ma'am. Dr. Nishant Verma, sir. Now we are moving for our next and the last session, session number 5. I would like to request our chairpersons, Dr. S.P. Verma, sir, Professor and Head of the Department, Clinical Hematology, King George Medical University, Lucknow, and Professor Rashmi Kushwaha ma'am, organizing secretary of the CME, kindly come and grace the dais.
So the next talk is by Dr. Priyavardhana. She is Associate Professor in Pathology and Laboratory Medicine at AIMS Rishikesh. Welcome, Dr. Priya.
And I was here. I mean the pointer.
So, ma'am, this is the pointer. Ma'am, laser pointer.
And can I use this only? So that I know what is context. This is fine, no? I use this.
So, good evening, everyone. First of all, I would like to thank Rashmi ma'am for giving me this opportunity, and I feel privileged to give a talk in front of my teacher and mentor Sukesh sir sitting here. And whatever my understanding in coagulation is all what I learned from sir and the patients and the technical staff from CMC Vellore and AIMS Rishikesh. This will be going to be a very interactive. I want the residents to take part. So my focus will be on this side. So what do you think the best lab test is? Everyone has been telling from morning, emphasizing on that. Please, what is the best lab test? From morning, people were talking about that only. I want answers from this side. History taking. History taking is going to be like very important. And so once now you have taken the history and you've identified the patient as a leader. So what next? You will go for what? Yeah, we will go for screening test. So the screening test will be CBC with peripheral smear, bleeding time, prothrombin time, ABTT, thrombin time, fibrinogen. So some labs don't do TT and fibrinogen. So this is the classical coagulation cascade as we are aware of. So this, though it has like some deficiencies, it explains the in vitro plasma-based clotting test. So PT is for what? ABTT is for what? Intrinsic pathway. What are the factors involved in intrinsic pathway? 8, 9, 11, 12. Intrinsic, please write it down in your notebook. Further cases will solve based on this. So intrinsic pathway, April will be prolonged. What are the factors involved? 8, 9, 11, 12. PT is for extrinsic pathway. Factor 7. Yes, very good. So common pathway, what are the factors involved? 2, 5, 10. Very good. So PT and DT both will be prolonged in common pathway. And TT is for fibrinogen. So with this, we will go to the patient 1. So 15-year-old male with large swelling at the back of thigh with discoloration. Symptomatic from 1 year of age, knee joint swelling and now walks with a limp, and there is a positive family history. So with this, the patient is a bleeder. The patient is having severe bleeding. So now we will go for the basic screening test. So here the bleeding time is normal, platelet is normal, PT is normal, APDT is prolonged. So APDT prolonged means which pathway? Intrinsic pathway. What are the factors? 8, 9, 11, 12. Okay. So now APDT is prolonged. What will you do next? Mixing studies. Very good, because that is my topic. So now when either PT or APDT is prolonged, we will go for mixing studies. So mixing studies, this sir has already explained. So sir has made my job like very easier because most of the things sir is told. So when there is unexplained prolongation of PT or APTT, if you do a correction test by mixing with the patient's plasma with pooled normal plasma, we can establish like what it is. And if there is a correction, it indicates a possible factor deficiency. If there is failure to correct, it is either factor inhibitors or lupus. And mixing or correction studies are done when either PT or APT is prolonged. However, we do is take equal volumes of patient plasma and pooled normal plasma, mix it and do either PT or APT whichever is prolonged. So the various plasma reagents used for mixing studies is normal plasma, H serum, adsorbed plasma, and selective plasmas, which are like factor 8 and 9 deficient plasmas. So this, Adsorb plasma is made by using barium sulfate. It absorbs 2, 7, 9, 10 vitamin K deficient clotting factors. This also remember 2, 7, 9, 10 is removed in adsorb plasma. So adsorb plasma has 1, 5, 8 and 11, 12 and 13. Please note this down. Adsorb plasma has 2, 7, 9, 10 is removed. It has 1, 5, 8. Okay. And tomorrow in the workshop will be discussed in detail how it will be prepared. Now I'll just tell you the theoretical aspects. An age serum, you let the serum, without any anticurrent, you collect the sample, leave it for 2 days, 48 hours, and usually we take it from biochemistry lab or from like blood bank. And age serum will have 7, 9, 10, 11, 12, 13. So adsorb plasma will have 1, 5, 8, age serum will have 7, 9, 10, both will have 11, 12, 13. So now you will help me in interpreting these mixing studies. Ability is prolonged, it means intrinsic pathway. 9, 10, 11, 12. Okay, clear. So normal plasma it is getting corrected. Adsorb plasma is getting corrected. Adsorb plasma has what factors? 1, 5, 8. So what is this? Getting corrected with adsorb plasma is not with age serum. Factor 8, very good. And getting corrected with age serum and not with adsorb plasma? 8, 9, very good. So now it is getting corrected with all three, which is present in both. 11 and 12 is present in both. So it is getting corrected with all three, 11 and 12, and no correction, it is inhibitors. Now if you are going to use a factor 8 and 9 deficient plasma, it is getting corrected with factor 9 deficient plasma. So what it is? So factor 9 deficient plasma will have what factor? 9 is deficient. What will it have? Okay. Here ability is abnormal. So it is getting corrected with factor 9 deficient plasma, it is factor 8, and which is getting corrected with factor 8 deficient plasma is factor 9. So now this here APTT, PT both are prolonged, so it is common pathway. So common pathway will have 2, 5, 10, very good. So both age serum and adsorb plasma is not showing correction. So which factor is not present in both age serum and adsorb plasma? It is I have written here, please check and tell fast. 2, very good. So this is very important. Age serum and adsorb plasma will not have factor 2. It will get corrected only with normal plasma and both PT and PT will be prolonged. And this is factor 5. And here only PT is abnormal, so it is extrinsic pathway factor 7. And here it is getting corrected with normal plasma and age serum. So what it is? And no correction with adsorb plasma. No, factor 5 will get corrected with adsorb plasma. What is present here? 10, very good. So this is all the interpretation. So based on this, we'll see some cases. So this patient is a bleeder. We have done the basic staining test. Bleeding time is normal, platelets normal, PT normal, apidity prolonged. Mixing studies with PNP is getting corrected. Now apidity is getting normal with adsorb plasma but prolonged with age serum. So what it is? Everyone is clear? 8. It is getting corrected with adsorb plasma but not with age serum, factor 8 deficiency. And this case, bleeding time is not done because the platelets are low and both PT and APT is prolonged. So what it is? Both PT and APT prolonged, common pathway. Which are the factors in common pathway? Very good. So mixing it is getting corrected with both. And now it is getting corrected with age serum but not with adsorb plasma. This APT is prolonged. Mixing is getting corrected with normal plasma. So if APT is prolonged, it means intrinsic. Factors in intrinsic 8, 9, 11, 12. Very good. It has become like a rhyme. So the more number of times you tell, you will remember it. So what is this? Both are getting corrected with both age serum and adsorb plasma. Which factors are present in both? I have written the factors here. 11 and 12. Very good. And one more. Both APDT and PT is prolonged. Getting corrected. Both APDT PT prolonged is what? Common pathway. Factors in common pathway? 2, 5, 10. Very good. So now it is getting corrected with normal plasma but not with adsorbed and age serum. So what it is? No. It is not getting corrected with both. No. I made it very specifically 2. Very good. Because it is 2 is not present in both. So now we have identified the factor deficiency. So what next we will do? We have identified there is some factor deficiency. Then what next we will do? We have to do the factor assays, whichever factor was deficient based on the mixing studies. So this is the same patient, the first patient which I showed. Only APDT is prolonged. Mixing status is getting corrected with pooled normal plasma, and APDT is getting corrected with adsorbed plasma, but not with H serum. So what it is? A. Very good. So this patient is a case of hemophilia A. So now we have to do the factor assay. So why we have to do the factor assay? What is the need for factor assay? To establish the severe diagnosis of the factor deficiency, to assess the severity. So this is the mild is 6 to 40%, moderate is 1 to 5%, severe is less than 1%. To monitor the replacement therapy and detect carrier states in affected families. So factor assays can be 1 stage, 2 stage or chromogenic. And this sir has already told the definition of 1 stage assay. And this is how we will plot it on a semi-log paper. This for the same patient I am showing the things, and this will be again tomorrow discussed in the workshop in detail. And this is the calibration values and the test values, and it is being plotted, and we obtain the values, and this is the final value we are getting after multiplying by calibrator. It is 24.5%. So what this is? Mild, moderate or severe? Mild was 6 to 50%. So what is this? So mild hemophilia A with the factor 8 levels of 24.5%. So this will be discussed tomorrow in the workshop. Whoever is attending the workshop, they will know how to plot these graphs. And another thing is like factor 8 recovery, which the clinicians will send the samples for. So this, the literature tells the factor 8 levels are lower by 1 stage factor assay by at least 20 to 30% compared to chromogenic or 2 stage factor assays. I will just tell the principles of this. So 2 stage factor assays is done in 2 stages. First, the concentration of factor 8 is made the rate limiting step in a reaction generates factor 10E, and the second stage determines the amount of factor 10E being produced. And these are the various reagents required for 2 stage factor assays. So adsorb patient plasma, activated serum with other factors, formation of factor A, then you subsample to normal plasma and derive from the clotting time of the second stage. And chromogenic assay, it is measured from the chromogenic substrate. And few words on the extended half-life factor 8, and this was already discussed. So how lab monitoring becomes important from the lab pathologist point of view. So these are the various like EHL products of factor 8 and factor 9, and there are like various literature reviews which tells that with 1 stage factor assays, if these are the APDT based agents used, and they have told that they don't give a correct value. And this is another paper where they have mentioned various silica based tests and allergic acid based APDT reagents, and they have mentioned with different EHLs what happens. There is usually underestimation. And this is another reference where they have mentioned like the chromogenic assay most accurately reflects the clinical hemostatic potential of Astella and is preferred. And in 1 stage assays, it is reduced by approximately 45%. And conversion factor is used. As sir has mentioned, like the 1 stage assays can be modified and it can be used for its measurement. And apart from this EHLs, recently there are like other novel medications like MSCC-BAB, and for MSCC-BAB, modified factor 1 stage assay is sensitive to MSCC-MAB, and factor 8 chromogenic activity assay bovine is insensitive, and chromogenic Bethesda assay is also not affected by MSCC-MAB. I think the next topic is on non-factor therapies of hemophilia. So it is very important that there is a proper discussion happening between the pathologist and the clinical hematologist, like what factor is being given and what is the APDT, what activator is used in the APDT before interpreting the values. And now the factor levels are identified, then what next? The patient is a known case of hemophilia on like multiple factor concentrates, and what next you will do? We will go for inhibitor screen, and the principle of inhibitor screen is the presence of an inhibitor can be determined by a simple mixing experiment using the test plasma and normal pool plasma, and some factor 8 antibodies which are slow reaction breaks may be missed if insufficient time is allowed for the incubation step. And like how we do is we take like 0.5 ml of pool normal plasma and test plasma and mix both in another tube and incubate at 37 degree. And at the end of 1 hour, we take equal volume from this and take 0.1 ml from this fresh mix and from this incubated mix and do APTT, and at the end of 2 hours also do APTT in both fresh mix and incubated mix. And if the difference between fresh and incubated mix is more than 8 seconds, it is taken as positive presence of inhibitors. Less than 8 is taken as absence of inhibitors. This is around 8 to 10 seconds. The lab must establish its own range. And this case, air acidity is prolonged and it is getting corrected with PNP. This is the fresh mix value, incubated mix. So what is the difference? 10 seconds, so there is presence of inhibitors. And the interpretation of the inhibitor screen based on APTT is, so this is normal plasma, patient plasma, 50-50 mixture, incubated for 2 hours, and this is without any incubation. And if it is prolonged with, if it is getting corrected with both, it is only deficiency. If it is prolonged with all three, it is immediately acting inhibitors. If it is prolonged with after incubation but getting corrected with fresh mix, it is time dependent inhibitors. Factor 8 are usually time dependent inhibitors. Their late acting inhibitors pick mostly on incubation. If you see this example, the incubated mix is much prolonged, but on mixing it is getting corrected, the fresh mix. So now inhibitor screen is positive. After that, what we will do? If the inhibitor screen is positive, then we will go for inhibitor assay. So I have few cases fully worked up. I think I have 10 minutes left. I will go through the cases. I want active participation from you people. Okay. So this is a 70-year-old male presented with large ecchymotic patches, blackish discoloration on right arm and thigh, 4 such episodes in the last 4 months. The patient is having significant bleeding. Okay, fine. So nearby hospital reported a prolonged APTT, no previous history of any active bleeding manifestations and no history of blood transfusions. Hemoglobin, there is anemia is there, total count is normal, platelet count normal, normal platelet morphology, bleeding time is normal. PFA 200 is again normal, clot attraction is good. And next we will go for PT, APTT, TT. So PT is normal, TT is normal, APTT is prolonged. APTT is 80.5 seconds. When APTT is prolonged, what we will do next? Mixing studies. So we did the mixing studies. So if you see here, it is not getting corrected with any, with normal plasma, adsorb plasma and H serum. So what it is, if it is not getting corrected? Inhibitors. So what do you think, what we have to go next for this patient? First we have to find out what is the deficiency in this patient. What is causing, we have to identify what factor deficiency or what is causing the inhibitors. So what we have seen is factor 8 level is less than 1%, others are normal, fibrinogen breakoff. So what is this patient? So factor 8 severe hemophilia with inhibitors. So inhibitor screen is positive and Bethesda is very high, 1800. So what do you think with this? Hemophilia A with inhibitors? But the patient is 76 years old. Anything else? So to summarize the findings, the patient is having like everything normal. There is prolonged APTT not correcting with control plasma, adsorb plasma, H serum, and markedly reduced levels of factor 8. So it is severe hemophilia A with high titer of inhibitors. So this is a case of acquired hemophilia A, and acquired hemophilia A is an autoimmune condition with sudden production of autoantibody inhibitors in an individual without any personal or family history of bleeding. See, whatever we try to do, even rare cases, all these things, finally the history helps so much. And 50 cases are idiopathic. The patient can have mucocutaneous sites or soft tissues, recurrent GI. Ecchymosis is the most common presentation. In hemophilia, what happens is the patient has joint bleeds. Like the patient have like presentations of a secondary hemostatic defect, but here the presentation is more of a primary hemostatic defect. Because bleeding into the joints is very rare and bleeding can occur spontaneously or can be precipitated. Diagnosis, lab tests including coagulation mixing studies, and management is treatment of the underlying illness. So the key points from case number 1 is elderly with bleeding complaints, no history of family history of bleeding, do screening coagulation tests, especially PT and APTT. And case 2, it is I have only 3 cases. It is a 2-year-old child with umbilical stump bleeding on day 7, red blood cell transfusion given, ecchymotic patches, subcutaneous hematomas, spontaneously and after trauma, resolved spontaneously, non-consensus marriage, elder sister, similar bleeding complaints. This case was already shown before, similar case. So from the case, 2-year-old child with umbilical stump bleeding which requires transfusion. Very good. So see how history is like very important in cases. So everything is normal, and here PT, every TT is normal. So platelet count is normal, all the basic staining test is normal. So here the history is like very important because the patient is a severe bleeder, but PT, bleeding count, everything is normal. And 7, 9, 11 is normal. Factor 13, activity 6.2, antigen is 0. So mildly reduced levels of factor 13 activity with undetectable fibrinogen. It is mild factor 13 deficiency. So case 3, it is a 16-year-old boy was referred for complete coagulation workup due to prolonged bleeding following trauma. At 12 years of age, he had prolonged bleeding at trauma site after a fall, which required hospitalization, transfusion with red cells and plasma. There is a past history of prolonged bleeding following surgery at 2 years of age. No other bleeding history or drug history. Born of second degree consanguineous marriage, and maternal cousin also present with similar complaints. So with this, what do you think? The patient is a bleeder. The patient is having bleeding symptoms. Patient is a bleeder. So hemoglobin is 12.5. Total count, platelet count is normal. Bleeding time is normal. PFA is normal. Clot fraction is good. And here, what is abnormal in this? Ability is prolonged. So ability is prolonged. What does it mean? Intrinsic pathway. Very good. What are the factors in intrinsic pathway? 8, 9, 11, 12. Very good. And so now ability is prolonged. So we'll go for mixing studies. So mixing studies. Interpret this mixing studies. What is the interpretation? It is getting corrected with control plasma and adsorb plasma, but not with 8 serum. So what it is? Anyone? It is not getting corrected with 8 serum. What is absent in 8 serum? Factor? 8. So now factor 8 assay is 6%, others are normal, and this factor 8 assay is 6% means it is mild hemophilia A. This is based on the one stage clotting assay, but the patient is having severe bleeding symptoms. So the factor 8C was done with chromogenic assay, which is less than 1%. And so if we summarize these findings, the patient is having prolonged APTT correcting with control plasma, adsorb plasma, not with 8 serum. In one stage, the patient is labeled as mild hemophilia A, and in chromogenic, the patient is severe hemophilia A. What is his diagnosis? So what will you give us? Either you give it as mild or severe. So this condition is known as discrepant hemophilia A. So like DHA denotes the discrepancy between factor 8 activity measured by different assay methodologies in patients with non-severe hemophilia A. It's not only a lab phenomenon, but it can also affect the clinical management. In a patient with suspected bleeding disorder with normal routine coagulation test, chromogenic substance assay is warranted to rule out DHA. And this is in this study article they have done 3 cases, and all these 3 cases the patients present with severe bleeding phenotype. But if you see the difference between on stage assay and clotting assay, it is like almost half. The one stage assay it is like almost the on stage assay almost double the value subtended chromogenic substrate assay in all the 3 patients. And these are the various articles that reported this discrepant hemophilia A. And if you see here, the ratio between one stage assay and chromogenic substrate is more than almost 1.5 to 2. And these are the various articles. If you see, the first article is reported in 1988. Until now, there are articles reporting on this discrepant hemophilia A. And also there is something known as inverse discrepant hemophilia A. What happens here is, usually we see chromogenic will give a lesser value compared to the one stage assay. But here, the one stage assay gives a lesser value compared to the chromogenic assay. It is written because of like some factor 8 mutations. So the learning point from this case is a good history is very important because the patient is having severe bleeding symptoms, but it is like mild hemophilia A. And without any symptoms, an abnormal coagulation test has no value. And with a good history, even a basic test of hemostasis will be helpful in the diagnosis. So the key point from the entire discussion from these 3 cases is, what is that? I want to sum up is the best lab test is history taking. With history, you can come to almost diagnosis with the history if you take the history properly. So it is always advisable that you don't rely on the history provided by the clinicians. You take the history, you ask the patient to come to the lab and take the history yourself. So these are my references, and special thanks to Rashmi ma'am. And this is the place from where I have come from. This is Jibma, AIMS Delhi, CNC Vellore. And this was taken during convocation with Sukesh sir. And this is the place where I am. And I thank everyone, and especially patients and the technical staff from whom there is a lot of knowledge and understanding gained on coagulation. Thank you so much. Any questions, I'll take it up.
Thank you, Dr. Priya. That was a very lovely and simplified way of mixing studies that you have told. And I can make out the AIMS Rishikesh is located at a very lovely place.
Yeah, it overlooks the Ganges and mountains.
So, residents, if you have any query, you can ask. If no questions, we can proceed ahead for the next talk.
So now we move to the last talk of the day, and I would like to invite Colonel Dr. Kundan Mishra, his professor and head clinical hematology and DMT medical division command hospital. And his case area of interest is immune thrombocytopenia, and he has a lot of awards and honors to his credit, and almost around 150 publications in various national and international journals. Dr. Kundan,
So
please.
send me on Gmail. I have opened my Gmail account. So on Gmail, you can send.
Yes. Good evening, everybody. Till the time this slide is being uploaded, I'll just begin because we are already almost 2 hours late. So I'm a physician. And physicians think that they are the best. The reason being that when there is a problem which is not being solved, then it comes to the physician. Surgeon will operate if there is a big thing, and if it cannot be operated, it will be given over to physicians. Likewise for anybody. But there are some changes which have come in last few decades. Like I'll say that when we are doing MBBS, I could also do BT-CT, and it was easy for me to do it. I could learn it easy. But by the time I did my DM, doing even PT was a big task. To be very frank, it was in my DM exam, I had to perform PT, and how I performed, I don't want to share that with all of you. So things and today for last few hours, I have been listening and observing things, and I noticed that things have evolved quite a lot in hematopathology or hematology, and I think some of them are beyond my head only. But things have normalized, things have simplified for physicians quite a lot. I'll tell you. You give, for example, for hemophilia, what I'm going to talk about. To diagnose, ma'am was just telling so many examples. You have to take history. As a pathologist, you will take history, you will do this test, that test, everything you will diagnose, and then you will give it to me. Once you give it to me, it's very easy for me to treat that patient. You would have taken it maybe a few days, many hours to diagnose it. But for me to start the treatment, it takes only a few minutes. I'll not a second, but only a few minutes. On top of that, things have changed quite a lot. Earlier, treating a hemophilia was not that very easy. You had to arrange the factors and all. It was very costly and all. Anyway, cost factor I'll not take into consideration today, because it is true that money doesn't buy you everything. Money doesn't get you everything. But this is also a fact that बिना पैसे के बहुत कुछ मिलता भी नहीं है life में. So forget about the money part. Factors are available, but you see, when factors started getting available, then people had complaints. Small babies, you cannot find the veins. How to give the factors? It was a big issue. Then you have to take injection every day, then it can that you can take factor every alternate day. Then you can take once in a week kind of things. But still getting lifelong injections once in a week and all for treatment of hemophilia was very difficult. That to finding veins even in a slightly grown up kid, it was very difficult. But now things have simplified for me. There is no need to look for any kind of veins. You just give it subcutaneously. Then came the latest thing is that you don't have to be dependent on anybody else. You have those pains like insulin. Just give it, take it, keep your hemophilia, that factor pen inside your pocket wherever you are going. Just take it in your abdomen wherever you feel like. And that too, maybe there are injections which can be given once in a month also. So things have simplified quite a lot. Today, if I have to teach, I don't wonder why the MD medicine is not allowed DM hematopathology, while MD pathology is easily getting absorbed into DM clinical hematology, and they're doing very well. Most of them are doing very well. I think that medicine has got simplified in last few years. At least hemophilia is testimonial for that. So what I am going to talk today is role of non-factor therapies in management of hemophilia. So coming back to the topic actually. So hemophilia, you all know more than me what hemophilia is exactly. I'll not take much of time on that. And when you talk about hemophilia, the issue is that you have to replace the factor. You have to replace the factor preferably before patient starts bleeding. And if patient has bled, then definitely you have to give factor. There is absolutely no doubt. And whenever you are in doubt, again you give factor and treat the patient. That has been the ruling in hemophilia. But as I said, last couple of minutes, that issue has been those veins, the recurrent injections and all. To sort it out, we have got now novel therapies and the two things where this novel therapies are targeting. One is the Staphy thing, this tissue factor the pathway inhibitors, and the other one is this on prothrombin. So at least on antithrombin. So at least these two targets are being utilized in the management of hemophilia very well. And how it is coming, I will talk about that. So few factors which have come into the action in hemophilia care. One is concizumab. It is now, shortly we are going to use it. I have not used it till date, but I am sure that in next coming few months only we will be able to use concizumab. And it is a humanized monoclonal antibodies. It is approved in many countries, Canada, Switzerland, whole Europe, US and all. Then one is this mastacimab, which is also under development right now, approved by FDA. We may not get it shortly with us at least. Then a few under development like MIM8. Then we have this fitusiran, which is antithrombin basically. But I concentrate mainly on concizumab, how it is going to change the way we look at hemophilia as a physician, how the life will be much more easier once we get the concizumab thing. So, concizumab, humanized monoclonal IgG4 antibodies. So, it is administered subcutaneously. So, the biggest problem, if any one of you is treating hemophilia boy, those young infants to neonates, then I'll say that toddlers, even grown-up kids, adults and all, the biggest issue is getting getting an IV access. You have a specialized those one or nurse in every hospital. When you are not getting IV, then you will be looking for that lady who will be able to find out the veins. So now we have subcutaneous preparation. So that solves one issue. Apart from money, what we are talking, I discarded right in the beginning. The other issue which is being killed is finding a vein. You can just give it subcutaneously, problem is sorted out. Now further to it, even for subcutaneously, at times you are dependent upon others. Somebody will give and come and give you the injections. But now it will come in pen. It's something like insulin that it is in the pen. You decide how much you have to take. You have to take, usually the loading dose is 1 mg and then 1 mg per kg, and the maintenance dose is 0.2 mg per kg. So you just calculate by your weight how much is the dose required. You just set it in the pen, put it, give it to yourself either in your abdomen or on your thigh easily. Most of the time painless, so no issue. You carry the pen with you. Yes, here in contrary to few other factors, the issue here is that you have to give injection daily. So that may be a little bit hindrance, but if it is painless and self-administered, perhaps that also solves the problem. So there has been various phases of development of this product. Explorer 1, 2, 3, 4, up to I think Explorer 10 have been there. Various phase 1, 2, and 3 trials have been taken. We'll concentrate today on Explorer 7, the phase 3 trials. So design was phase 3A multi-center open label trial, and the objective was to evaluate the efficacy and safety of daily concizumab prophylaxis versus no prophylaxis in a known case of hemophilia A. So 52 patients, all aged more than 12 years, hemophilia A and or B. So here the beauty is that you don't have to even diagnose that whether you are treating with hemophilia A or B, because there are lots of difference between hemophilia A and B. I remember when our bosses used to say that if you try, if inhibitors develop and you're not aware of that, and you give factor 9 to a patient from hemophilia B, the patient will develop, will get into the anaphylaxis and all, and will land up in problems and all. So here there is no problem whether inhibitor, no inhibitors, whether hemophilia A or B. You just be ready with your pen and things are sorted out. So age group, there were two groups. One was on demand treatment for more than 24 weeks, and the other group was on concizumab prophylaxis for equal to more than 32 weeks. And there were additional patients from the previous studies and all. They were also taken into group 3 and 4. The primary endpoint was to comparison of treated spontaneous and traumatic bleeding episode, means what usually we call annual bleeding rate. That was what was the primary endpoint. We had to look for whether ABR decreases or not with concizumab prophylaxis. So we can see here well-designed study where there are various arms. 1 and 2 is basically what new patients who have been taken into the study, and 3 or 4 are the carry-forward patients from the various previous. So the patient received 1 mg per kg of concizumab loading dose followed by initial 0.2 mg per kg daily dose, and there was an adjustment which depending upon the concentration of concizumab which was being measured. If it was less than 200, we could increase it to up to 0.25 milligram per kg, and if it was more than 4000 nanogram per ml, decrease it to 0.15 mg per kg. And this is how it continued. And if you look at that, the primary endpoint, the annualized bleeding rate, we can see here there was a vast difference, which 1.7 in concizumab in comparison to 11.8 in patients who were not receiving any prophylaxis. So definitely concizumab is effective, absolutely no doubt about that. If you give it, the bleeding rate will go down substantially in the patient. If you are talking about the various ABR and the various joint bleeds or target joints bleeds or untreated response and all, we can see over here that overall the p-value is significant over here in the two groups, group 1 and group 2. And the other things also, spontaneous bleeding episodes or joint bleeding episodes and all, everything is lesser in concizumab prophylaxis, which is expected. That is how the ABR was lesser. Looking at the safety profile and all, overall there is no major safety concern. If you look at the concizumab thing, the serious events were hardly 0.3% per year of exposure. There were few patients who were having hypersensitivity reaction in group 1 or group 4, but the numbers were very negligible, 1 or 2 only. Arthralgia kind of things were seen in a few patients, otherwise no major concern, no major grade 3 or grade 4 kinds of adverse effects. If you look at this forest graph, you can see that no matter what parameter you take, bodily pain, physical functioning, this is SF33, usually we use for measuring the health-related quality of life for most of the diseases in hematology, whether you are talking about benign or even sometimes malignant disorders and all. SF36 is a standard of care for measuring the health-related quality of life in hematology. So that is what they have used over here. And all the parameters like general health, vitality, social functioning, emotional health, mental health, physical health component, and other things. Every parameters, the quality of life favored use of concizumab prophylaxis in the patient. This is another same TAFI that tissue factor pathway inhibitor, the mastacimab. This is not going to be available sooner to us, though it is already in the market at a few places. And here, if you talk about the basis study, so here it was again an open label, multi-center pivotal phase 3 study kind of things. So male aged more than 12, male less than 75, where having severe hemophilia was where A or B were included in this study. The primary endpoint here was again ABR. Means most of the hemophilia, usually the endpoint we keep, like in malignancy, we keep event-free survival. In hemophilia, ABR is the one which is endpoint of most of the patients. So we can see over here that this study, this basis study is right now ongoing only, and let us see, we will discuss maybe in the time to come how the result was. Then is a fluticasone, that antithrombin inhibitor. So it is a chemically synthesized this single interference RNA molecule which specifically inhibits the antithrombin, so increases the thrombin production, and it can also be used in hemophilia A or hemophilia B and few other rare bleeding disorders as well. And here again the beauty is not just subcutaneous, but it is required to be given once in a month. So once a month, even the frequency is very less. So this study is going on. The main primary endpoint over here was that annualized, that again ABR and the intention to treat analysis set. So we can see over here that the ABR in all these patients who received this fitusiran was hardly not just statistically significant, but you can see 87% reduction, 90% reduction, 92% reduction, and again 90% reduction kind of thing. So quite effective as far as treating the bleeding episodes are concerned. So this is all about the studies. I'll just overlook it, and you can see that on-demand fitusiran can be used in these patients. If you look at the primary outcome of bypassing agent or on-demand groups and all, and in the fitusiran prophylaxis, the ABR was hardly 1.7 in comparison to on-demand group, which was 18.1. So p-value is significant, of course. So if you look at the health score also, it was much better in the patients who received fitusiran. If you look at the adverse events and all, not much, though there were a few patients had this AST, ALT, which was increased. Infections and all were higher. We'll have to look into the exact cause, how it has happened, but no major concern as such, as far as the adverse events are concerned, and no fatal also. One more drug, I'll just like to tell that this is factor 8 mimetic called MIM8. The study is going on, and again, this is also supposed to be a better drug, which will, in the time to come, it will be available for us to use. But right now, it is under development only, so I'll not get into detail. This is the Frontier 2 study design, which is being done for, sorry. So, which is being done for checking of the effectivity of factor 8 mimetic. So, the end point over here, if you can see, the almost from 15.75 ABR, it has come down to 0.45. So this is also very effective as far as the clinical data concerned right now. It is not available in the market right now anywhere for that matter. So in the time to come, maybe MIM8 will also be one of the futuristic drug for us, and we'll also have the option to use it. So going ahead, I think I'll just skip it for the positive time. So as far as safety concern is safety data for MIM8 is concerned, there is hardly any issues with that. Despite the exposure time of almost 8 to 9 years in the individuals, there is no as such fatal, I'll say, adverse events in these patients. And there was low rate of, or there is no evidence of any neutralizing anti-MIM8 antibody which was observed during this observation period. So the landscape of hemophilia therapy is rapidly evolving, particularly with novel treatments, basically because of this huge availability of subcutaneous drugs and the lesser frequency of requirement of these drugs to be given. The anti-TFPI agents like concizumab is already available in the market, and mestasemib is also likely to come. The RNA interference therapies like fitusiran is also going to be there, which will be used monthly, and that will obviously change the landscape of hemophilia. And in the coming time, we'll have MIM8 also, as I just showed. And the quality of life is greatly improved because of this lesser frequency and the subcutaneous route of these drugs. So the future for hemophilia A will be much better for the patients, and for physician, it will be much easier to treat this otherwise very difficult to treat disease. One last slide about the novel delivery system, particularly the pen system, which is coming up. So there are a few studies which, since this pen thing came for insulin, for comparison, we can take the insulin thing. Since this pen system of insulin has come, you might have seen that people who are having type 1 or type 2 diabetes and are insulin dependent, they keep their insulin in their pocket when they go to party or they go outside anywhere, they're traveling and all, and they take their injection themselves whenever it is required or whenever it is indicated. So pen is definitely going to make a change. There is no great science in that. It was not available till now, but once it is available, it's the first one, concizumab, which will come to India shortly, which will be available to us shortly. We get it, and it will definitely make lots of changes and lots of benefit to the patient. So if you look over here, you can see that it's easy to train and inject and preferred by the patients anytime. There's no doubt. 90% of people with hemophilia on subcutaneous injections with vial and syringes found that learning to use the pen injectors was easier or much easier. You don't have to load it. You don't have to do anything, any post injection care and all, and it is always available with you. So obviously, it is much easier. So that's it. Thank you very much. This was all about treatment of hemophilia from my side with neurotherapy.
Thank you, Mr. Kanya. Any questions? Thank you.
Too late. Thank you. Thank you.
Thank you.
Thank you, sir, so much. Now I request Professor S.P. Verma, sir, to please felicitate Dr. Priya, ma'am.
Sir, kindly felicitate Dr. Kundan Mishra, sir.
I would request Professor Rashmi Kushwaha, ma'am, to felicitate Professor S.P. Verma, sir. And I would request Professor Rashmi Kushwaha ma'am to say a vote of thanks.
Thanks to all of you for a patient listening and